We have a 4-year-old boy here who presented to us in our OPD with parents having a concern about no speech development for the past 6 months. His perinatal history was insignificant apart from his parents having a consanguineous marriage. In our audiological evaluations, the findings were BERA being moderate, severe to severe on the right side and on the left side being severe, and bilateral OAEs absent. Further radiological investigations such as MRI and CT scan of temporal bone were normal study. Hearing aids were given for both ears for a duration of 1 year, and speech therapy was also started, which gave no response. And here we are going to witness left ear cochlear implant surgery today. Thank you.
Good morning, all.
Good morning, ma'am.
Rohan, good morning.
Good morning,
Is
ma'am.
everything transmission is okay?
Yes, it is fine. So, can we start with the radiology?
Yeah, sir is coming. We'll start with the radiology. Maybe if you can start with some basics about CI. Dr. Rohan himself is a wonderful CI surgeon from Jammu, and he does regularly quite good number of CI. Since sir is coming, Rohan, please take over and discuss some basics.
Okay, ma'am. Actually, so today what we'll be witnessing is the Varia technique of CI surgery. So there are two basic techniques. One is the posterior tympanotomy, in which we drill the mastoid, we clear the mastoid air cells, go deep and identify the facial nerve, and go in between the chorda and the facial nerve to identify the round window niche. And as soon as we do that, we drill it out or remove the round window and insert the electrode. But what sir would be demonstrating is a different technique that is called the Varia technique, in which mastoid needs no drilling. They just create a small suprameatal well and a small tunnel through the posterior canal wall, so which goes parallel to the IS joint. And with the help of the tunnel, they get an access into the middle ear. And they remove the tympanomeatal flap and identify the round window, which gives a clear head-on view, and the electrode insertion becomes easy. So everybody has his or her own technique. So this is what we are going to be demonstrated by Dr. J.M. Hunt, sir. Sir, this doing tracheostomy, people do it with round window or extended round window. Sir prefers tracheostomy in every case. Yes, people are, but Dr. Hans is in favor of tracheostomy. He feels that it is more direct. He feels that it is direct, and he says that you need to drill the outer lip so as to get an access to the round window. So once you are drilling, doing a tracheostomy or drilling around the round window, it means the same. But the people who do round window insertion or who do extended, they are in support saying that we don't drill inside the inner ear, so we avoid giving damage to any residual area. The bone that's going in, the drill going in, drill bit going in, giving vibrations.
It is very important. Unlike the other ENT surgeries, definitely we maintain sterility there as well, but here it is, we are much more careful, and sir really does wash the hand for 3 times. First time he does from the fingertip to elbow, and then he will do again from here to here, and last he will do up to the wrist. And he was doing that now, and he is into gown now. We are using all disposable gowns, drapes, etc. And we try to minimize the people in the OT who are absolutely necessary, the technician, the anesthesia team, the surgeon, assistant, and scrub nurse. We should not allow too many people. These all are important to prevent future infection in the implant site. Every single step is important.
Marcus, okay, this is okay. This is okay.
For the surgery, CI surgery should be done in the morning hour when the OT has not been utilized. Sir is ready. Sir, welcome and thank you for coming and demonstrating the surgery. It's a pleasure to see you always.
Good morning, everybody. I hope there is a little rush there. Too early in the morning for after a gala dinner with songs and drinks. So the most important thing is, as Dr. Sampurna told you, we have to ENT, cochlear implants are the only, maybe cochlear implants and stapes are the only surgery where we really need to scrub well. The rest we do, but most of us who do the basic ENT surgeries, we remember ENT was never that important as far as scrubbing was concerned, because we are dealing with the dirtiest part of the body, which is the nose and the mouth. But here you have to be, even I wash my specs before I scrub. So that's very important, because your specs may touch the microscope and then your hands may touch that. So you have to be that kind of serious in the whole thing. Now, the most important step before we start the surgeries is the CT. We get an MRI and CT both, but MRI is not needed in the surgical part. The CT is primarily for the surgical steps, what we are doing. Now, there are three things to it. One is we have to know whether the facial recess is well formed or not, and that is good for both the posterior tympanotomy and the Varia technique. So in both the cases, and if there is no tympanic plate, as I told you yesterday, that the facial recess is formed by the union of the tympanic plate to the mastoid bone. The facial nerve is a part of the petromastoid bone, embryologically. So it will never be in the facial recess. So if we have a good facial recess, both posterior tympanotomy and the Varia, this is the area what we address. And if there is no tympanic plate, that means there is atresia of the canal. Actually, you can't do a cochlear implant. So what we see is, now look at this one. If you can zoom in here, that is the nerve, that is the facial nerve, that is the pyramid, that is the annulus. So that we have a beautiful facial recess here, very big facial recess. So if it is magnified, you can see it properly. Now, that is the lateral semicircular canal. What we see in cochlear implant is also two things. We want to see the cochlear aqueduct and the vestibular aqueduct. Now, the cochlear aqueduct, when you see the basal turn, you will see the cochlear aqueduct going here. Now, that is what the cochlear aqueduct is, but it is completely obliterated here. On the other side also, you can see a little marking of that cochlear aqueduct, but it is not patent. So now you are sure that you will not encounter a CSF gusher in this. The second is, when you see the vestibular area, the signet ring, then you will find here the endolymphatic sac. That's the endolymphatic sac. So, but it is not a large vestibular aqueduct syndrome. So that means if there is a large vestibular aqueduct syndrome, it is one of the reasons for the child to have a progressive hearing loss. The child is born normally, but then gradually as he jumps and does vigorous exercises, the endolymph gushes back into the the endolymphatic in the inner ear and causes hearing loss and vertigo. These children would come with gradually increasing hearing loss and vertigo. So that large vestibular, so there is no large vestibular aqueduct also in this case. So we are dealing with a very normal cochlea, and that is the Varia technique. And I think those people who could not do it properly are the ones who probably did not do a temporal bone dissection. You know, the best way to learn Varia is that you have a temporal bone dissection, create many tunnels, wrong and right, you know, both, and then do a cortical mastectomy and then see where your tunnels went. That's the best way to learn. So I remember I used to do 2-3 temporal bones, create tunnels, and then do a cortical mastectomy to see where my tunnels have gone vis-a-vis the facial nerve. So once you have this in mind, you can go actually with your eyes closed and nothing would happen. So that is the beauty of this technique. The most important is that when you have the panoramic view of the promontory, and I'll tell you how it happens. And another thing which I want to say today is that you will have to work with both your hands. You can't be working with one hand. If you're doing a Varia, on the left side, you'll have to create the tunnel with your right hand. On the right side, you'll have to create the tunnel with the left hand, and vice versa as far as the cochleostomy is concerned. So another thing which maybe I am not able to show you there, but I'll tell you, your left hand is your right cochlea. So please see here that this is the round window, and that is the basal turn coming. So if you have a round window like that, round window niche like that, please understand the round window niche is not till here. It is not till here. It ends here. Where the basal turn comes and meets the round window niche is the end of the round window niche. This portion of the round window is not the round window niche. It may be a round window niche, but in all consideration, when you are doing a cochleostomy, you have to see the basal turn. And when the basal turn comes and meets the area of the round window niche, that anterior inferior is the area where the scala tympani would be. And opposite in cases of the left cochlea. Your right hand becomes the right cochlea. So this is the round window, and that is the basal turn coming. Wherever it meets, you just have to see the basal turn and do this. And all the other ways, I mean, this is also helpful when you are doing a drill out technique in cases of, doing a second cochleostomy. All these are possible only if you have this in mind, the basal turn in mind, and if you keep seeing the basal turn, you can actually avoid going into the internal carotid artery also anteriorly. So basal turn on the cochlear promontory, is the crux of cochlear implant surgery, even in difficult situations. So we will start the surgery now. And
sir, any specific things you would like to see on an MRI, except for the nerve thickness?
Yeah, we can actually see the modular diameters also, as I told you yesterday. Those people who use the perimodular, they should understand that the modular diameters can be different, very, very different. And you are putting a pre-curved electrode there. So modular diameters can be different. So you have very thick to very thin, spiral ganglions, circular. So in the MRI, you see that.
And then, sir, in some cases, you don't have a dilated vestibular aqueduct or a problem in ISC, but still you get a gusher or an oozer. So what can be the probable reason?
No. See, please understand, if you have a large vestibular aqueduct, you will not get a gusher. You will get only a pulsating discharge for some time. Gusher will come only if you have a large cochlear aqueduct.
Okay.
These two ducts are different. I think we are still confusing with that. These two things are different.
Right, sir.
A large cochlear aqueduct you can actually see very well. I want to focus that. Yeah, that's better. That's better. A gusher will occur only if you have a large cochlear aqueduct or your internal auditory canal is continuous with the basal turn.
Right.
Okay. We will now mark the implant site first. Yeah, give me the now, if that is the
4 years.
receiver stimulator. Can you see that?
Yes, sir.
No. Please, ऊपर वाला कर दो. ऊपर वाला कर दो. ये वाला ले आओ. और थोड़ा आगे करो. Zoom back. नहीं, zoom back.
Zoom out.
Zoom out. हाँ, बस ठीक. हाँ. अब लाइट कम करो. Yeah, this is okay. ठीक है? Now you keep the implant at the right place. In a child, the area is quite convex, and that's why as I told you yesterday, we have to have receiver stimulators which have the angle fixed in on the squamous temporal bone properly. So if you don't have it, you will have problems. Now, for an endoral incision, go a little away from the that is the incision which we'll make. Okay?
Sir, how do you ensure symmetrical placement in bilateral cases?
Huh?
Symmetrical placement in bilateral.
Yeah, we should. We should keep a symmetry, but please don't compromise the positioning of the implant onto the skull for a symmetry, because the children the squamous temporal bone may be irregular on both sides, and that will cause a problem. So, but you have to see that your implant, sits onto the squamous temporal bone properly. That's important.
So more important
So even
is
if there is
stability.
the stability is more important than anything else. And now we first give, no, circular, we first give a horizontal incision.
Sir, has the
So
child
give
been
it-
infiltrated?
Yeah, the child, I wish I had shown you that, but the infiltration is given over here, and around the pinna. Infiltration is given around that area. And I wish I had shown you that also, but then scrubbing and it becomes a little difficult thing. So now you take this position, this is a good flap, and you take this position and give a horizontal incision. Yeah, blade. Now, with your left hand, please see what I am doing. With your left hand, I am holding both your hands have to work in this. You can't just be doing with one. With your left hand, then take this incision anteriorly so that your posterior canal wall is big enough and come out. Can you see that?
Yes, sir. Sir, can the
Definitely.
second camera focus on your hands and show us in PIP?
हाँ प्लीज डू दैट मेरा ये दिखा सकते हो साथ में हाथ भी ब्लेड दे दो दोबारा कैन यू शो माय can both the picture in picture can be shown in my hand and my
Microscopic picture.
रख दो I'll go very slow today
Right, sir.
so that you can appreciate each and every step. Now, again, this goes out and the upper thing comes. Blade. And now this is extended. मेरे को लाइट इधर भी चाहिए ये लाइट भी दो या इसको ऊपर कर दीजिए प्लीज पुट इट हियर yeah that's better.
Sir, we cannot see the incision. The angle of the camera has changed. Yes, sir,
Can you
this is
see?
fine. This is fine, sir. Sir, has your incision changed with time or it has remained the same?
It's become smaller, much smaller than what I used to give. Actually, we were used to of the pulsar implant, if you remember. And then we used to give a very big incision because that was, scissors and forceps. In that case, we had to drill the whole bed of the implant. Everything was in that pulsar, and the incision was really big. Now, the incisions are very, very small.
Right, sir. This is separation of the subcutaneous tissue from the musculoperiosteal flap,
From
sir.
the muscular bed, yeah.
Sir, the camera position needs to be adjusted. Your hand is not allowing us to see the dissection.
थोड़ा zoom in कर दो. Yeah. Bipolar. Bipolar, please. Can you give me this thing? Towel clip. One more. Then things won't fall. Oh no.
Sir, head shaving, is it done the same day or a day before?
Complete head shave.
You still believe in complete head shaving?
Yeah. You know, in India, the sweat from the hair is pretty bad. And that pressure bandage, what we give for 5 days, somehow being in a government, when I was earlier in government, I don't compromise on these things, and that's probably gave me good results, you know, no infections, all those things, which, yeah. Dabado. नहीं बाइपोलर नहीं चल रहा नहीं 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 ठीक कर रहा था दिस इज कोगुलेशन ना
So do you use the unipolar or just the bipolar?
Yes, sir, that is.
the bipolar
Only the bipolar.
only the bipolar see when we are doing the other side sequentially then in any case we can't use it so it is better that you try to
Get used to the bipolar
get
only.
used to of the bipolar only.
So little fine focusing needs to be done.
कर दो भैया फाइन फोकस दे दो ब्लेड दे दो In a child, you will have these fibers getting attached from though he's a 4-year-old child, but you still have those fibers getting attached from the skin, the temporalis muscle fiber. So that's why you will have a few. Yeah, give me a tie, please. This says stay sutures. Now you give this, but इसको focus कर दो. ये focus it. Now, one thing which I'll again tell you, please do the way I am doing. Don't try to, find your ways. It is only because I keep telling that not that I'm right, but I was wrong many times.
Right, sir.
So what finally has come out is a thing which I suffered and then I changed. See, I was the only guy doing this. So there were many changes to be done and I kept changing with time. The initial things, I had problems, I kept changing. So finally now you don't have to, do research on these things that what to do. It might suit you, but one day it will give you a little problem. So always, if the way I am doing, do it completely like that.
Right.
Every step I can tell you, please do it the way I am telling you to do. Then Varia would be very, very easy. I know sometimes people tell me, sir, it looks very easy, but you have to really practice it. Blade.
Right.
Now, yes, now this is called the Hunt's flap. Now, why is it important? Your temporalis muscle comes and gets attached to the suprameatal crest. And below that is only the temporalis muscle and the periosteum. So you can take that flap. Now, in the initial surgery, the incision goes like this. So when you are trying to cover the suprameatal well, it would not get covered properly and the electrode, sometimes if it is not snugly fitting into the suprameatal well, will keep coming out, popping out. And it may fall anteriorly into the canal also. So these small little things I'm telling you today, how to avoid the wires have, the electrodes have actually fallen into the extraordinary canal. Now that was a very small mistake which people did, and this is what I'm trying to tell you, that please do it this way. So that is the
Hans flap.
The Hans flap, and goes like that. And now this portion has only, there is no muscle in this. There is no temporalis muscle, because the temporalis muscle has got attached to forceps, has got attached to the suprametal crest there. Here. Calcula. Yeah. Blade. No, elevator.
And an important thing to note here is that the lines are not overlapping. Both the incision lines are not overlapping.
Blade, please. Blade again. Every tissue has to be removed. When you are elevating and if you see a fine little strand coming, cut it. Don't try to elevate it with the thing on, because it can bring out your tympanic membrane completely. So right. Cut it. Just keep cutting every bit of strand which is coming there and trying to... See, please understand, like a cataract surgery, everything goes back. Every millimeter of tissue goes back from where it has been removed. So you have to cut it that way, so that you don't have to, you can't spoil any of the tissue so that it doesn't close the way it should close.
Right, sir.
Tie again, the stay sutures.
Do you undermine the tissue? Is it required, sir?
Undermine means?
Means freeing the flaps so that at the end you get a good closure or no tension on the suture line.
No. You don't need that. Believe me. If you have done a good, if the implant is in a good bed, you will not need any of the mobilizations of that.
Right.
Elevator. Now the periosteal, subperiosteal funnel for the forceps. Implant. No, the template. Now see, it is lying very well. You have to take it a little posteriorly, because that is the stable area which is there. One more thing very important is that your incision should not come over the coil. If the now this is the coil here, this is the coil. It should not come onto the coil. If it comes onto the coil, then when the electricity passes, you will have redness and erosion here. So
Sir, do you always make a bed?
Always. See, all these implants need the bed to be made in a child whose skull is so... मेरे को elevator दे दो. Elevator. नहीं, elevator बेटा. Yeah. Marker.
Sir, but as the age is coming down, age of implantation,
it's very, very difficult. You will have to. Retractor, mastoid retractor. Bed has to be made in all these implants. You don't try to not make the bed. Bed is very important. Yeah, drill please. Marathon.
Sir, and your criteria for selection, any minimum weight or hemoglobin level or age, what is your criteria? How do you select?
Yeah, the hemoglobin has to be all right. नहीं राजेश, this is not working. ये हैंड पीस भी काम नहीं कर रहा. उसको रखो. मेरे को मैराथन दे दो. वो दे दो दूसरा जो मेट्रॉनिक्स दे दो. या हाँ उसके स्ट्रेट हैंड पीस भी रहे गड़बड़ है. हाँ मेट्रॉनिक्स ले लो. इसका वो कहाँ है? ये रहा.
Sir, many times while doing this, the dura gets exposed or the bony island is not
No, we
attached.
have to keep a little a bony island there. We have to. You can't expose the dura because please understand the dura only understands the heat sensation. It doesn't understand the prick sensation. So if you have not done if you have put the implant onto the dura, the child is going to suffer. So never do that, please.
And in case if we get a free bone, so we should place it in between.
Take a complete island, push it inside. You can do that.
Right. What if at the stage you get a CSF leak or there is an injury to dura and you get a CSF leak?
No, then you close it, have fibrin glue with you, put a cartilage inside and fix it up.
And sir, do you collect the bone dust?
Huh?
Do you collect the bone dust? Many people, they do it to fix the electrode or...
Maybe in the initial stages, when you are a budding surgeon, you should, because then if you do a buttonholing of the tunnel,
Right.
you can put bone dust over there and a, diamond dinner. Remove all the bone marrow because the bone marrow will keep bleeding.
And sir, how often do you find an emissary, mastoid emissary vein?
Sanjay?
How often do you find the mastoid emissary vein bleeding?
Oh, quite some time. With the diamond, you can actually take care of that.
Right. Sir, do you fix the implant?
No. You make a good bed, there is no need to fix the implant. And with the bipolar we have, with the double-breasted incision we have, the flaps, it will hold the implant very well there.
Right.
Chota cutting de do.
And was it the same practice when you started?
Always.
Okay.
No, but the ceramic implant, what do you do? Template. The ceramic implant we used to fix. because that was all exposed.
Okay.
There's a marker. No, shooter cutting.
So the edges of the bed, they should be at a 90-degree angle, right?
What?
Edges of the bed.
Yeah, 90 degrees. Only then it will fit there.
Right.
I think I'll have to make an island like that because it's a very thin bone.
Yes, sir.
The diamond. The bone marrow will keep bothering you, so don't worry.
Yes, ma'am.
Yeah, bipolar. The what?
Yes.
Hold it like that. Uh-huh. No, no. Okay, no, no. See, that's the reason why I say they will have to come up with implants which don't need this kind of a drilling, very thin implants. Even in the nucleus, we have to do it.
The profile series.
And in small children, we are trying to do as small as 6 months now. Cutting. Template de do.
So do you require a bed with that neurobio implant, the new implant?
Huh?
Neurobio?
Huh?
No.
Yeah. No, I have started liking it because, first of all, Diamond, there is no electronics inside. So I'm not putting any electronics inside the child's skull. And secondly, there is no drilling required.
All right. So you just slip it in the periosteal pocket.
You just slip it in it's like a coin. Wash. Yeah. Give me a cutting, please. Take first and then a cutting. No. Good. Cutting. Okay, now once this bed has been created, you have to, the next step is to raise the flap. And you put the focused. Yeah, give me a blade.
Sir, little fine focusing is required.
Chota suction and blade. Is it okay?
Fine focusing.
Fine focus कर दो बेटा अपने वहां से आगे से. हाँ.
And sir, distance that you take from the annulus to the incision, it should
Yeah.
It should
No, it depends upon the size of your canal.
Okay.
I purposely took it small today so that it doesn't come on your vision and you can see it properly. If the canal is good enough, you can actually take a bigger incision. Flap.
Right now we are going with a smaller flap.
We've taken a smaller flap because
it can come in between.
Now I am sure that there will be no buttonholing and I don't need a bigger one. But in the initial stages, you may
lift a longer flap.
Take a longer flap. Circular, please.
Sir, what size suction tip are you using?
This is 14. Now I'll take a smaller one. अब छोटा दे दो sister. Circular and cotton.
And the point of entry, it would be in the region of flaccida, right?
Yeah.
Okay, sir.
Cotton. And give me micro scissors, please. Micro scissors. Specular again. Give me a dry gauze. Flag.
This is the corda.
Needle. Flag.
First aid.
Yes. Crocodile, please. Flag. Clear दे दो.
Sir, what should be the level?
What should be the?
Level of raising the TM flap. It is from 11 o'clock to 6 o'clock, I suppose.
No, almost 12 to 6.
12 to 6.
12 to 6, just to show you. Otherwise, it can be small either.
Okay.
Drill दीजिए, छोटा drill दीजिए. Maybe a diamond. या cutting दे दो. एक cotton दे दीजिए. Cotton डाल दो बेटा अंदर. डाल दो. One more. Now that is done so that no dust should go inside the
Right, sir.
middle ear. Put a cotton there so that no dust should go.
You're now straightening the canal, sir?
I am straightening the canal now. It's almost straight. That is the suprametal crest.
Right.
So I have to be under that. And in middle, you have to create a very big suprametal well because the extra electrode is too big.
So please centralize.
ये बड़ा करो बेटा.
Sir, the image needs to be centralized. This is fine.
Undermine the
Edges.
undermine the edges so that your
Electrode fits.
electrode goes inside. Yes, in a medal, again, I'm telling you, you need a little bigger. And this should be, can you see how deep it is?
Yes, sir.
So that it doesn't slip out.
Right, sir.
लो, एक छोटा कटिंग दीजिए. Small cutting, very small cutting. मुझे एक diamond भी दो इसके बाद. Now you drill that
And you connect
to
it with
put
the
your electrode from there.
Sir, do you create a hook in this region to hold the
Yeah.
electrode?
Yeah, I am doing that. Now, earlier I used to make this a tunnel only,
Okay.
but now I am opening it because you will have to otherwise, take it from here and then bring it out and then take it again from. So this is the kind of hook you have created
Okay.
so that the electrode would stay there. Okay?
Right, sir.
Now, diamond again. थोड़ा सा यहाँ ooze है. Diamond दो. नहीं थोड़ा बड़ा बेटा.
Sir, once a patient comes to you with bilateral severe to profound hearing loss, not getting any significant benefit with a hearing aid, do you always suggest bilateral or recommend bilateral?
No, always, now always. And they're getting it done.
Okay.
People are getting it done.
So first recommendation is bilateral.
Bilateral always.
So then it is
Because
financial.
the child who has to learn hearing needs a bilateral.
Right, sir.
Too many emissaries there. Please see that they are completely closed. Otherwise, they will bleed again. Take some time to
Achieve hemostasis.
Yeah. Okay. Crocodile, please.
And
Cutting dena beta.
Once the patient, they come to you, they have been counseled by other doctors or they have read about the surgery online. So do they ask you about the chances of facial nerve injury or implant migration or device extrusion? Do you get these questions?
Yeah, they do ask. They do ask. Tell them one story. Tell them, have you ever gone to a chota or chota? Have you ever been on an aircraft? They'll say yes. Does that girl say that the aircraft may fall down? They will say yes. So do you get down of the aircraft or you still want to travel? Similarly, we have to tell you all these things, but they generally don't happen. They can happen, but they generally don't happen. Okay. Now, I'll show you where my cochleostomy would be. That's important. So, first bit of magnification bada kar do. Okay. Where is the fine focus in this? Yes, there is a fine focus. Okay. Yes. Okay, now you see. Now is the most important step. Give me a needle first. Give me a needle first. How many people are there in the auditorium?
Sir, it's almost half full.
Oh, almost half full. That's good enough for a cochlear implant surgery. Now see this. Please see, this is the round window niche. Now, initially we used to do it anterior-inferiorly from here. But see the basal turn coming. See the basal turn coming. That is the basal turn, and that is where your cochleostomy has to be. Yahan par. Your round window niche actually ends here. This is the hypotympanic extension of the round window. Chota de do. So I'll just mark the area where the
cochleostomy would be. Sir, can we zoom in a bit into the middle ear?
Zoom, okay. No, wait. Can you see?
Yes, sir.
Is it okay? Now, just see that. I'll have to zoom it back because I won't be able to operate this too close, but that is the basal. This is the round window niche. That is the basal turn. That is the basal turn going. That is the basal turn going up.
Right, sir.
You have to do a cochleostomy where the basal turn comes and meet this. Yeah, as I told you, this is the area where the cochleostomy would be, and I'll just show you how.
Right, sir.
Yeah.
And what we can see inferiorly is the hypotympanic extension, sir.
Huh?
The inferior part is the hypotympanic extension.
You want to see that?
No,
Okay,
what we are actually seeing on the screen below
the
the round window niche.
hypotympanic extension. That's not the round window niche.
Right, sir.
The round window niche is ending at the projected area.
Right, sir.
That is the mistake we are making all the time. We are doing anterior inferior to the round window niche.
That is going
and
into the
thinking that the
hypotympanic.
round window niche is going right till down. No, it is not going. This is not the round window.
Right.
This is not the round window niche. The round window niche is ending here, this one. And that is the basal turn coming. With a diamond in it. Cochleostomy diamond. Now you will have to hold it with your left hand. You're doing the left side, hold it with your left hand. You can't do it with the right hand. So this is the area where your cochleostomy would be.
Sir, can they focus on your hand?
Can you show my hand, please?
In the PIP. So you're just marking the site of cochleostomy, or you'll be...
Yeah, just marking. Just marking at the moment. Because that is also important.
So they need to focus on your hands.
My tunnel would be in line with that. My tunnel would be in line with that.
Right, sir. Sir, have you reduced the speed?
We have reduced the speed. Okay, that is the area where the cochleostomy has to be. It is anterior to the round window. It will go up. It will go in that direction.
Right, sir.
So give me a gel foam, please. Now, I'll show you where the tunnel would be. Give me a marker, please. Marker. Now, your tunnel has to be in line with this, okay?
Right.
That is your tunnel. Now give me perforator, please. ये section थोड़ा बड़ा कर दीजिए. Perforator.
Sir, almost every time it is this place only, or it varies a lot. The
Kya
tunnel,
cheez?
the line of the tunnel.
No, it should always be like this. Lots of water. Inside out, please. Now, one thing which I'll tell you after I have done this.
It has come out.
Now, hold it like this. Hold it like this with your right hand. This is the left side, so you'll have to do the tunneling with the right hand. Okay? Now, give me the small sections. Small sections. Now, you see, we have put the tunnel has to be behind this, not over this. I mean, I saw one doctor doing it right here. This wall was very thick. Then once you pack it, that electrode would get pinked. Now look at that. Can you see the corner is fine? It is going straight to the cochleostomy. And there is no problem at all. How much time did it take? 10 seconds. Okay? Now we go back to the cochleostomy side.
Sir, what if little amount of buttonholing happens? You just need to cover it with bone dust? buttonholing in the tunnel.
Yeah, initially you can do that. Yeah, give me that cochleostomy. ठीक है राजेश.
Sir, the size of the bit that you're using for cochleostomy?
1.2.
1.2.
In middle, you will have to use this because.
And sir, you don't irrigate with steroid while you're making it?
We are doing that. It is steroid. Section chota karo.
And the direction of drilling?
Anterior superiorly.
Anterior superior.
Anterior superiorly.
The direction of the cochlea.
Yeah. Towards the basal turn.
Right.
Direction of the basal turn. Do we have the straight one? Straight diamond. इससे थोड़ा बड़ा system.
Sir, you always do it with the 1.2 mm burr, even if the electrode is small?
No, I'm taking the 0.8 now, and that I'll show you.
Okay.
0.08 straight middle cochleostomy burr.
Okay.
Okay? You're right there.
Right, sir.
You will never ever go wrong. Never ever go wrong. That is the endosteum. And now you bring down the endosteum. This is the crista which I am drilling now. That is the crista. This down thing was the crista.
So that we get a straight access.
Yeah. You can see the modulus. Beta bas bas. थोड़ा मुझे दो. Give me that. नहीं. Dexa सबसे पतले needle में दो. You can put some Dexa inside so that no dust goes in there.
Just to mention about the equipment, we are using Zeiss X-ray microscope, and with a beam splitter we have put the stored spike camera, and that is how it is getting transmitted. Sir can do with marathon also, but presently the marathon handpiece didn't work somehow, so we are using Medtronic's IPC with the straight and contra-angle handpiece, and the perforator is from Decibel. Anybody can order that from Decibel.
Yeah.
They make it.
Give me the implant, please.
And we are using a metal implant.
What is the thickness of the electrode, ma'am?
Metal concerto.
1.2 is the base, 0.6 is the tip. The ring is 1.3. So what I have created is 1.2 and a half.
So the ring
So
would
that
fit.
when the ring goes there, it snugly fits inside.
Right, sir.
So you don't have to pack it.
Metal
Standard electrode. Standard. De do?
So you're taking the implant?
Huh?
You're taking the implant?
Yeah, I'm taking the implant.
Initially, what you used to do was a genta wash before the implant. Now you're not doing that?
No, I'm not doing. Because I was in a government setup, and that's why I used to do that. In a private setup, the things are pretty good. We are using disposable things. The sterility is par excellence.
Right, sir.
So now there is no need, and we are giving monosef amikacin, for 5 days. So I have had never a problem of infection because my ways of doing the implant are still the old primitive. I shave off the head completely. I give them monosephamicacin for 5 days, injectable. So, and I do it in a very, very sterile condition. Boss, please.
And the first dose, it is intraoperatively only?
Yeah.
And for how long do you continue with antibiotics, sir?
5 days. 10 days?
No, 5 is
5
for
days
injectable and
5 days.
5 more days.
5 more days, 10 days. And the dressing is also for 5 days.
And after
Can I
5 days, you remove it or you do it again?
Huh?
You remove the dressing after 5 days or you do it again after 5 days?
Change it.
Change it. And you remove it on the 10th day. Sir, this implant does not have a ground electrode, a separate ground electrode.
I'll show you where the ground electrode is. See, my time taken was only for the bed. Can you believe it?
Right, sir.
That was creating all the nuisance which, as an implant surgeon, I think there is. Exposure of the dura, thinning the squamous part of the temporal bone in a child. And I have had cases in which the child fell down and a fracture because of these beds created. There was a fracture in the bed and going out because obviously it becomes a very thin area. So these implant people will have to come out with something which is much smaller, much smaller. If new bio can come, why can't we come?
Right.
That is what my thing is. They have to give us something which is very, very small so that we can put it easily in a 6-month-old child. Elevator, please. Surgery bhi de do.
And sir, the youngest child that you have done is 6 months?
6 months, 6 months. I'm putting a little Surgicel onto the dura just as a precautionary measure. Thoda aur de do, sister.
Sir, microscopic picture needs centralization.
Focus kar do.
You have covered the dura with Surgicel, the exposed part.
Now these things are important, Elevator. These things are important because dura understands only and this is an electronic thing. Anytime you will have heating up of the whole thing.
It has went smoothly under your hook.
Can you see that?
Yes, sir.
Now hold it in your right hand on the left side and vice versa on the other. Louder. Claw or something.
So you're pushing it with your right hand only.
Yeah.
Guiding it.
Now forceps, the middle forceps. Section, please. Hold the forceps with your left hand and keep putting it gradually.
Sir, do you instill Decatron while passing the electrode in?
I did it.
Okay, sir.
I did it before that. Just millimeter by millimeter, don't force it. See, that is the ring there now, and it is snugly fitting inside.
Right, sir. Sir, what if at this stage the electrode is not going in completely, but you know that you have made it on the right track? So any
No problem. No problem. See now, maybe my this thing was smaller, the cochleostomy, and a part of the electrode, but all the rings have gone in, but part of the electrode is still out, but I'm not bothered. So I don't want to push it because all the active electrodes are inside, so there is no problem. The ground electrode will now come here, the extra electrode, elevator, micro elevator.
So do you recommend twisting it and directing it inside when it is not going? Twisting the electrode and directing it inside.
Yeah. It will go because there is a lot of overhang. You just have to put it inside, it will go there without any stress. See, I made that overhang very good. So you can see the whole thing is gone without causing, and this thing has come here and not coming out. Okay? Section, please.
Since we have a stopper, we don't need to pack it with periosteum.
No, we don't want to do that.
But you use periosteum only for packing?
For packing, yes. If there is any need, I'll just put that only.
Sir, any special precautions you take in cases of gushers? Any special things you do?
Yeah, we have a three-hand technique, as I told you. We will just needle. In gushers, we have to anticipate that. So we will have to keep the implant ready here and in the tunnel, so that when the gusher starts, you put the electrode immediately inside. Don't let the gusher completely. Now, there are two advantages of this. One, the scala is quite wide apart with the CSF inside. So it will go more smoothly. It has gone smoothly, but then it will even more smoothly. Secondly, you don't want the gusher to be completely, the CSF to dry out, because next day, if you would not know whether you have packed the cochleostomy properly or not when the pressure of the CSF is not so good. So what will happen is next day you will have a lot of soakage. So when you put it, when the gusher is on, gel foam de do, then you will not have these kind of things.
And any electrode that you recommend once you have a gusher that you have, on preoperative CT that you will get a gusher. So any electrode that you prefer?
No, but any electrode? No, normal electrode.
Normal.
Because the foam electrode is not the good one. It will not. It is okay for the endolymph coming out, not for the CSF coming out.
So any electrode can work?
No. Foam is not recommended. That's all I want to say.
Right. And
you can have any electrode, because then you will have to pack it with this thing.
Periosteum.
Periosteum. You will have to pack it with periosteum.
And
one more.
Post-operatively, how do you manage these cases, sir?
There is no need.
No acetazolamide?
No. There is no need. If you have packed it well, there is no need at all of anything.
And do we need to wait after packing so as to see if anything leaks out, or increase the ICP and see?
I hope you saw this thing yesterday, my video on that. Okay. And now we will show you how to close. Now closing is very important. Sister Scissors. Closing is as important as the surgery, because वो क्या था हमारा जो बाहर नहीं आ पाया, कौन थे वो महाभारत में? अभिमन्यु. अब वो बेचारा सीख जाता बाहर आना तो बड़ा अच्छा रह जाता उसके लिए. वो फंस गया क्योंकि उसको बाहर नहीं आना आता था. So if you don't close it, I'm telling you, you're gonna get into that. Many of people have got into granulations in the extra-aortic canal just because they did not pack it well. See, now it is going there. Can you see that?
Yes, sir.
you have to create a big tunnel bed so that no portion of the implant is outside. Switches.
Sir, when do you switch on the device?
There are people who do it on the table. I don't want to do that. Again, because there is a possibility of the infection going in through this speech processor. They keep the speech processor there. See how easily it is getting closed. I'm not forcing the. That is all because I took the flaps so beautifully that focus kar do yaar, अच्छी तरह.
And do you
ये
do
जरूरी है.
intraoperative X-ray, sir?
We are doing, no, there is no need. Oh, do you think there is any need? I could see the modulus, I put it very well inside.
Yes, sir.
It is going smoothly. There is no chance of any curling up there.
And this is your standard practice. You don't do it in any of the cases.
No, I do a post-op after in the evening. That is to keep the thing in my
Medical
file. I have even the first child's file with me. Please understand, this is a beautiful surgery. The only thing is you'll have to practice, practice, and practice. It is, your posterior tympanotomy is very easy. I believe that. But it is not a very scientific way of doing the cochlear implant. Because when Professor William Hout started the cochlear implants, the first thing he did was on adult. Now we are doing children. We have to respect the nature. We have to respect the nature. And nobody concentrated on this for so long.
Sir, you always prefer cochleostomy.
Huh?
You always prefer cochleostomy.
It is scientific. I worked with Professor Graham Clark for 1 year. And that time also people were trying to do a round window insertion. He only gave me this picture. You know the one I showed you yesterday?
Yes,
the Krista? It is he has given me. And he said that in a cochlear implant, a cochleostomy is better because the baffle effect needs to remain.
Right, sir.
And if you spoil the round window niche and put the electrode through the round window, such a big electrode, you will not have a baffle effect.
Right, sir. Sir, we'll be starting with the next talk in around 2-3 minutes.
Just one more stitch which I'll show you that is important.
Yes, sir.
So then the closure can be done by the girls. Now, just see these two stitches. This will come here.
Right, sir.
This will come here. पकड़ नहीं रहा आपका कितना
Thank you, Dr. Rohan, for wonderful moderation.
Dr. Sampurna, just one more stitch, very important stitch. Just let them see that. Now, this, okay, it is going on. This brings the canal together. This stitch brings the canal together. So there is no chance of any granulations in the canal, which many people say they are seeing after. So this parallel thing is the incision which will bring the two edges of the canal together. Now you can switch it over.
Sir, I want to tell you also, sir, we have created live YouTube link which has been forwarded to different groups in World ENT and different states, and a lot of people who could not come to the hall, or the doctors who left yesterday, they were present. Those who left for airport, they are watching your surgery. They have watched from their on the journey, and everybody is very, very happy. And you see, sir actually started at 9 o'clock, and by 10 o'clock, the whole surgery is over. That is the beauty of Varia technique, and that is how sir makes it look so easy, feel so easy. But definitely, it doesn't happen in one day. It needs practice, a lot of practice, especially making that tunnel how sir did in a single attempt. It needs to be practiced on a facon bone, on a wooden block, and then only smooth expertise comes. So I and carry on for the session. We have two wonderful talk which we have selected immediately after the implant, so that the essence of implantable otology keeps.
Thank you.
Now I call upon our speaker, Shailaja Temaraju. She'll be giving a talk on hearing implant solution. Let me introduce our speaker. She's a National Manager Education and Training at MedDel, Delhi. Experienced audiologist with Doctor of Audiology from A.T. Still University of Health Science and AIISH, Mysore. Skilled in working with surgeons and hearing professionals in cochlear implants, middle ear implant, and bone conduction implant for different age group. Strong healthcare services professional with focus on clinical audiology and research. Over to you, ma'am.
A very good morning to everyone. That was a great demonstration by Dr. Hans, and it's always a pleasure to see him operate, and he shows how easy it is to do cochlear implant surgery. So to continue with the cochlear implant aspects, and also to talk about candidacy considerations for cochlear implants and other implantable solutions. So the goal today in this short presentation now is to show what other implantable solutions are there for hearing loss, not just cochlear implants, right? So thank you so much at the outset to the organizers. It's a wonderful conference, and I wish you a very good scientific day today as well. All right, so hearing solutions are not just a cochlear implant. Depending on the site of anatomical depth, or depending on the site of the anatomical placement of the device, different names are given to these devices. So we have a different variety of implantable solutions, starting from cochlear implant. If it falls within the cochlear implant candidacy range. So this kind of setup would be called, or fitting is called as bimodal, because one side you're hearing through acoustic, the other side is electric through cochlear implant. So this is a bimodal kind of a setup, and this is very easily done nowadays with metal software we have. It's quite easy, quite simple. Another scenario is single-sided deafness. So single-sided deafness also is a great, way to achieve that binaural hearing or binaural advantage. So pseudo-binaural hearing is possible with other kind of devices, but true binaural hearing is when you stimulate the ear with hearing loss directly. So if done early, if done right away, you're giving them the true binaural hearing. But if it crosses that optimum age of giving a cochlear implant, if there is auditory deprivation, then we can consider another type of an implant, which I'll be talking about. Moving on to a different kind of an implant, which is electric acoustic stimulation system, wherein you have the combination of electric stimulation and acoustic amplification done through the same system. So if you look at the device, it has, it just looks like a cochlear implant, but the processor has an additional ear mold attached to it, to the end. So what it is doing is the sound, when it is heard by the processor, it is dividing the sound to low frequencies and high frequencies, or low, mid, and high frequencies. Then it will divide the high frequencies and convert those into electrical stimulation pulses, while the low and mid are going through the acoustic amplification unit or the system. At the end, the end sound is actually a combination of electric and acoustic. So this is what is presented to the individual, and he will hear the entire sound going through the same system. So ideally speaking, for a hearing loss like this, good low frequencies in the, good hearing in the low frequencies with poor mid and high frequencies, they should be wearing a hearing aid for low and a cochlear implant for the high. But that's not practically possible, and that's where the EAS system has come into place, and that takes care of both mids and lows and highs through the same system. Yeah, but the caveat is that there cannot be any malformation of either the external auditory canal or the cochlea also, because you need to have true representation of all frequencies inside the cochlea, and you need the external auditory canal to place the ear mold without any obstruction. Yeah, so these are the type of hearing loss that you can see, like good low frequencies, poor high frequencies. Also, the type of electrode array you choose for this, again, depends on where is your cutoff, like till where you want to give the acoustic amplification and where you want to switch to electric. So that's what determines your electrode array. So yeah, we've talked about this. Now moving on to the next implant system, Vibrant SoundBridge, which is a mid-ear implant system. And just to give you a basic idea when it was invented, it's in 1993. We are sitting like beyond 25 years now. And this is how the implant looks like. You have the same as a cochlear implant, you have a magnet, you have the coil, but you have a demodulator here instead of a receiver stimulator. In a cochlear implant, we have a receiver stimulator, while here it is a demodulator. You have a conductor link, you have vibrating ossicular reconstruction prosthesis, that's the VARP, that's what it is. And at the end, you have the floating mass transducer, the FMT. This is like, to give you a basic analogy that we can all understand, if you've had a hearing test done, a bone conduction test is done using a bone vibrator. So that's an electromagnetic transducer that vibrates and sends the signals into your skull. So similarly, this is an FMT, which is going to be placed in the middle ear. Middle ear ossicles is where it gets coupled onto, and this is the this is how it looks. If you can see this here. So middle ear ossicles is where it gets coupled onto, and once it vibrates, the middle ear ossicles are basically because the pathology, whatever was there, is already eradicated. Now you're looking to close the airborne gap and give a long-term solution without closing the ear canal. Because you don't want to close the ear canal, it will cause recurrence of whatever middle ear pathology was there. Right? So these are the cases where chronic otitis media, tympanosclerosis, cholesteatoma, or radical cavities. So all of these are the ones that pathology has been eradicated, bone conduction thresholds are stable now, there is no active infection, and now we've tried with passive reconstruction, and still the AB gap is left. And that's when the, what you call, vibrant sound bridge comes into play. Because these cases might have eroded bones, or the ossicles are eroded or fractured, you might not have the proper, like a bridge of ossicles to conduct the sound the same way as in sensory neural hearing loss. So those cases, you can choose either a vibroplastic clip coupler. That means this, this FMT can be coupled onto the stapes head, or you can choose the round window niche region. So these are the different couplers available for mixed hearing loss where the ossicles are not available to be used as the site of placement. Conductive hearing loss, again, the kids that are born with like normal BC, it'll have to be. Hearing loss is like the bone conduction hearing is within the normal region, normal thresholds. While if you look at the conditions, they are the ones that are born with stenosis, atresia, microtia, anosia, or malformed middle ear. They are the ones sometimes with fused ossicles as well. So those are the cases where the surgeon will have to fracture the ossicles and then go on to the stapes head. If the stapes footplate is mobile, right? If not, then you would choose a round window placement. So these are the different placements available depending on what is the condition: sensory neural hearing loss, mixed hearing loss, and conductive hearing loss. So these are the three types of hearing loss wherein you can choose the coupler based on the anatomy. Yeah. Samba 2 is the processor. I'll not go into the details of it, but let's just put it this way. It's an intelligent sound processor which knows to learn from the environment the patient is being in. So the end result of the sound that you get through middle ear implant or the vibrant sound bridge is very natural because you're just augmenting what's already happening in the normal anatomy just by placing the coupler. Yeah. And the other thing is, like I said, ear-specific stimulation. If you put vibrant sound bridge in this ear, you're stimulating only this ear. It's not crossing over to the other ear because you're only working with the one side where you're implanted the VSB. Single point attachment, it's going to be either on the ossicles or within the round window niche. So it's an ear-specific stimulation. True binaural hearing is what you get. Yeah. And because there is no receiver and microphone loop that gets formed in a hearing aid, there is no feedback. There is no occlusion because the ear canal is left open. So these are the advantages. Yeah. Bone bridge is the active bone conduction implant. Again, it was launched in 2011, and it's the world's first active transcutaneous bone conduction implant, which means that transcutaneous means there is no open wound or infection led because of the open wound. There is no need of maintaining the skin around the abutment or anything like that. Transcutaneous is intact skin solution, so that's the world's first transcutaneous solution in terms of a bone conduction implant. So the implant looks like that. So you have the magnet and the coil, and the newer design of the bone bridge comes with the demodulator and the floating mass transducer in one package. So it looks like that. So it is placed on the hardest part of the temporal bone. Like you'll have to choose the thickest portion of the temporal bone to actually drill and place the bone conduction implant in place, the FMT in place. So I'll be showing that as well. So indications, you can either do it for a conductive hearing loss or a mixed hearing loss, or single-sided deafness, which is sensory neural hearing loss. Conductive hearing loss, so obviously bone conduction has to be normal. If it is a mixed hearing loss, it can be within the red shaded region. And single-sided deafness are the individuals I just talked about in cochlear implants, wherein I said if the auditory deprivation period is too long, you can't do anything for the single-sided deafness ear, because if you place the cochlear implant, it's going to be a hindrance to the normal ear. So therein, if you want to provide at least a pseudo-binaural advantage, that's where you want to place a bone bridge here. So the head shadow effect is gone because you're picking up sounds from this side now. So because the bone bridge picks up the sound, stimulates the skull, and the sound goes to the best bone conduction, which is the normal ear. So you're actually placing the bone bridge on the single-sided deafness ear, and the signal is going to the routed through bone conduction to the good ear. So that's what is possible. Yeah, BCFMT placement. Yeah. So I'll take another 3 minutes, if allowed. Yeah, thank you. So placement is basically either a sinodural or a retrosigmoidal placement, or a middle fossa, if these two are not available. Temporal bone thickness analysis is what tells you where to place your, what do you call, the FMT. Because like I said, drilling has to be done, sigmoid sinus needs to be kept in mind, and dura as well, because you don't want to over-compress the dura, you don't want to expose the sigmoid. So these are the two things you need to keep in mind. So these are the advantages I already talked about. Adhere is the last device, which is the bone conduction device where there is no surgery. You just place the adhesive on the hardest part of your mastoid, and then you clip the adhere on top of it. So it kind of is a passive bone conduction aid. It takes care of those cases where you can't do the surgery and can't place the bone bridge. So that's where adhere comes into play. No age limit is the best part. A 15-day baby can also wear it. So all these cases with atresia, microtia, anosia, they all can go ahead with adhere till they are ready for a bone bridge at 5 years of age. Candidate selection, normal bone conduction. Single-sided deafness individuals who can't undergo a surgery and can't get a bone bridge can also benefit from an adhere. Yeah, okay. I'll jump on to the ABI, which is the last. So ABI is directly stimulating. It's bypassing all the peripheral system. It's going to the ventral cochlear nucleus directly, wherein the electrode doesn't look like an array. It is a paddle shape because the ventral cochlear nucleus is a region, and that's how you stimulate. These are the parts of it. It looks just like a cochlear implant, but the electrode array looks like a paddle. It's an electrode paddle. This is also MRI conditional and everything. Yeah, so these are the different implantable solutions.
We have just 3 minutes left for the question-answer session.
Sure.
So
I have the 4 questions. So these are the different types of implantable solutions and an implantable device available, because different hearing loss needs different kinds of devices. It's not one device that can fit all. Thank you so much for your attention.
Show the laptop here and then show this.
Thank you so much. Questions from the delegates? Any questions?
Ma'am, in patients with single-sided deafness, when you recommend a CI, so what is the patient's experience? One side having a normal hearing and other side having electrical stimulation. So how do the patients they report? Because if it is done in a postlingual patient, he must be able to tell you exactly what he's feeling or whether the sound is clear or it is confusing him. Yeah. How does things work?
All right, so while I answer the question, I have the other questions as well, because Dr. Sampurna wanted me to put the questions on here as well. 4 questions are there, and you can look at these questions. So, in single-sided deafness...
Am I just, Shailaja, 1 minute?
Yeah, yeah.
Neha, are you there? Dr. Neha?
Yes, ma'am, she is here.
Yeah, keep the chocolates and the gifts ready for the person who gives the right answer.
Okay, ma'am, I'll just check.
Okay. For the single-sided deafness individuals, studies are done in postlingual, like you correctly pointed them out, because they are the ones who can judge the quality perfectly well compared to how the normal ear sounds. So the previous implants and previous technology and all of that had this issue where you can't match, because normal ear has perfect hearing, quality is perfect. But with complete cochlear coverage that metal electrodes can provide, fine hearing sound coding strategy that we have, which mimics what happens in the normal auditory system, and preserving the structures while you do the electrode insertion. Electrode insertion is taking care of your structure preservation, hearing preservation, and fine hearing coding strategies giving you the quality you need. Complete cochlear coverage is stimulating all of the cochlea. So the studies that were done in these postlingual adults with single-sided deafness they compare the sound quality to be almost, you can say like in Hindi, they say 19-20. So it's almost there. And the brain kind of bridges the gap that is there. So it is possible now.
And this is from the first day or it happens with time?
It obviously takes time because, but it takes very less amount of time because you are utilizing all the neural structures that are there for stimulation. If you were to insert a shorter electrode array, that may not be possible.
And the condition in asymmetrical hearing loss, when one ear you are using a hearing aid and other ear you are using an
Cochlear
implant.
implant, yes.
So it remains same.
Yes, exactly. Because electrical stimulation is not a natural form of stimulation for our brain, for our auditory system. So for the auditory system to make sense of the electrical stimulation as a meaningful sound, it takes a tiny bit of time. So those cases, the rehabilitation will have to be good. Even the SSD cases, rehabilitation has to be good, home support has to be good.
And while the patient starts the rehabilitation, do they continue wearing the hearing aid during the initial sessions?
So it is on and off. It is on and off. So you only work with cochlear implant and then switch over to cochlear implant plus hearing aid. So that's, and also because 10 seconds I'll take to answer this.
Actually, we already have a speaker lined up here.
Okay.
Dr. Sanjay
So
Sastave
I'll
is
catch up
waiting
with
here.
you separately.
Yeah, we can continue.
So these are the questions. Sorry, do I go on or should I?
Yeah, please go
So
on.
the first question, cochlear implants can be recommended for which of the following conditions? All of the above. So who gets a chocolate? I'm sorry, I can't decide. Everybody gets a chocolate. Dr. Sampurna.
Please raise your hand.
I think I have arranged a better gift. There will be a free BP checking machine, a new kind of machine that is coming for this answer.
Yeah.
But you select whom to give. That I can't see from here.
Yeah, okay.
Rohan can do that. Rohan, be unbiased, Dr. Rohan, and select someone.
Okay, so you will have to select someone.
Dr. Shambhunath, is that you? Who is that? Can you stand up, please? I can see a cap. Yes, he must get it.
Okay. So I'll move on to my next question before you give the chocolates out.
Gift will be given later. Carry on.
Yes. Vibrant Sound Bridge is a mid-ear implant system, bone conduction hearing aid, bone conduction implant, or none of the above. Okay, you will have to choose the person.
Sir, aap ye se.
Okay, question 3. Bone conduction implant, bone bridge, that is suitable for which of these conditions? Single-sided deafness, congenital malformations of the external ear, mixed hearing loss followed by a higher but stable AB gap.
Please raise your hands.
Okay.
Please raise your hands and call out your name so that we can hand over the gift.
So sorry. Okay, so last question. Electric and acoustic stimulation system combines. Okay, so yeah, lady in the pink dress. Yes. Yes. I think Dr. Sampurna wanted me to check whether everybody is listening or not. Thank you so much for your attention. And can I get this?
An announcement. I know, first of all, I would like to thank delegates who are here from 8:30 on. Sachdev. He's a Principal Director ENT at Max Healthcare, New Delhi. Dr. Sachdev has 37 years of noteworthy experience in the profession. Regular operating faculty at the various state associations of otolaryngologists of India on varied subjects like skull-base surgery, surgery for snoring, cochlear implant, endoscopy sinus surgery, and many others. Worked as a director ENT Fortis Healthcare 2006 to 2010. Worked as a consultant at ENT Indraprasth Apollo Hospital from 92 to 2006. Sir has co-authored many books on endoscopy sinus surgery and many others. So I will not take much time of our next speaker. So over to you, sir.
Thank you for such kind words. Good morning, all. Very grateful to the organizing committee, Sampurna Ghosh and team, to organize such a brilliant conference. And also the weather was made to order. Thank you so much. We came out of Delhi with all the sweat and heat and really enjoyed ourselves. A lot of learning today and yesterday. Thank you again. And I'm going to talk on this bone-anchored hearing aid, bridging the gap between hearing aids and cochlear implant. History is a great teacher, so it goes back 1500s. The Italian Girolamo Cardano developed the first bone-anchored hearing. He used a rod placed between somebody's teeth and attached it to a musical instrument. Look at the innovation. Enabling a person to hear, with a hearing loss, to hear music. He was the one who first was to state that deaf people could learn to read and write without learning how to speak. This works on a principle of osseointegration, so we must understand what osseointegration is all about. Osseointegration initially occurs over the course of 4 to 6 weeks. So that is the lag period. So once you put an implant in, you can't do anything for 4 weeks. Many factors influence successful osseointegration, including the material, macro and micro structure of the implant, the quality of the bone at the site of implantation. And it is critical that the implant remains completely immobile during the initial period of osseointegration. In 1977, Mona Anderson became the first recipient of bone-anchored bone conduction implant, and Baha's surgery was only approved by FDA in 1996 for adults and 1999 for 5 years and above children. Now we're going to talk about Baha Ossea, which is the new toy in the market. The Cochlear Ossea system is an active implantable bone conduction system that uses digital piezoelectric stimulation. So that's an important factor, and we'll dwell on it a little bit more as the time goes by, to bypass and send sound directly to the cochlea. The piezo power transducers has high gain where it is needed most, with a fitting range of up to 55 decibel. So this is the gap that we are covering between the hearing aid and the cochlear implant. This helps patients to understand speech, especially in a noisy situation like restaurants, social events, or classrooms. So this is a challenge earlier, isn't it? So what are the indications? Would be exactly almost similar as what Medal was talking about, the bone bridge, but more or less overlapping. The Baha soft band, which was developed in was an introduction for children who cannot be implanted because they're less than 5 years of age, and they're just newborn with atresia, microtia, no canal, nothing there, but they will need some kind of a hearing, especially if they're bilateral. So they can be given these soft bands, which is a non-surgical way of giving a hearing, and this will be taken up till the child is grown up enough to get a proper implant. So other indications are congenital oral atresia, microtia, where there's an absence of external auditory canal. The infection has either caused it, there is a canal stenosis, or patient has practically undergone a lot of surgeries where the canal wall down procedures have been taken up, and the air cavity is still discharging, and obviously you can't put a hearing aid there, or the myotoplasty is too large for a good fit for a hearing aid. These are the conditions where you'll think of Ossea Baha technique. Of course, there will be other indications like cholesteatoma after the surgery, chronic suppurative otitis media, otosclerosis, where diseased eardrum or middle ossicles are not able to conduct. So this actually bypasses the normal hearing mechanism. So it doesn't interfere with the normal hearing mechanism at all. You put the implant at the back of the hearing mechanism on the cortical bone, and that's it. Nothing is done like a cochlear implantation or any transducer going onto the incus or anything. Nothing. Just put it behind the ear, and it will work in a perfect manner. So there are indications for single-sided deafness. The candidate should have a normal hearing on the contralateral side, because what you're doing is routing the signals onto the normal side. So again, like the lady just before me said about the shadow effect, that covers the shadow effect. because their patient will be able to hear from that ear, and the sound is going to be vibrating onto the normal cochlea. So the air conduction thresholds of that normal ear should be less than 20 decibel. So that's important. So for single-sided deafness, the sound processor picks up sound on the deaf side, sends it via bone conduction to the contralateral intact cochlea. In this way, the head shadow effect is eliminated, leading to improved speech understanding and speech awareness. And the advantage of having a BAHA vis-a-vis any other technology is that we can give a BAHA trial, especially in adults. They would know what they are going to go into. So they will actually be able to appreciate, yes, this is what I'm doing with a hearing aid, and now then when I'm going to get a BAHA, so you put a soft band, let them have a trial for a day or two, let them get aware of the fact that they are certainly much better off than hearing aid. So that is an advantage which we feel is certainly, and also for medical legal purposes, is a good documentation. Patients themselves will say, yes, there is a remarkable difference, and I don't think I would mind going through the procedure. So relative contraindications are child, of course, less than 5 years because the bone hasn't developed as yet, but these patients can be given soft band till the time they are 5, and then you can get them operated. A relative contraindication also exists for patients with bone abnormalities like osteogenesis imperfecta, Paget's, severe osteoporosis, brittle bone, osteopenia, medical conditions where there is a lot of radiation being given in that area and the bone is very brittle and may not be able to have that osteointegration, which is possible, which has to be mandatory for this kind of an implant. Smoking and chronic steroid users can also have a problem in the bone bed. So let me go through this testimonial. They are playing, but nothing is happening. Just a glitch, sorry. Time out, please, as you do in basketball.
I'm Amit Chandra, 65 years old, and I'm a patient of Dr. Sanjay Sachdev. I have a very active lifestyle. My ears were my best assets. I lost my hearing in my right ear a few years ago. In August 23, I had a severe left ear infection and I lost most of my hearing. The infection showed up in no tests at all. I went through all kinds of medication for months. There were varied opinions by several doctors, and I'm glad I stayed with Sanjay. My life came to a grinding halt and the world around me shut down as I went into total silence. It had a severe psychological impact on me. Panic attacks, anxiety, depression, sleep loss. I went in for psychiatric treatment also. Sanjay then suggested a BAHA. I tried a headband BAHA for several weeks, which seemed like a very good option. While the treatment of the left ear was a long journey and the left ear still had a reasonable bone conduction threshold, and to bring normalcy to my life, I decided to go in for an Osher implant on the right side to conduct to the left cochlea, a very complicated case. I asked all kinds of questions. Sanjay and his team were extremely patient and understanding, giving unbiased pros and cons for me to make up my mind. I had the Osher implant on 1st February 24. It took me a while to get used to it as the brain had to adapt to it. It had to be reprogrammed a few times. It is a very effective solution when there is poor air conduction and hearing aids don't work. I started to hear again. It changed my life. I'm now on a solo 8,000-kilometer road trip across the country. Thank you.
So this gentleman is actually a sound expert. He does acoustics for most of the large conference halls, cinema halls, and a very, very popular, and this is a very niche area, isn't it? So he had to use his ears, and that is why you could appreciate that he knew a lot about sound and a lot about air conduction, bone conduction, and the science behind it, because he's himself a scientist. So this testimonial not only gives us the insight to what the osseous can do, but also the indications. You could understand the psyche behind it. I mean, a man who was so active suddenly could not hear, and the psychological trauma that he had to face. And then things changed for him, which is good.
I'm Amit Chandra.
Sorry.
60.
So this is another testimonial, and you can see his face.
मेरा नाम अंकित गोयल है, मैं रोहतक हरियाणा से बिलोंग करता हूँ और पिछले 9 महीने से मैं बाहा इम्प्लांट को यूज़ कर रहा हूँ। उस इम्प्लांट के बारे में बताने से पहले मैं अपने बारे में बता दूँ कि जैसा कि मेरा ये राइट ईयर है, ये राइट ईयर का मैंने 2 बार ही सर्जरी कराया है, जिसमें राइट ईयर पूरा का पूरा डैमेज हो गया था और लेफ्ट ईयर मेरा बचपन से ही डैमेज है, जो मैं एट द एज ऑफ 16 ईयर्स की एज से लेफ्ट ईयर को नहीं सुन पा रहा हूँ, सिर्फ राइट ईयर से सपोर्ट कर रहा था अपनी हेयरिंग को। लेकिन एट द एज ऑफ 34 मुझे राइट ईयर में भी इन्फेक्शन हुआ एंड उस इन्फेक्शंस के अंदर मेरा पूरी तरह से हेयरिंग लॉस हो गया था। देन उसके बाद मैं डॉक्टर संजय सचदेवा जी से मिला और संजय सचदेवा जी ने हमें पहली बार बाहा इम्प्लांट्स के बारे में बताया। तो पहली बार हमने भी सुना था तो हम भी उसमें शॉक हुए थे कि कैसे एक पर्सन बिना हेयरिंग हेड के ईयर में लगाए हुए सुन भी सकता है उस चीज़ को, क्योंकि हमने आज तक ओनली हेयरिंग एड्स के बारे में ही सुना था। तो जब 6 महीने के बाद पहली बार हमने बाहा इम्प्लांट यूज़ किया और मैंने फील किया कि मैं भी और लोगों की तरह, एक नॉर्मल लोगों की तरह सुन पा रहा हूँ, बात कर पा रहा हूँ, या मुझे भी कॉन्फिडेंस आया कि मैं भी एक नेचुरल मेरी लाइफ में आ सकता हूँ फिर से। तो देन उसकी जो भी पॉजिटिवनेस थी सर ने ब्रीफली हमारे को बताई, उससे क्या क्या बेनिफिट्स होंगे। और आज के टाइम पे जैसे मैंने लास्ट टाइम अक्टूबर 2023 में आपका सर्जरी कराया था और आज जब हम आपसे डिस्कस कर रहे हैं तो जुलाई 2024 में है और मेरा लेफ्ट ईयर आज भी काम नहीं कर रहा एंड ओनली राइट ईयर पे सिर्फ टोटली जो बाहा इम्प्लांट ओशिया इम्प्लांट है उसकी सपोर्ट से मैं सुन पा रहा हूँ, एक नॉर्मल लाइफ अपनी जी पा रहा हूँ, जिससे लोगों से मैं एटलीस्ट 6-7 मीटर के डिस्टेंस में अप टू 10 मीटर के डिस्टेंस तक सुन भी सकता हूँ, बातें कर सकता हूँ या कहीं मीटिंग कर सकता हूँ, एटलीस्ट शोर में भी कंफर्टेबल होते हैं। तो मैंने सर से इस इम्प्लांट को लगवाने के बाद एक नया जीवन जो है वो मुझे मिला है।
So basically again another indications quite clearly seen. This patient has facial palsy on the left side, so got operated there. There was a large cavity discharging. The right ear had to be operated 2 times and still the hearing, of course the left side had gone earlier, the right side went because of 2 repeated surgeries. And this is the best thing that we could offer. And the advantage again I would emphasize, re-emphasize, is that he had used soft band for a week and made sure that his hearing is going to improve. So when you use a soft band and the patient goes back home with the soft band, he realizes that his hearing gets much better, and whatever hearing is with the soft band, they would at least with osseous have 23 to 24% better hearing after the surgery. Because obviously that is a soft band onto the skin, but when you put the implant, it is under the skin. So this is the operative instrument, and this is the operative technique. You have different incisions. More important is to see the thickness of the bone. Let me just go with a surgical step here. So you just put the osseous implant there, and at the level of the external auditory canal, go about 50 centimeters, 50 millimeters behind the margin, and you put the implant, draw an incision that you want to make. The incision is your choice entirely, but only thing is that it should be 15 millimeters in front of the implant margin, so that the incision is not overlapping the implant. Then thickness of the skin is very important before you give local anesthesia. So that has to be measured at 3 different spaces where the magnet is going to be. This is measured. It should be less than 7 millimeters at every point. And once you've done that, So you just see different 3 points and measure it. You have a measuring rod, or you can use a scale, whatever you want to use. It should be less than 7 millimeters. If it is higher than 7 millimeters, as was in this case, then you have to thin down the skin so that the magnet does not get displaced when you're putting it and is not jeopardizing your surgical work. So here we go again, a little higher, a little, what's happening? Can you make it fast forward? Can you make it fast forward? No? Can you make it fast forward? Can you make this fast forward? No? You can't? Why won't you? Can you make it fast forward, please? You have a cursor, you can. It's not working. Can you take it to this end? My time is up. You can go to the surgery, then main surgery, and then show. There is a better. Is it coming? Yeah. So then, of course, after measuring that, you will give an incision directly onto the periosteum. Make sure that the bed is open so that you can put the screw. That this is how you measure the thickness of the skin. Here in this case it was about 9 millimeters, so you have to thin it down. And once you've done that, then you make sure that your implant is not seen. This is the implant which is going on the template, and then you have a drill. Before you drill, you make that bed absolutely smooth. And then you drill with a marker there to make sure that it is absolutely at right angles to the skull, and it should not go, because osseointegration has to be there. Like I said, the screw will not move. So that's important, and lot of irrigation, because you don't want to heat up the bone. Once that is done, you just put the implant in and screw it up with this screw. This is a torque measuring jig. So that torque is always at 25 joules per square centimeters, and that will make sure that the implant is absolutely steady, and then you just suture it up. So fairly simple, straightforward surgical approach, and with very, very minimal complications, so to say. But just to complete the list, there will be some complications, like you can have a hematoma, you can sometimes have abscess, but if you maintain the sterility, there will be no problem. There will be times when you're actually making a burr onto the skull. You might get into a vein sinus or into the dura. Then you can change the place of your the burr bit, and few centimeter, 1 centimeter here and there, you will invariably get another space where you can do the same thing. Just make sure that the irrigation is copious amount when you're putting that, when you're using the drill. So I think, thank you so much. Sorry for the glitch. I couldn't.
Any questions from the delegate? You can raise your hand.
In patient with facial palsy who was operated twice and had SNHL in the other ear, which side did you implant?
So we implanted the one which was operated 2 times. The reason is the other side was deaf for a very, very long time. And when we were doing Baha trial, we always do it on both the sides. So we ask the patient which side is better. So that is the advantage of using a soft band prior to deciding So patient tells you, okay, my right side seems to be better and I think I'll go for an implant on this side. Which advantage you will not get in any other technology. So that is actually chosen by the patient himself. So that is the advantage that we find in this kind of a situation.
Previously, the Baha had the problem of extrusion and osteomyelitis, infection of the bone. Did you see any?
So no, we didn't see any. And earlier when we were doing Baha, we were doing percutaneous. And that is the time when we saw a lot of problems because there was a jutting pin there, which was causing a lot of problems in a weather like Delhi with a lot of sweat, heat, temperature variations, and hygiene. So that area was either getting infected, and a lot of them was sometimes getting even covered up by the bone, by the skin, and getting displaced, getting hidden from there, and we had to again make a hole and get the implant in. But after we started using transcutaneous, Baha 2, certainly Ossia is giving us a benefit of about 16 to 17 decibel, more than Baha 2. So that advantage we see certainly, because once we were giving soft band, and invariably the soft band is for Baha 2. So if the patient is happy with Baha 2, then he'll certainly be happier with Ossia, which is like 16 to 17 decibel, much more effective than Baha 2. So with Baha 2, if the patient is happy, we are very happy to tell him that Ossia will work better. And that advantage I think we have in this technology, where we can decide, or the patient himself can decide whether the technology is going to work for him or not.
We still have 34 seconds. Any other
we
question?
do? I was just rushing through. I did not know that I have such. Yeah, please.
Sir, how many cases till now you have done, and what is the most common complication you have faced?
Most common complication?
Yeah, you have faced.
No, like I said earlier, we were doing that percutaneous. We were getting complications quite a high number. We did about 8 of them, and so we were not very happy because of Delhi weather. The sweating and the skin erosions and irritation was causing a lot of problems. Patient kept coming to you, and in 3 patients there was skin overgrowth over the abutment, and then we had to make a incision again. So we're not happy. Transcutaneous was better, but Ossia versus Baha 2, there is a remarkable difference. We've done about 7 now with Baha 2, with Ossia.
With no major.
And of course, I got the best 2 to show you. I won't show you the ones which are not too happy.
So there was no case of infection in those 7 cases?
No. So one of them is about a year old and one of them is about 9 months old. So till now we haven't got any problems at all.
Thank you.
You have to choose the magnet also. The magnet should not be very strong. And that is why the thickness of the skin is very important. So that is why we take time, and there are times when you have to really thin it down and make sure that the thickness is just right. Not too less, because too less will again cause a necrosis with magnet, and not too more, then the magnet will not stitch. So for the magnet to sit properly, the thickness is apt. So 6 to 7 millimeters is something which you really need to address to.
Thank you.
Thank you, sir.
Thank you so much.
May I request our moderator of this session, Dr. Rohan Gupta, to felicitate our speaker, Madam Shailaja Timaraju. Thank you so much. Now I would request our speaker, Dr. Sanjay Sachdev, to felicitate our moderator, Dr. Rohan Gupta. Thank you so much, sir.
When on, tell me on.
Now we end this session. I would like to thank our moderator, Dr. Rohan Gupta and Dr. Sampurna Ghoshni
1 hour.
for overseeing the session, and Dr. J.M. Hans for the live demonstration of cochlear implant surgery at Medicover Hospital, and the entire team supported by Dr. Neha and others. Thank you.
On.
Now we move on to our next session. Over to you, Neha.
Ms. Jyoti, am I audible?
Yes, ma'am.
Yeah. So after a very a session of very advanced otology, which was all about cochlear implant, middle ear implant, and all implantable device, we are moving to so-called basic surgery. But again, our bread and butter. When we start MS, we all are taught to do tonsillectomy first in the first year, and then we move on. And still in the practice, tonsil adenoid will never go out of the demand. And we are going to show one case of pediatric OSA now, which I will demonstrate. And I request Dr. Aishwarya Mathur to describe about the case, and then we'll move on directly for the surgery.
Good morning, everyone. Am I audible?
Dr. Neha, can you hold for a minute? Sorry, Dr. Aishwarya, please hold for a minute. Let me call upon the moderators, Dr. N. Venkatram Reddy and Dr. J. Shanmuga Priya. I would like to moderate this session. May I introduce our moderator, Dr. N. Venkatram Reddy, Professor in Bhaskar Medical College and Senior Consultant in Ma ENT Hospital and Global Hospital, Hyderabad, and Dr. J. Shanmugh Priya, Senior Divisional Medical Officer, Railway Hospital, Secunderabad. Thank you so much for coming. Over to you, Ashwi.
Good morning, everyone. I'm Dr. Aishwarya, and let me just describe the case that will be operated by Sampurna ma'am today. This case is of a 6-year-old girl who presented to us in our OPD with chief complaints of severe snoring. And she had restless sleep. She was unable to sleep in supine position with repeated apnea episodes observed by the mother. This has been there since 1 year. On examination of her throat, it revealed a grade 4 tonsillar hypertrophy, and as like we do for every other child in our OPD, a diagnostic nasal endoscopy showed a grade 4 adenoid hypertrophy. Ear endoscopy was normal, and repeated multiple medical management failed. Hence, we are planning for the tonsil adenoidectomy today. Thank you.
Before starting, I want to thank my wonderful anesthesia team, Dr. Sandhya, who is a specialist in pediatric anesthesia, Dr. Venugopal, a senior anesthetist who are giving all the ENT cases in robotic center, Dr. Harish, Dr. Tejasvi, and Dr. Kiran. On a day of Sunday, all of them have agreed to come just to help to run the 2 pediatric cases smoothly, and I am really, really obliged to them. Moving on to the case, first I want to show you the coblation wand. I would say the coblation wand is not correct. That is by a brand name of a particular brand. We should talk more about the technology, which is RF, which is radio frequency, and it should be called radio frequency ablation. Can I request our AV team to show the wand which I am showing now? So this is the wand. I am using Bond's radio frequency technology, and this is the tonsil wand for them. And before you start the surgery, suction on. Is the suction on? And before the surgery, you always check the glow. Can you see there is a yellow glow?
Yes, yes.
So this yellow glow means that you're actually getting the advantage of the radio frequency field. And what is this flowing? This is nothing but normal saline. And as you press the paddle, there are 2 paddles, yellow and blue. The yellow paddle is for coblation and the blue paddle is for coagulation. So as I press the yellow button, don't increase the pressure, please keep it normal. And then you get this glow. So I also want to show you the settings of the machine. You can see there the machine which has been set in 8-4. Normally when you put the tonsil wand, the setting will come 7-3. You can increase if you want. And I always use a pressure bag on the saline bottle. That's a optional thing, because when I do adenoid, I almost do under the water. So my case goes more smoothly, and a lot of people ask me about blockage of the coblation wand. If you follow this technique, the blockage will be minimum. Venkatram sir and Shanmukpriya ma'am, thank you so much. I am honored that you are moderating my surgical session.
Yes, we are here with you, Dr. Sampurna.
Yeah. So, Venkat sir, I want to ask you, this is the tonsil you can all see, like a grade 3 tonsil.
Yes.
And I was thinking that this is a 7-year-old girl, but tonsil is not infected one. So I take the decision, if there is a feature of chronic tonsillitis, I will definitely do proper classic tonsillectomy. But if it is only for OSA, which the tonsil is causing a space-occupying thing, then I will go for subcapsular. So I was thinking, should I demonstrate one side classical and one subcapsular, sir?
Sure.
Right? Should we go like that?
Yes, you can.
Okay, sir. Okay. So first I always pull, and classical way we want to see where the tonsil is ending, and I will start from the superior end. Increase the water a little bit. So you can all see.
You're working.
Is the transmission good?
Yes, you're working close to the antipillar.
Yeah. So we got the plane. You can all see the capsule.
Yes. Which microscope you are using?
It's a laparoscope.
Laparoscope, okay.
Yeah, to give a better clarity.
10 mm?
10 mm, yes.
10 mm laparoscope.
Okay. Yeah. 10 mm 0-degree laparoscope.
It is absolutely looking like a microscope. We use microscope generally.
I don't use anything, just for the demonstration I took this.
Yeah, I think some are doing with a naked eye. What is your message to them?
I think if I say do a tonsil with microscope,
no,
that will be
you are watching in the monitor.
Impractical.
Are you watching in the monitor and doing?
No. I am doing under the, like how you do normally, classical.
With the naked
That's
eye.
why I'm asking you that how is the transmission, how it is.
Transmission absolutely fine.
Yeah, because I am not seeing the monitor. I am doing how I do normally everybody does with headlight, same way.
Yeah. You are doing with the naked eye.
In fact, I forgot to take the headlight with the endoscope light.
Yes.
Only I started doing. Someone will give me the headlight, please. Please add the headlight. We are using Storz Spice camera, and that Storz light itself was so good, so I forgot to take the headlight. Now somebody is adding.
Yeah, we could see it.
Yeah. Light on kar do. Yeah.
So you are doing surgery without magnification, you mean?
Yes, without magnification.
Without magnification, with a 10 mm laparoscope for the viewers here down in the auditorium.
Yes.
And normally you do so every time? You don't use a microscope at all?
No, I don't use microscope at all.
Okay.
I know, a lot of seniors recommend that because they say the plane.
No, I recommend that.
Yeah, I know. Maybe it is true, but I think it's too cumbersome. It takes time for me, and I get good result by this. So.
Okay. See, adenoid tonsil are done in different ways by different surgeons. It's all individual preference and choice. But what I could see with using microscope is you can see the tonsillar cotyledons very, very clearly.
Fast. One cotton ball, please. One ball. Yeah. So the tonsil is out. One bleeder is there. So now I will use the coagulation. Coagulation I use bare minimum. The other paddle, the yellow paddle should be used more because the main reason of radiofrequency use is that we want less tissue damage. That is the difference between monopolar, bipolar and this. Sister, can you give me the retractor? So if you keep on buzzing with the coagulation foot paddle, you don't get that benefit and patient will have more pain. So use that bare minimum. Only few spots at the end. the whole dissection will be over with the yellow paddle only, and it takes very less time. So yeah, so here there is a bleeder. Now only I will use the quag, not much. Can you reduce the water a little bit? Sister, reduce the water a little bit. So the coagulation is here, you have to take full contact, and the suction will show you the exact spot. After taking the full contact
for few seconds.
Few seconds, right, yes. Sir, right. Unlike the dissection where we
Not
don't take full contact.
Not touch and go, but say about 4 to 5 seconds.
Stay there for few seconds, right.
Yeah.
Water reduce little bit. Yeah, so it's done.
Dr. Sampurna, did you have any local infiltration before the procedure?
No.
You never have the...
Infiltration for tonsil?
Yeah, usually some surgeons, they infiltrate.
No, I will infiltrate after the surgery for immediate pain relief. Now I will infiltrate.
Okay.
Once more, please. So I will move on to the other side. That side I will try to do the subcapsular tonsillectomy. Not this one. Dr. Elena is holding the scope and she is moving to the other side now. Subcapsular is so comfortable for the child in post-op period, there will be zero pain. Believe me, some parents have asked me next day after doing subcapsular tonsil adenoid, when the child is jumping and eating, they're behaving normal. They asked me, did you really remove it? It is so comfortable. So this is, I'm using the other side of the dissector and pushing it from here so that the part which is protruding and which may contribute in the obstruction part, only that part I will remove with the coblation. Again, I am using the yellow paddle, not the blue paddle, and start doing like this. In between, in the audience, delegates, anybody wants to ask me about the technology or anything, please feel free to ask or pass on the question to Madam or Venkat sir.
Any questions, beginners, please come forward and just tell me. I just transmit into the theater.
This is the throat pack. Okay. Am I doing very fast? I'm not sure, but I am doing fast because I know Dr. Kalpana and Dr. Nishi, they're waiting for their talks, and there are many national speakers who have their flights, so I'm doing fast. But questions are all welcome. While doing only, I will answer. Sir, yes, tell me, sir.
Sampurna.
Venkat sir.
Yeah, there is some senior delegate asking one question that any incidence of bleeding postoperatively by intracapsular technique?
Sir, louder please. I couldn't get it.
Any incidence of bleeding postop in the intracapsular technique?
So, sir, I am doing this kind of technology I am using since 2014. 10 years now, and I stopped using the cold still technique. In 10 years, I have done around 400 pediatric OSA cases, and I got only 3 patients in 400 where I actually had to take them to OT to control. There was a big clot in the lower pole, or the child came with active bleeding.
Round about 1%. 1% roundabout.
Yes. And others, sometimes they came with little blood-tinged sputum, but nothing serious. I said continue the hydrogen peroxide gargle or take the soft diet for a few more days, and it controls. And as now, if I think that maybe in those 4 cases, few I took out of my panic. They were only big clots sitting there. If I see now at this stage of maturity, maybe I wouldn't have taken them as well. So this is done. Subcapsular is done.
Those were cases of tonsillotomy or tonsillectomy?
What?
That is in intracapsular, the bleeding complications which you had?
Intracapsular? No, I have never seen bleeding in intracapsular. Those were classic complete tonsillectomy. This side I kept the cotton because I believe near the superior pole that oozing has completely not stopped. So I am checking once more. Yes, here it is. One more time I will buzz. Yes, now I am happy. And you can see the vessel also here. Elena, can you show the vessel? This is the vessel.
Yeah, we could
This
see that.
vessel I am seeing, no? Yeah, that I will buzz. Peritonsillar vein. Okay.
One delegate is asking, how is this differs from a cautery technique, bipolar cautery technique?
Okay, any cautery will generate more heat. The heat produced by RF is 1/10 of the heat, and it is more precise. The surrounding tissue damage in different papers they have shown that the depth of the heat penetration is much less in radiofrequency ablation. So if you, maybe I will put this question in a different way, that why we need to use this, why not do classical way? May I answer like in that way?
Yes, you
if
can.
you ask me that, do you really need coblation for tonsil? Maybe no. If you are very good in classic dissection technique, do it. But I deal with cases who are even 3 years old, 4 years old, and I cannot allow even 10 cc blood loss in their body.
True.
So
Absolutely
I want
true.
this white field, and then I will do like this. And recently I was operating on a Somalian lady with a very bad chronic tonsillitis, fibrous tonsil, and a hypertensive. Even after giving all the drugs on table, the BP was 200/100. Still, I could finish the tonsil exactly like how I did today. 5 minutes, 5 minutes, 10 minutes done in a BP of 200/100 and no bleeding at all. So these are the cases. So
I think, Dr. Sampurna, there is a lot of tonsillar tissue left on the left side.
Yes, I don't want to remove more
You
here.
can, you can take out some more so that it will closer to your capsule.
Okay.
You don't
As
dissect
you
the tonsil,
suggest.
but you have to take out much of the bulk.
We'll do that.
Yes.
So this part you are talking about.
Yes. And as far as you said, coblation is a big invention, I would say. It's a very big invention of the century, like microscope is an invention. Coblation is also a big boon and invention. So because of coblation, we can operate the youngest of the young one. I operated 1 year, 2 months, that is the youngest child with the OSA. The adenoid, only adenoidectomy. So in a otherwise scenario, so in the ester years, I think we are not dare enough to touch because of anesthesia complication. Anesthesia has improved, and we are bothered about more of a bleeding adenoid. So that has, the coblation has given a big advantage.
Sir, I removed little more as you advised, and
Yes.
I am moving to the adenoid part now. And while you were speaking, I have given a little bit of local anesthesia, which is a mixture of bupivacaine and lignocaine 1:1 ratio in the tonsillar fossa. Again, is it necessary? No, but I have seen the children after extubation, they will not cry so much if you give this, because they will be very panicked anyway during extubation, and then if you can give some pain relief, it works well for me.
What is the site of infiltration, Sampurna?
Just around the pillars or in the fossa, but you make sure that you withdraw and you are not injecting directly into any vessel. So as continuing the other delegate's question, I don't know whoever asked, thank you for the question. So you're giving me the opportunity to describe why you need to do more tonsil adenoid with coblation. So as you go for critical cases like how Kranti Bhavana ma'am showed yesterday, using in JNA or using in skull base or doing a larynx case, laryngeal papilloma, before that, you have to learn the technology, right? And nothing like doing tonsil adenoid. This is your learning step. So do, please brush. external camera, please show how the sister is cleaning. So I keep a toothbrush to clean the wands. If there is any tissue, like this, gently remove it. So what I was saying that, yeah. So that is why one should do more tonsil adenoid with the coblation, so that when the time comes to use for other critical cases, you are confident and your hand is ready.
Can you focus the camera a little bit?
Oh, okay, sure.
Little bit of focus.
Is it okay?
Yes, absolutely fantastic.
So I'm using a 2.7 mm endoscope. This one is a Chinese scope because my stored scope is 4 mm. And what I have done, I have put a feeding tube through nose like this, which has come out from the palate. And Dr. Elena is pulling it up so that when you are doing the adenoid, you never injure the soft palate. You can put it on both sides if you want. I saw today by putting on one side it was enough, so I will carry on. And there is a mucus sucker in her hand through which she will give me saline flow on and off, so that I don't have to take out the scope multiple times to clean, because that's a wastage of time. Okay, so I'm starting now. The setting is 8-4, and you can see all the electrodes and see how I'm doing. I'm starting from the corner. You need very good suction. That is very, very important. And a good water flow. It's a balance game between the suction and water flow. Then everything will be like Snow White. No blood, all white. Beautiful. I love seeing this white thing. And you keep a couple of video with you in your OPD computer, so that when parents come, you can show them this is how it is done. Lot of fear factor will go away immediately, and they will agree for it. Lot of time you see parents who, even though the child is suffering badly from OSA, after your counseling, they will go to homeopathy, other people, pediatrician, they will take advice from neighbor and try all kind of things, but not come for the surgery. So we should not get angry at them. Think yourself as a parent. If you are the parent, obviously you will not like putting your child under the knife at tender age. So our duty is to assure them and make sure, and don't think that, you know, parents are, they don't know anything. Nowadays, people are very, very well informed. Don't judge by their appearance. So you tell them that we are using this equipment, it will be safe. I want to thank our moderator, Shanmukh ma'am, because this child was actually sent by ma'am. The child came to railway hospital, and the parents, madam sent me another case as well, which I promised I will do within next few days. And surprisingly, the father told me that I wanted the case to be done by coblation only. So a lot of people are well aware now. That is why we have to be well equipped, learn all the technology. Then if you don't want to use, it's okay. You use in the patient those who have budget. But learning is important, and to learn and to keep your hand ready, you have to keep doing more cases, and tonsil adenoid is the learning stepping stone. So my one side is done. You can see this is the passavance ridge. And I always make sure that I clear this area. These nooks and corners, these will be the reason of recurrence if we don't use. After doing so much, my wand is getting little blocked. So I will show you how the sister, my scrub nurse is Miss Sarita, how she will clean it. AV team, please focus on sister's flush and clean, please.
How do you decide that all the adenoid tissue has come out? Because I still see...
I will show you. I have not finished yet. I will show you that point. I will reach the buccopharyngeal fascia, completely delineate the fascia, then only I will end.
Okay.
While the sister is cleaning, we can discuss little bit. That's why I took a break.
There is a question from...
ending point,
Dr.
The
Sampurna,
ending point is, 1 minute, let me finish this, ma'am. The ending point is you have to clear all lymphoid tissue from coana to passavant ridge, from one side eustachian tube to other side eustachian tube, and the depth will be nothing less than buccopharyngeal fascia. Ma'am, please.
There is a question from delegate Dr. Vivechna. In cases of unresolving chronic adenotonsillitis, is there any role of ruling out allergic airway disease for effective and better post-operative management?
Ma'am, repeat once, slowly.
If there is unresolving chronic adenotonsillitis, but probably it is a failed post-surgery, is there any role of ruling out allergic airway disease?
Unresolving adenotonsillitis?
Means probably she meant that it should be like a recurrence of adenoid or adenoidal hypertrophy.
Ma'am, can you give the mic to the delegate to ask directly? I'm not clear about the question.
Doctor. Yeah, she is there.
Yeah.
Ma'am, in cases where adenotonsillitis is unresolving with medication, is there any role to rule out allergic airway disease before doing the surgery?
Adenotonsillitis, I am not sure exactly what you mean. Do you mean recurrent URTI by that?
Even in allergies, ma'am, allergic airway disease, there will be constant chronic adenotonsillitis unresolving with medication.
See, for me, I don't take the decision only by X-ray nasopharynx or only by one symptom. I do a very detailed analysis of the child. So my team will first take the history, which will include the number of URTI per month, the recurrent episode of tonsillitis. If tonsillitis, is it really strep throat or just a viral infection? And then I will ask the parents personally about their sleep history. Do the child have regular mouth breathing or occasional mouth breathing? Is it snoring? Is it apnea is there? I also sometimes when I'm not very confident from the history, parents are fumbling, I tell them come back after 1 week with a video of how the child is sleeping. Because from the video I can pick up very well. And then in my mind it will be clear that how much features are obstructive features and how much are only allergic. Accordingly I will take the call. If I see there is a lot of obstruction, I will definitely go for surgery. But at the same time, I will counsel the parents that even after surgery, some anti-allergic management will continue and you have to come for regular follow-up. Is that clear?
Yes, ma'am. Thank you.
Increase the water flow, please. Saline flow increase. Tasim, I'm talking to you. Saline flow increase, please.
Yeah, what I would like to add here is that even though the child may be having a coexisting allergic rhinitis allergic rhinitis could be the cause for adenoid hypertrophy, one has to give medical management in case of allergy, that is intranasal corticosteroids, mometasone in case of children, or Montelukast with whatever levocetrizine. And even after 3 months, if the adenoid hypertrophy is not resolving or the child is having symptoms of tonsillitis adenitis, we can go for surgery. At the same time, the coexisting allergy also has to be treated. But one does not rule, it does not contraindicate the surgery. Allergy does not contraindicate surgery if the obstructive features are there, as Sampurna clearly said. So it is not one respective of the other. Surgery can be done if the obstructive element is there, despite 3 months of medical management.
Yeah, Shakuntala ma'am, thank you.
For your intracapsular tonsillectomy, when do you, how do you know that you have reached the end point?
Intracapsular tonsillectomy can be done up to the tonsillar capsule. When you see the, again, buccopharyngeal fascia, then you can stop.
Okay.
Coming back to allergies.
There are many children, when I don't do the tonsil also, if I see tonsils are really not that big, it is only the adenoid causing obstruction, I do only adenoid. So all decisions should be customized. There is no rule key, everybody will undergo tonsil adenoid. I want to stress on one point here that all this child, I always check their tympanic membrane and I do a impedance. That has become a practice of mine, and so 50% of these kids will have OME, 50%. And sometimes I get pediatric cholesteatoma as well. Shanmukhpriya ma'am, if you remember, we did a case together in Railway Hospital. We planned adenoid. As my habit, I checked the year and the pediatric cholesteatoma was diagnosed, which madam did later.
Yeah, later we did canal wall down.
Yeah, so make it a habit. Many times parents don't give the history. You check the ear, always, always.
Coming back to allergies.
Same applied for cochlear implant. Before cochlear implant, I check for the adenoid as well.
Yeah, coming back to allergies, sometimes it's a good practice to send a little tissue of adenoid for histopathology to find out the cytological background, and that also will give you a lot of clue on what kind of cells are there, whether it is a neutrophilic or eosinophilic
Devashi
pathology.
sir, what is the time? Huh?
It's a point well taken.
How much time I have? I have 25 minutes more? Okay. Okay.
Sampurna, I had one more doubt here. Do you remove, like if there is excess lymphoid tissue on the torus tubalis, which might be obstructing the eustachian tube orifices,
Yes,
do you also?
I do.
Yes.
I do a brushing technique. I increase the water flow.
Yes.
I don't touch it directly from a distance. I will just do like a brush painting. So the tissue will be ablated on superficial level.
So can you demonstrate that in this surgery now for the benefit
sure,
of the delegates?
Sure. Is Kalpana ma'am there? Shakuntala ma'am, Kalpana ma'am is there? Okay, no problem.
Yes. Hello, ma'am. So can you just tell us the limits or the boundaries of the adenoids? Superior to inferior,
so
lateral?
This is the passavance ridge, and you can see the throat pack here.
Yes.
So the lymphoid tissues are ending here. If the child has a submucosal cleft palate, leave a little tissue here. Otherwise, still here, clean it.
Okay. And
Increase
superior?
the water.
What is your superior limit?
Now, look, this is the end. Can you see the fascia?
The buccopharyngeal fascia, yes.
Yeah, okay. This
Very
is the
well
level.
seen.
At one point, you do this horizontal movement with lot of water flow, and you see the fascia, and then you know, okay, I have reached this limit. Everywhere you don't have to, delineate in that way, but you will understand that, okay, I have reached that limit. I can see the fascia here and here, okay? And these are all dead tissue. If you have time, you can remove that slowly, but even if you don't remove, they are not going to recur.
But
And
in
there
case
is
of
another way-
Sampurna, in case
Just
of
1
young
minute,
children,
ma'am, 1 minute.
Yeah,
Another way to clean the coblation wand is dip it in a saline, like this. The kidney tray is full of saline. Dip it in this saline and keep the yellow button pressed so that the tissue which was blocking the electrodes will get clean.
yes, that's an
Another,
excellent tip.
Okay. And
yeah,
then look into
Sampurna.
it.
So
yeah.
this unblocking we do with a betadine solution. Betadine solution.
Okay.
A gauze placed over the betadine, and you can press it immediately. It gets clean completely.
I need lot of water flow here. Tasim, acha se water do.
So,
this is the polishing part I am doing.
Yes.
Like you can see the viable tissues are all gone.
Yes, the membranes.
I'm feeling the choana here. You can feel the choana. This is one end point. This is another end point. This is side by one eustachian tube and the other eustachian tube. And the depth is buccopharyngeal fascia.
Excellent.
Hello.
Shakuntala ma'am, you were asking something. I interrupted you. Please continue.
No, I was just saying from my own experience that very young children and those who have a coexistent allergic rhinitis also, one should be a little more aggressive and take out as much of lymphoid tissue as possible. Otherwise, they have a chance of regrowth. And it becomes a little embarrassing.
Younger the patient, more aggressive you have to be.
Because otherwise they can come back later after a year or so.
If you operate in a 10, 12 years old child, the chance of recurrence will be less.
Yes,
but if you are doing in a 4, 5 years, the chance of recurrence will be more.
Exactly. So almost subtotal removal is required in a younger child so that you don't get
I want to ask the delegate who asked for the ending point. Doctor, if you are there, are you clear about the ending point?
Yes, madam, there. And one more thing I've seen during doing adenoidectomy by coablation is we can see the palotopharyngeal contractions. Suddenly the passavance ridge contractions can happen. That shows that we are approaching the buccopharyngeal fascia. So even before seeing buccopharyngeal fascia, sometimes we can see this contractions.
Yeah, this is the buccopharyngeal fascia. Clear?
Yeah.
Yeah.
Sometimes we can see palotopharyngeal contractions even before buccopharyngeal fascia is seen. So that is another indication that we are approaching buccopharyngeal fascia.
So yeah, little tissue from this corner also I will clear.
Sampurna, any complications you have seen if you have accidentally injured the buccopharyngeal membrane and exposed the muscle?
Nothing happens. You see the muscle, you stop there. I have been training Dr. Neha, who is doing individually now, then Alina and Dr. Aishwarya, all of them, most of my tonsil adenoid cases they are doing nowadays. They are doing wonderful. Couple of times, even if they have exposed, what will happen? You have to identify and you have to stop. You don't damage further muscle. That's it. And you tell the parents that there may be slight neck pain.
Yeah.
Don't get worried and give the antibiotic for little more duration. And very important is a nice saline wash so that there is no secondary infection.
Yes, sometimes they may get foul smell post-operatively at the back of the nose because of the sloughing of the tissue. And if we accidentally injure the muscle or expose the muscle, then second post-operative week, the patient may come back to you with neck stiffness or neck pain. So you must identify that and give muscle relaxants for a course of 5 days and it should settle.
Shakuntala ma'am, I almost done. Once more I will take the wand and show that brushing technique. And somebody told me I'm doing very fast. So I kept everything aside and I want to focus only on the question answer session now. After that, I will do the finishing part.
Madam, we saw that endoscope was passed through the nasal cavity and the wand was passed through the oropharynx.
Right.
In cases where there is severe DNS, something like that, you cannot pass the scope. This happens in 2 small children. Then the alternate technique is passing the scope and the wand through the oropharynx, like our St. Clair Thompson's. So what is your comments on this?
It depends on the training. Like if Dr. Sandeep Dachuri and Dr. Ashok, my 2 colleagues, are there in the hall, they can say they regularly do in that way. I have not been trained to do through mouth cavity, but saying that, I never felt any difficulty in this way, because even if a small child has severe DNS, I can finish the whole process from one side. I don't enter into the other side, because you can see in small child both the eustachian tube. So by putting in one nasal cavity, I will finish it off.
One more
if
thing.
it is in a,
Yeah, I think you can use the angled telescope 2.7 mm and finish the job on both sides. That is one tip.
Yeah.
Another tip is the pre-operatively, when you start the coblation surgery, you need to decongest not once, twice, so that you can have a good space. So even if there is a gross DNS, you can pass the 2.7 mm scope along the floor, no problem. In many, almost 99% of the cases, there is no issue.
Sampurna, Pawan here.
Sir,
Sampurna, I've seen people. I've seen people doing this this endoscope through the nose and the vent coming through the mouth, with it is fixed and the oral cavity opened. But I've seen follow-ups of. We see follow-up of each and every one. At Jaipur, at SMS, I see many patients for follow-up. I've seen Sainiki there in the kid's nose after this endoscope going through the nose and something is being done. What we have done so far for last 5-10 years, we do per oral approach, 70-degree we use, and you get such a panoramic view of the nasopharynx. You know your limits. The place I start is like I'm using a 70-degree. I'm making a fulcrum of the buccal mucosa with a 70-degree in my left hand, and I'm using the cobblator wand there in my right hand. At first, I see the septum. I locate the septum. I'm getting all the view. I'm getting the view of both the chicken tube, the passivus ridge there, the septum there. So I know my limits there. With the endoscope through the nose, sometimes there are some areas which are hidden in one go. And when inadvertently the human tremors, they can move your vent from here and there, and you can sometimes injure maybe the torus tuberis, maybe the passivus ridge done very deeply, or maybe the posterior wall of the posterior part of the septum is getting charred out. So this is how I have practiced, and now I am practicing. This panoramic view gives you a very good thing. Yes.
Yeah, I want to
so
add
I've seen
on this.
Sainiki there in the nose of kids.
I will tell you, okay, first of all, I have never seen Sainikia. If that is there, I must say the surgeon has done it very badly. He or she must have hit the scope multiple times in septum or turbinate. or they have not given a proper instruction to the child how to take care post-operatively. I have, how I prepare my cases, before intubation, Otrivin drop was given. After intubation, even before draping, Dr. Elena has put the nasal wicks, which was soaked in 4% xylocaine and 1 ampule of adrenaline. By the time I finished the tonsil, the nose was nicely decongested. If this is the preparation done, it will be never difficult, even if there is DNAs or whatever it is, a 2.7 mm scope will go nicely. And when I train my fellows, I always say that don't take out the scope again and put again. That damages the nasal mucosa in a child. Diameter is always less. So make your hands stable. If you want to do, of course, you can do through oral cavity, but those who want to learn this technique, your left hand has to be strong and stable to hold it in one place and continue the surgery. If you want to clean the scope, you don't need to bring it out. Ask your assistant to flush the nose with saline. From which the endoscope has passed. Through the same nostril, the saline has to be flushed. Automatically, inside the nose, the scope will be cleaned. Once you have finished that side, then only your scope has to come out. If somebody follows that, there will be no synechia, and all children do 10 days of nice saline irrigation in my cases, and that is by a 10 cc syringe filled up with saline. Many of you may think that children will not do that, but believe me, they do it. Because we personally show them, sometimes I show on the parents also. I have made a video of one of my 5-year-old child doing that herself. And that video I circulate to all the patients. Look, this is how the child is doing. Your child will also do. By taking care of this, you will avoid secondary infection. You will avoid foul smell coming from the nose. You will avoid synechia.
Sampurna?
Hello, Sampurna.
Sampurna?
Yeah.
Hello, Sampurna. What is your take on when we do septoplasty and adenoidectomy? Which position you advise or you follow?
When I do septoplasty,
Septoplasty, adenoidectomy, same sitting.
I don't do in this position. Adenoid, I do in the same septoplasty position only.
Okay.
Because here tonsil and adenoid was there and it's a child I have put. I do many face patients I see or OSA patients where I see adult adenoid. Then I continue in face position. In the same way, again, I pass this feeding tube. I pass the feeding tube through the nose and take it out through mouth cavity and ask the assistant to pull, and the coblation goes like this. But I stand in a face position only. The patient will be in face position only. But for learning, for initial learning of adenoid, I will recommend this one. After that, you can, somebody can upgrade to continue in that way.
Dr. Sampurna?
Sir.
Good morning. This is Dr. Singhi from Delhi. I had a suggestion, like initially when we started the surgery, there was a discussion on whether to use the scope or whether that you are using a naked eye. So what I personally do is I never use a scope, neither a microscope for adenoids. I use a headlight, but I then add on a loop to it. So with loop, you get 4x magnification, and it's not cumbersome. Yeah, because I do all my head and neck surgeries also with headlight and loop. Also.
Yeah.
So that magnifies.
I know, sir, people practice in different setup. I work in corporate, so I can take microscope and storage and this and that whenever I want. But there may be somebody is doing in a nursing home tonsil adenoid posted. You may not ask for a microscope. But this loop option sounds really wonderful because you can keep it with yourself like a personal property and not so costly, and you can use it. That is a nice suggestion, sir. Because I cannot keep a small child intubated for long, so I am finishing it now, but while doing I will answer if any question is still left. Is the focus good, Elena? Do I have to focus?
Hi, Dr. Sampurna, Dr. Kalpana Nagpal here.
Hi, ma'am.
Hi.
Because of your flight, I did so fast.
Thank you. You've done an excellent job and the teaching is good.
That is Kalpana, ma'am. You should not miss the flight.
Thank you so much. By the way, nasopharyngeal scarring is not unknown. Recently, I had a Kenyan patient, 6-year-old, and the first adenoidectomy was done at 4 years, and he had 3 adenoidectomies, and it was very sad to see the bad scarring in the nasopharynx. So for the juniors, yeah, we must teach 2 things. For the juniors, take-home messages. One is how to prevent recurrence of adenoids, and if it has happened, then what workup is required. And the second is to prevent the nasopharyngeal scarring. You have clearly shown the planes, and I hope this is a strong take-home message.
And this was the brushing technique I was talking about,
Yes.
Near the eustachian tube, not injuring it, but just to reduce the chance of overgrowth of the lymphoid tissue which is there. And here is the passavance ridge. Many times some lymphoid tissue will be hidden here. Very carefully pull it midline, towards the midline, and then gently ablate. But never do something blindly. You must see the active ones in front of you. Okay? Otherwise you will injure.
Before coming out, I would request you to show the this tonsillar capsule on the intracapsular side.
What you want to see?
The capsule up to which you remove the tonsil.
Okay. Then we'll put that endoscope again. Laparoscope, please. Give me a headlight. I will show that. Just wanted to say I have already injected the local anesthesia surrounding that area, so it may look little swollen and edematous. And it's also very important how you are counseling the parents before and after surgery. After surgery, we have to tell them that whether coblation or normal, whatever, that there will be more snoring initial post-op period. And our anesthesia team are expert to deal with severe OSA kids because sometimes they may desaturate, and we have to take care of that. They may also have some pulmonary issue or cardiac issue which has to be screened and dealt before the surgery itself. Importance of gargle and saline wash. Multiple times we have to say this is the fossa on right side. And Dr. Elena, I think you have to show the subcapsular part. 1 minute. This is the subcapsular part. Okay, and uvula will be edematous. That sometimes parents or children will say that I'm feeling as if something is there. In radiofrequency technique, that uvula edema will be more than cold still. But nothing to worry. I give a little bit of steroid post-op first 2 to 3 days. That is wonderful for reducing this edema and also pain management.
What is the dietary advice, Sampurna, after the surgery?
This child within 2 hours will be given ice cream. So that 4 hours, 6 hours waiting protocol is old. Can you focus the camera on Dr. Sandhya and give her a mic, please, to just say a few words on this part? Because I have seen in places where they maintain 6 hours NPM for children, that is a torture and that's not needed.
Hello, I'm Dr. Sandhya. I'm a pediatric anesthesiologist. Okay. So fasting post-op, we have to judge between the recovery, how the sedation is there, post-operative sedation and all. And we usually ensure that once the baby is completely awake, and he's asking for water or anything, we allow sips of water because that allows a little the dehydration, whatever part is taken control, and that soreness of the throat and all that will be very relieved once the baby takes a little sip of water. So we usually allow between 1 and 2 hours, but provided the child should be completely awake, there is no post-op sedation, we first rule out that and we allow sips of water.
So, is the endoscopic view visible there?
No, we are just seeing the...
No, nothing more to show. As I told you, as a practice, before extubation also, I always check the ear. And grommets will be kept ready because if, suppose you saw the child, this is conference case, so maybe I saw 1 month back, in between also if she has developed OME, so make a habit of checking ear for every child who has tonsil adenoid.
And you were telling
So
about
the
the
other
diet.
dietary
Yes.
advice, ma'am, dietary advice will be just soft diet. So today only we'll start soft rice, upma, idli, everything.
Okay.
No liquid diet.
For how long?
Soft diet for about, if I have done the tonsil, soft diet for about 10 days. If it is only adenoid, then normal diet.
Yes. Okay.
The dietary advice is more important for my multi-level OSA patients. They have to be under liquid diet for complete 7 days. But for kids, tonsil adenoid, it's just soft diet.
Yes, but the soft diet is very important because sometimes
Correct.
inadvertently, once the pain is less, from the second week, the child may take some hard food items without our knowledge, and then that may be one of the reasons for secondary hemorrhage. So it is important to instruct the parents as well as the child to take soft diet for, I would say, 2 weeks, because 2 weeks is the period where you might have the hemorrhage, especially in the coblation cases. Not in the
Yes.
normal snare method, dissection snare method, but coblation can.
That part I disagree, ma'am, because the secondary hemorrhage rate is no different in coblation and cold still. It is the same.
No, sometimes the main thing is that in coblation, you coagulate the bleeder superficially. So after, say, about 1 week or 10 days, the slough might come off, and, you know, the deeper part of the bleeders may be exposed due to taking, you know, some hard diet or whatever, coughing post-operatively or whatever be the reason. So that may be the cause for secondary hemorrhage in coblation cases.
That was a myth, and only a few papers gave that bad name to the technology that it will cause more secondary hemorrhage. It is absolutely false. It is that you have to learn from a right mentor, because it's ultimately a tool. Imagine the laser. Recently it happened, one of a very good stapes surgeon did a stapes surgery on my relative, and there was a facial palsy, which I couldn't believe that it can happen, because he was not used to using laser in stapes. That's why it happened. Similarly, if your hand is not used, you can't blame the technology that the technology is causing more hemorrhage. You have to be in the right plane. You should not damage the tissue by pressing more blue button.
Yes.
If you damage the tissue, there will be more granulation, there will be more muscle damage, and that can cause secondary hemorrhage.
Absolutely,
But
absolutely.
if you compare an expert surgeon doing with cold still and coblation, I believe that the hemorrhage rates are not different. It cannot be.
True, that is very true. There is a learning curve. That as we become senior and we, you know, try to remain in the correct plane that is immediately outside the capsule, between the capsule and the muscle bed, without injuring muscle bed, without having to use the blue switch intraoperatively, you can fairly reduce the chance of postoperative pain and hemorrhage. So there's a learning curve, and one should not be discouraged if we encounter any obstacles in the initial part.
But first few cases you have to see with a mentor, you have to do the hands-on and supervised, and then you start doing your own. Technology is wonderful, everybody should learn it.
Ma'am, Dr. Neha here.
Hi.
Ma'am, we'll end the session. We'll take more questions once Dr. Sampurna is back to the hall, because we have to proceed with our next talk.
I'm really happy to address the question. I'm happy. I was thinking after CI showing the tonsil adenoid, is it a bad decision? But I'm happy. Wonderful interaction, but because my speakers are all my guests and for their schedule and flight, I am leaving the OT now, coming to venue, and in lunchtime we'll meet you all. Thank you.
Ma'am, just one question.
Yeah.
There is a delegate asking, post-operative, which steroid do you prefer and what dose is given to the child?
Right. So during intubation, anesthesia team has already given Decadron, right, ma'am? And hydrocort and Decadron. And post-op, I give Omnacotil syrup.
Based on the weight of the child?
Yes, yes. 4-5 days I will give that. And I do a lot of turbinoplasty in children. Somebody who asked about the allergic part, if I see the child has a lot of allergic component, and on my OPD endoscopy, the turbinates are huge. While doing the adenoid, I will also do turbinoplasty in the kids, and the coblation wand for the radiofrequency wand, I should say, for the turbinate is wonderful. It causes minimal tissue damage, and it takes just another 5 minutes to do turbinoplasty in kids. Because turbinate hypertrophy, if not addressed, that is another reason of the OSA not getting resolved even after doing a good job in tonsil adenoid. So turbinate must be given attention in all OSA patients, whether pediatric or adult.
Thank you, ma'am. Wonderful demonstration.
Thank you all. See you in the venue. Yeah.
Thank you, Sampurna. And let us move for our next session, that is a talk by Shakuntala Ghosh. I invite her onto the stage to proceed with her radio frequency talk, its applications in ENT surgeries.
Please carry on, sir.
I would like to introduce our speaker, Dr. Shakuntala Ghosh. She is a senior consultant and director, Sri Ram ENT Care Center, with a wealth of over 23 years of experience as a senior consultant. She was the first rank holder in MS ENT PGI MER. Best Paper Awardee, and Dr. Shakuntala Ghosh was invited as guest faculty in several workshops and conferences. She is also executive member of AOI Telangana 2023 till 24. Over to you, ma'am. Ma'am, shall I continue? There are some more introduction of yours. Area of interest, pediatric OSA, endoscopic ear surgery, ES, and endo DCR. Over to you, ma'am.
After that excellent demonstration of adenotonsillectomy by Sampurna, in continuation with the coablation, so today I'm going to talk to you about the application of RF plasma in ENT surgeries. So talking about the basic principles of RF plasma or coablation, coablation is nothing but controlled ablation, and it is a non-thermal volumetric tissue removal through molecular dissociation. This technology uses a plasma field to precisely dissolve the targeted tissue while maintaining integrity of the surrounding tissue. And unlike the conventional radio frequency devices which cut and cauterize at higher temperatures, the coablation or the RF plasma uses radio frequency in a controlled manner at much lower temperatures, that is 1/10 temperature, that is at 40 to 70 degrees, to do the same with minimal tissue damage. So basically, what you see is that electric current is passed through active electrodes, high frequency electric current, and when it is passed between the electrodes at the coablation wand tip through a conducting fluid which is saline, then a charged layer of particles called plasma is formed. Plasma is nothing but ionized gas. So it is gas with the ionized particles which actually does the main ablation work. So these plasma ions are formed by the disintegration of the water into H+ and OH ions and the Na and the Cl ions. So these highly energetic ions at the end of the wand tip and tissue interface, they basically act on the covalent bonds of the protein molecules, leading to disintegration of the molecules and progressive ablation of tissue. So as you've realized that coablation is actually a chemical process and not a thermal process. So what are the stages of plasma generation? There are 5 stages. First is the stage of vapor gas piston formation. Second is the stage of vapor film pulsation, and this is the most important stage. That is where the actual tissue ablation occurs. And the third stage is the current dissipates and the amplitude reduces across the electrodes. The fourth stage is the energy dissipates, and the fifth stage, the plasma ions which had been formed, they recombine. So that is why, as you can see, that the second stage is the one where the vapor film pulsation occurs and the ablation occurs. So we have to press the yellow switch, not continuously, but on and off. So we should take our feet off and press it on and off mode, so that we get more of the second stage, and so we can achieve more of the coablation. That is something that we have to remember. So we can increase the efficiency of coablation by intermittent application of the ablation mode, by copious irrigation of normal saline so that we can generate more plasma, and by using cold saline, this can also produce more efficient plasma. So coming to the components, all of you all are aware that there is an RF generator, there is a foot pedal with the yellow switch for ablation, the blue for coagulation, there is an irrigation controller and the wand. And then coming to the history, I will not go much into it, but what I would like to say that it was an Indian, Hira Thapliyal, along with Philip Eggers, who patented the radiosurgical ablation probe for the first time in 1999. And Arthrocare acquired this and marketed it as coablation. So initially it was used in arthroscopic surgeries for injured athletes, and now, of course, its application has increased to many fields. So what are the advantages of RF plasma over the conventional diathermy? The temperatures, as I mentioned earlier, is 40 to 70 degrees. Diathermy, it is about 600. So the temperature of coagulation is 1/10. Then the less collateral damage occurs to the surrounding tissues. The depth of the energy penetration into the tissues is much less as compared to diathermy. And the post-operative pain is, that is why less. And the healing is, of course, faster. Then the coablation is a multitasking, versatile tool. In one single tool, you can achieve dissection, cauterization, irrigation, suction, etc. So what are the disadvantages? Main thing, the cost of the wand is very high, so it is not affordable to all. Then it is not reusable, as the plasma formation dissipates with reuse, and so the efficacy is best on first-time use. And so therefore, on reuse, the post-operative secondary bleeding is much more common. So based on the different applications of coablation in different types of surgery, various companies have come forward and designed different types of wands depending on the nature of the tissue ablated and the type of surgery. So the wands have different diameters, different shaft length, and the tips have different types of electrodes, arrays. The suction port may be small or large, etc. So the commonly used wand, of course, is the EVAC 70 HP or the tonsil blator. Then the Precise Max, which is a much more powerful version with having two electrodes. And then there is the two wands which are used for the turbinates, that is the Reflex Ultra PTR or the Turbine EXC or the Turbinator wand with a much less diameter of 1.3 to 1.6 millimeter and with markings on them. Then we have the various laryngeal wands, that is the MLW or laryngeal blator. There is laryngeal plus, laryngeal max wand, and also for the pediatric population, there is laryngeal neo and laryngeal mini. With very fine, that is 3.8 to 2.8 to 2 millimeter diameter, working in small areas. Then of course, for the soft palate region, there is a Reflex Ultra or the Palate EXSP wand. There are new coablation wands which have come up by certain companies. This is an example. This is a master pillar wand which is used for control of epistaxis. As you can see that the shaft is little long and it is curved and it has a diameter of about 3 millimeters and it has this bipolar type of suction port in it to effectively manage epistaxis. Then there is a new wand called the TR forceps wand. It looks like a bipolar wand, but on the tips it has one port for suction and one for irrigation, and you can do a lot of soft tissue dissection in the neck area with this wand. And it is a multitasking wand, so you do not need separate instruments. One single instrument can achieve this surgery. So coming to auto view. So as endoscopic ear surgery is progressing, so basically we came across three major obstacles. One is that it's a one-handed technique, then also that we have to work in a narrow space, so any bleeding will cause the obscuring of the view. And also the third thing is that drilling becomes a big challenge because the bone dust and then intermittent use of the drill with we have to stop in between to irrigate, suck, and then drill. That becomes a major challenge. So this Chinese expert consultant roundtable forum was formed in Shanghai, and they kind of put their heads together and came out with Auto View. That is a set of wands which can be used in endoscopic ear surgery. And one of the pioneers was Hu Zhao. So they tried it out in 159 hospitals and carried in 11 provinces in China. Nearly 10 special Auto View applications were done, meetings were held, and they debated, and they came out with a set of wands, which is called as the Auto View. So they have a sheath, the otoscope, and these are the different wands which can perform the different steps of endoscopic ear surgery in a very clean manner with hemostasis, at the same time irrigation, suction, everything combined into one single wand. So as you can see here, this is the auto hook, which is kind of in a film of saline, which is the surgery is being done so that it doesn't obscure the view of the endoscope. And it looks like a sickle knife, but it's called the auto hook to elevate the flap. And there is this auto knife. So basically, they are working in a pool of saline, and it keeps the field clean and free of blood. So coming to different applications in otolaryngology, there are multiple because it's such a versatile tool. So the scope is limitless. And it's people are innovating continuously and coming out with new applications of coablation. So it can be used in rhinology and anterior skull base, adenoidectomy, tonsillectomy, oropharyngeal surgery for OSA, phonosurgery, other laryngeal and oropharyngeal lesions, vascular lesions of the ear, and thyroidectomy, and it goes on and on. So coming to the applications in rhinology and anterior skull base, we can use it to coagulate bleeders. So sometimes when there is a big bleeder, then the whole field gets full of blood, and then you have to suck, you need another assistant to suck blood, you have to identify the bleeder and coagulate. So this one versatile tool, coablation tool, can do everything at one go, and you can control the bleeding with ease. So retrocolumnar vein bleed, Kieselbach's plexus, Woodruff plexus in hypertensives, spinopalatine artery bleed, anterior ethmoidal artery, septal branch ascending peloton, and so on and so forth. Then it can be also used in inferior turbinate reduction, endoscopic approaches for different surgeries like the Denker's approach, and during the surgery for JNA and other tumors, etc. So the soft tissue work can be done with a lot of ease using the coablation tool. Then also for excision of benign tumors like pyogenic granuloma, of course the angiofibroma, hemangioma, inverted papillomas, chondroma, aneurysmal bone cysts, fibrous dysplasias. Then in endoscopic excision of malignant paranasal tumors also, it is a very useful tool. Coming to the applications in obstructive sleep apnea surgery, we can do the adenoidectomy, we can do tonsillectomy, either intracapsular or extracapsular as shown by Sampurna. Then the salpingopharyngeal fold channeling, soft palate channeling, partial uvulectomy, palatoplasty, that is anterior palatoplasty, zeta palatoplasty, where there is a lot of soft tissue work on the soft palate. This can be done very well with a coablation wand. Tongue-based channeling, lingual tonsillectomy for lingual tonsillar hypertrophy, also tongue-based reduction, that is midline glossectomy. And also if there is an epiglottic obstruction, then partial epiglotectomy and the glossoepiglottopexy can be done with the coablation. Coming to applications in phonosurgery and other laryngeal pathologies, angiomatous vocal polyps, that is large polyps which are vascular, can be dealt with very effectively with the coablation. Then respiratory papillomatosis, partial chordectomy in early laryngeal cancers, T1, T2. Then posterior chordotomy, Kashima's technique, then bilateral abductor palsy. Then valvular cyst excision, lingual tonsils, also in laryngomalacia, that is epiglottoplasty or supraglottoplasty can be done. And also in hemangiomatous lesions of the oropharynx, lateral pharyngeal wall, nasopharynx, nasopharyngeal cysts, and so on and so forth. You can just improvise and do. There is no limit. So coming to a few surgeries, which I am just going to show short video clips. So here is a one of inferior turbinate reduction. So you can use the Reflex Ultra PTR turbinator wand, and as you can see that we are introducing the wand with the ablation mode, and it has 3 markings on it, 1, 2, 3, all the 3 have to go, and then basically as you perform the surgery, and you can see that there will be visible shrinkage of the tissue. I'm sorry, I'm not able to fast forward it, but basically the tissue shrinks. So as you withdraw, you keep for 10 seconds and then you withdraw to up to the 3rd mark. And then finally, when you take it out, you have to press the coablation mode, that is the coagulation mode, to prevent any bleeding. And you will see a shrinkage. So this is very useful in small children. As Sampurna mentioned, that when you're doing adenotonsillectomy, if the turbinates are also enlarged, you wouldn't like to go for a radical procedure like turbinoplasty or inferior turbinectomy, but you can use the coablation to reduce the turbinates and open up the airway. Similarly, this was a case where it was a revision fess. You can see that the middle turbinate was lateralized and there was Synechiae formation and there were polyps, recurrent polyps here. So I used instead of using the microdebrider, I used the EVAC 70 coablation wand, that is a tonsil blator, and I removed the few polyps that were present, and also did avascular removal of the tissues there. The Synechiae was removed completely, and you can see a patent middle meatus at the end of the surgery. So I used the coablation here instead of the debrider because I could achieve hemostasis, and at the same time I didn't have to pack the nasal cavity post-operatively. Then in video neurectomy or the posterior neurectomy, the singular neurectomy, which is used in cases of recalcitrant allergic rhinitis or vasomotor rhinitis. Again, coablation is a wonderful tool to kind of ablate the singular nerve. after you have elevated the flap posteriorly behind the, in the posterior part behind the maxillary ostium. And then you raise the flap, identify the sphenopalatine artery, go a few millimeters below that, identify the singular nerve, and then you can either cut it or you can use the coblation. Then epistaxis control, as I said earlier, that this is a case of a Woodruff's plexus, posterior bleeding in a hypertensive patient, and I use the EVAC 70 or the tonsil bladder wand, and you can see that I can identify the bleeder exactly using the suction, and then I can ablate very effectively. So I didn't need another instrument for it. It's very useful in case of hypertensive epistaxis, posterior epistaxis, where there is profuse bleeding. And again, of course, all of you all know about the adenoidectomy, demonstrated very well by Sampurna. So I do it in the normal fess position. It is very convenient for me. It's a more anatomical position for me. And you can see that the entire boundaries of the adenoids can be very well identified, and you can do a bloodless surgery and without any hassle, that is, having to kind of take out the wand, take out the endoscope, and, achieve hemostasis and then do the surgery again. In one go, you can finish it off. You can either use the EVAC 70 or the tonsil bladder wand, or you can use the ProSize Max or the tonsil bladder plus, which has only 2 electrodes with a wider suction port. And so it doesn't get blocked very frequently, and you can do the surgery in a very effective and efficient manner. And complete removal can be done. You can identify the limits of dissection, and there will hardly be any recurrence and hardly any intraoperatively bleeding. And of course, the tonsillectomy using the conventional EVAC 70 or the tonsil bladder wand. That is, extracapsular tonsillectomy is being shown here. So you have to basically only dissect the connective tissue fibers between the capsule and the muscle, and do not go into the muscle bed. You have to see a clean layer of white on the muscle bed at the end of your surgery. That means that you have remained in the correct plane, and that will not cause any intraoperative bleeding or any postoperative bleeding. And the chances of pain is also much less. It takes only about 5 minutes, even in an adult patient. You can do a very precise dissection with this coblation tool. So this is how the fossa looks at the end of surgery. And then soft palate channeling. I will just take 5 minutes, Neha, please. Soft palate channeling. So in case of a patient with having only snoring or having a very thin and a flabby palate, but not a very thick palate, we can do soft palate channeling only using the Reflex Ultra SP wand. So I will not go show you the video for lack of time. We can also do midline glossectomy using the ProSize Max wand and remove the midline major chunk of the tissue behind the foramen cecum. We can also do zeta palatoplasty using the coblation, where you make a butterfly incision and you remove the minor salivary glands and the fat in the butterfly incision. And then somehow I'm not able to fast forward the video in this setting. I was able to do it at home, so it's taking time, so I will just go on to the next. Laryngeal vocal polyps, which are very large and of this size, you can remove. And also, in case of angiomatous polyps, you can use the MLW or the laryngeal bladder wand, and you can actually do a very good dissection, neat dissection, and you can take out the polyps. You can also do posterior chordotomy, the Kashima's method, where you take out the posterior 1/3 of the cord and also the vocal process of the arytenoid here. And you can use the MLW wand for that. Or in children, you can use the laryngeal mini or the laryngeal neo. Then you can also do valvular cysts. So using the the EVAC 70 tonsil bladder wand, you first have to use the coagulation mode and achieve a good hemostasis, and then you open up the cyst, and you can do maspulization or remove the wall completely. And then the same principle you can use for a lingual tonsillar hypertrophy also. Again, for lack of time, I will not show you the video. You can do thyroidectomy. As I had mentioned, that there is a new thyroid wand called the TR forceps, with the help of which you can actually do a very neat dissection. This is the forceps. It has the irrigation and the suction. I'm not able to fast forward. I don't know why. So it's killing a lot of time. So I wish I could show you the whole video. Some problem here. I don't know why I'm not able to fast forward. So I'm sorry about that. And then this is actually Dr. Mohan Reddy. He is one of the doyens and pioneers of endoscopic ear surgery in India. So he has tried out the Otto View wands, which are shown earlier. You can see this is the Otto knife. And in this, there is a irrigation and a suction channel through which you can have a very clear bloodless field. You can elevate the flap, at the same time achieve hemostasis and do many steps of the endoscopic ear surgery. So my journey of coablation started with my mentor, Dr. G. Sham, a senior consultant working in Mahavir Hospital, Hyderabad, and he was the one who introduced coablation to me in 2011. He handled me and taught me coablation, and I owe my coablation journey to him. Thank you, sir. And thank you.
Thank you so much. We have 1 minute left. So, any questions from the audience? No? Then we'll go ahead with our next felicitation. Ma'am, be here. May I call upon our moderator of the session, Dr. N. Venkatram Reddy, to felicitate Dr. Shakuntala Ghosh. May I request Dr. Kalpana Nagpal to felicitate our moderator, Dr. N. Venkatram Reddy. Yeah, I request Dr. Shakuntala Ghosh to felicitate our moderator, Dr. J. Shanmugapriya. आप भी आइए. The sound of the applaud is very low. Lunch is already ready. Dr. Venkatram, please, 1 minute. I request Dr. Nishi Gupta to please come on to the stage to felicitate our moderator, Dr. N. Venkatram Reddy. Dr. Nishi Gupta. Thank you, ma'am. I extend my gratitude to the moderators and all our speakers. Now, moving on to our most awaited lecture for our Elevate ENT Summit 2024. Our keynote lecturer, Dr. Pepagaran Narayanan, Senior Professor and Consultant from Malaya Medical College, Kuala Lumpur, is here with us. And I request our chairperson, Dr. Vinod Felix, Consultant, ENT Surgeon, KIMS Health Trivandrum, and Dr. Somnath Shah, Professor and Head of ENT Department at Bardhaman Medical College, Kolkata, to please come onto the dais to chair the session.
No, video call. No mic. Oh no, you have to do mirror. Okay, can you change mirror?
By the time we are settling down here, I would like to give an announcement that there are certificates ready for all our delegates Please collect it from the registration counter.
Hi, good afternoon, everyone. First of all, I would like to thank Sampurna for the very kind invitation for inviting me to Hyderabad. My wife is still shopping, and we bought 2 empty bags so that she can finish all the shopping for Deepavali. When I go back, I'll find out how much extra bags I need to bring back. So, I'm going to talk about difficult cases. I'm just going to pick a few here and there so that I can show you, but the mainly will be rhinology. The next time I come, I'll show you mainly otology. Then the following time, if I come, I get to show you mainly otology. So this is a patient who presented with an extensive fibrous sarcoma of the nasal cavity. He had chemoradiotherapy and a tumor recurred. Now, what made this difficult is that you can see how the dura is enhanced. It's touching. We have to differentiate between an infiltration of a dura and where it's touching the dura. You can see the clivus. You can see it's very close to the carotid artery. The bone around the carotid artery will be missing as well. The most difficult part is the area between the optic nerve and the dura as well. So this is a preoperative view. Because of previous surgery, previous chemoradiotherapy, there is no landmark whatsoever. There is no way you'll be able to differentiate one plane from the other. So the way to do this is to actually go debulk the center of the tumor. And once we have debulked the center of the tumor, make your enemies your friend. And in this case, the enemies are optic nerve, dura, as well as orbit. So what I'm going to do is I'm going to dissect and identify the orbit. That's the orbit being identified here. Then, once we know the orbit is, we can easily debride the remaining of the tumor and then continue the dissection. And so we dissect further, we come to the optic nerve. That's the tumor being removed from the optic nerve itself, and that's the tumor being removed from the dura itself here. That's optic nerve, that's dura being removed. Now we're going to peel off the tumor from the dura itself, both from the right and left planum, and that's the view of the optic nerve that is nicely seen. This is the carotid artery, the optical-carotid recess. So once you get the right plane, you are able to dissect it very nicely, and that's the optical-carotid recess that is being shown here. And once we have done that, now you can see the dura. That's the optic nerve here. That is the orbit. So the only tumor that is left is exactly on the optical-carotid recess here. And what we're going to do now is we're going to dissect the tumor away from the optical-carotid recess and identify and remove the tumor, leaving a small stump exactly between the junction of the pituitary gland and the carotid artery, which we're going to cauterize because if we take this out, there's a good chance we'll tear the carotid artery. And then we are able to resect it completely. This is the final view of the surgery. You can see the dura that is completely exposed here. You can see the orbit that is completely exposed, the optic nerve, the carotid artery, the optical carotid recess, and here will be the V2. That's V2 down here. That's the cavernous sinus. So sometimes the best surgeons are tumors themselves. They do surgeries far better than any one of us can do. And all we have to do is follow the tumors, dissect it out nicely, and all the tumors come back on its own. Cellular, that is dehiscent as well. Reconstruction. So this was a 14-month baby which came with a huge, huge meningoencephalocele, as you can see. This is the lesion. It's directly connected to the third ventricle. It's going from the sphenoid, going all the way down to the nasal cavity. So this is a preoperative view, and the child having cleft palate doesn't help either. So here you can see the lesion in the nose, as well as in the oral cavity as well. So what we're going to do now is we're going to excise this multipotally through the oral cavity as well as through the nasal. It's only 14-month-old baby. So now we have pushed everything, dissected from the oropharynx. We're going to remove the lesion from the additions around the nasal cavity as well. And then, transnasally now, we are able to visualize the entire encephalocele. We're dissecting the encephalocele now so that we are able to see the landmarks. And once we've opened up the meningoencephalocele, that's the CSF leak that is leaking, now we can start cutting out the meningoencephalocele. Cauterize the edges, that's the meningoencephalocele that has been opened up. Cauterize the edges, cut. Cauterize the edges, cut. So it's a very systematic way of dissecting it until the entire meningoencephalocele is completely removed. And that's the final part of the meningoencephalocele. And with that now we are able to remove the meningoencephalocele straight fallen down into the nasopharynx, and the meningeal encapsula has been removed in a 14-month-old baby. You can see how big the lesion is. So how do we reconstruct? This is the ultimate test. Nasopharynx, eustachian tube, nasopharynx, and you can see the entire brain is going straight into the third ventricle and the fourth ventricle. The fourth ventricle is missing. You can see the middle cerebral arteries. You can see exactly like what I showed you in the dissection yesterday. The peduncular cistern, and that's the foramen of Monro and third ventricle. Let's have a look with a 30-degree scope again. The entire third ventricle is missing. The fourth ventricle is missing. Now we're going to do a reconstruction by using fat. Duragen is quite expensive for us, and so we always use the simplest we can find. So we stuffed the whole fat inside the cavity, but I was paranoid that it might fall back. So we actually told the parents that we will have to use Duracell, and the parents agreed to pay for it. So we're going to stuck Duracell into all the edges. The problem with a 14-month baby is you cannot do nasal toilet. You can't pack the nose because you can't be able to remove the pack. So what we did was we took the child 2 weeks down the line into the OT just to do a nasal toilet, and you can see how the entire reconstruction has healed quite nicely. That is a soft palate, and you can see the airway is there already. So we have not seen the child ever since, but we've been told by our pediatric colleague the child is well. Let's talk about Meckel's cave. Now, this is a dissection that I did in Joburg, South Africa. This is the left paraclavial carotid. You can see the third nerve, the fourth cranial nerve, and the sixth cranial nerve, V1, V2, Meckel's cave. So if you follow the sixth cranial nerve backwards here, that's the V1, V2, Meckel's cave, foramen rotundum, exactly like how I showed you just now. There's the Meckel's cave with the V3 going down here. And here you can see the sixth nerve going behind the paraclavial carotid, and that's the sixth nerve here. So this is the Doyle's canal. This one, this bony intrusion here is the Doyle's canal, where the nerve comes across lateral to the posterolateral to the paraclavial ICA. And if we also look at another dissection that I did, I think this was in Switzerland, you can see again the V2, foramen rotundum. This is foramen ovale, and you can see very nicely how the V3 and the V3 nerve, foramen ovale, Meckel's cave, and what is more important is you can actually make out the ICA. So this is the paraclavial carotid, and you can see the petrous carotid here as well. So with this landmark in your mind, you can now do surgeries of the cavernous sinus and so on. Let's start with a cavernous sinus tumor. She came with a sixth nerve palsy. So now, I'm going to skip all this in view of time. Infiltration of the nasal septum, septal flap. I'm going to go straight into the sphenosinus itself. So this is the optico-carotid recess. This is the bone over the cavernous sinus tumor. We're going to use a Carrison punch, and we're going to remove the bone around the tumor until we are able to visualize up to the junction of the paraclavial carotid. Now, a cavernous sinus tumor, if we are lucky, the tumor will have thrombosed the sigmoid sinus, then you have no bleeding. So we're going to cut the first layer. No bleeding so far, thank God for that. But there are two layers in the cavernous sinus dura. So sometimes when you cut the dura, what will happen is you will decompress the cavernous sinus and you start to have bleeding. We're going to cut the second layer of the cavernous sinus, and you can see the tumor coming into view. And this is the plane between the tumor and the cavernous sinus. As we cut a little bit more, this is the kind of bleeding that you will get from cavernous sinus. It's a low pressure bleeding, but the bleeding will be there. So you must be able to do your surgery underwater. So identify the exact location. Usually we use a surgery cell, but in this case we couldn't get into the junction of the dura and the tumor itself, so we had no choice but to use a flow cell. And once we have done that, now we are going to go inside the cavernous sinus itself, catch the tumor, now dissect the tumor from the cavernous sinus. As you dissect the tumor from the cavernous sinus, you'll have more and more bleeding, simply because the cavernous sinus is actually being decompressed. Oops, sorry, let me just go back here again. So here now, we are actually inside the cavernous sinus. We put a patty inside the cavernous sinus here to dissect. You can see how the cavernous sinus is open. You will have continuous bleeding in the cavernous sinus. It will not stop bleeding until the tumor is out. So now we are coming right to the edge where the 3, 4, V1, V2 will be. And this is the most important structure. Don't pull on the nerve. Go between the junction between the nerve and the tumor, and then we can easily dissect the tumor. So again, you can see how important it is to have 4 hands. And now the tumor is being dissected out, and you can see the edges where it's stuck to the lateral wall of the cavernous sinus, and these are the nerves. Can you see, guys? That's the nerves of the lateral wall. So you dissect away just at the margin of the tumor and the nerve, say a prayer, and the tumor comes out very nicely. So this is post-op view. Surgicel, everything stopped. And this came back as a hemangioma. If we had known we were going to do a hemangioma in the cavernous sinus, we would have prayed a little bit harder. She's well. She had a transient 6-nerve palsy, but both nerves recovered after 6 months. This is how she looks like 6 months after the surgery. Everything has healed very nicely. Another gentleman who came to us with a trigeminal schwannoma here, along the Meckel's cave. You can see the foramen ovale here. Can we do this endoscopically? Again, you will see that we preserve all the turbinates. Now we are going to remove the bone between V2 and Vidian. And now we are going to remove the bone over the Meckel's cave itself. That's a tumor that is being exposed. And we remove and open the space V2, Vidian, the lateral recess approach, and the tumor is now completely exposed. Now what we need to do is, first of all, we know the tumor is soft. We know the tumor has got fluid and tumor inside. Take biopsy first. Sometimes it happened before that in our excitement to operate, we forgot to take biopsy. Now we always make sure we take biopsy. We are now removing the tumor from inside the cavernous sinus. I'll go a bit quickly here. So now we are inside the cavernous sinus itself, the Meckel's cave. That's the lateral wall of the Meckel's cave. This is the medial wall of the Meckel's cave and cavernous sinus abutting the cavernous sinus. So now we are going to go right into the apex of the lesion, removing the neck portion. And now that's the carotid artery, guys. Can you see this? That's the carotid artery. This is the carotid artery of the cavernous sinus. This is dura. This is dura. Carotid artery of the cavernous sinus here. Now we are trying to remove the last piece of tumor that is adherent. This is the carotid artery. Is it clear on the screen? And you can see the dura of the middle cranial fossa, the lateral wall, and the last part, once we remove, then the surgery is over. And you can see in this case, there's not much bleeding because the tumor has literally compressed everything. So this is the final view of the surgery. Preserved all the turbinates, septal flap that we never use at all. And let me go a bit quick in view time. So now you can see the paraclival carotid. That's the cavernous sinus. We're going to go into the cavernous sinus to show there's a lateral wall of the cavernous sinus there. And here you can see the carotid artery. This is the carotid artery in the cavernous sinus. And you can see how all the tumor has been completely removed. This came back as a trigeminal schwannoma. So this is a case that I'll never forget. A young medical doctor who just finished an internship. She came with a numbness of the face. And you can see the lesion here. The problem is the foramen ovale is enlarged. The problem with this kind of surgery is you have no biopsy. You have to remove the whole thing and only then you get the biopsy. So we told her, usually lesions in this area are usually benign. So she was quite happy. So this is the surgery itself. Maxilla is open. The carotid, optical carotical recess. The next step is to remove the bone in the lateral recess between the V2 as well as the Vidian's nerve. That gives us the view to the tumor in the Meckel's cave and going to foramen ovale. Now we are able to remove the tumor that is inside the sphenoid sinus, only leaving the tumor that's in foramen ovale and downwards. So now you can see the foramen ovale. This is the foramen ovale that is dilated. What is blocking the view is the pterygoid wedge, exactly like how I showed you yesterday, the pterygoid wedge. So either we remove the pterygoid wedge or we just push it aside. So what I did was I just pushed the entire wedge aside, and that gives me a very nice view of the foramen ovale itself. So now you can see very beautifully, that's the wedge that I kept aside, and now you can see very beautifully the foramen ovale that is dilated, that is going between the two heads of the pterygoid muscle. So I'm going to use a debrider to use this. The next time I'll use a coblator, since I enjoyed the presentation just now. The next time I'll use a coblator and see. I'm going to use the curved debrider to remove the tumor, and then you can see at the end of it, we are going to go all the way to the back and dissect the tumor from the depth of the foramen ovale itself. So we're going to remove the tumor from the foramen ovale and until all the tumor is completely removed. This is the tumor coming out from the foramen ovale as well as the nasal cavity itself. So this is the final view. Paraclival carotid to the right, the sella, the left paraclival carotid, And again, you can see very nicely, this is the foramen ovale that is dilated. This is a pterygoid wedge that I swung, and I'm going to put it back into place. You can see how grossly we've removed all the tumor, and now we are in the foramen ovale between the two heads of pterygoid muscle. This came back as a unvisualized sarcoma, and she died within 6 months. So sometimes I wonder, we fight over simple things when life is so temporary. So it made me remember this patient always. A 23-year-old doctor that we say is most likely benign came back as a sarcoma, and she died within 6 months. Petrous apex cholesteatomas. This patient had an accident, a huge petrous apex cholesteatoma. What made this difficult is the carotid artery. Can you see the carotid artery is actually riding like a cowboy between this, very close to the cochlea. Like Vinod said, this is the cochlear portion of the carotid artery. And you can see the extensive intracranial but extradural component. So this is the video of the dissection itself. So this is the sphenoid that is opened up. And what made this difficult was the fact that the carotid artery runs here. We are now going to open up the lesion, and we can see it's all cholesteatoma being dissected out. Then subsequently, we are going to use a J sucker to remove the lesion from the dura itself. This is the dura of the middle cranial fossa, and that's the cholesteatoma that's being removed from the dura itself. If we puncture the dura, the patient will definitely have meningitis. So we have to do this in without trying to puncture the dura. So what is important for skull-base surgery is tactile sensation, the ability to feel with your instruments. And this is the final view of the surgery. Again, you can see, this is an old video, it's almost 15 years ago. This is the paraclavial carotid. That's the optic nerve. And you can see the dura pulsating from here all the way here. But look at the carotid artery. This is petrous bone. That's the horizontal segment of the carotid artery, and this is the vertical segment of the carotid artery as well, as you can see. Let us have a look at the carotid artery. So this is a transnasal view of the horizontal portion of the carotid artery and where it becomes vertical. And this is the video of it. The dura pulsating, petrous bone, the horizontal portion of the carotid, the vertical portion of the carotid. We just left it open. We didn't plug with anything, we just left it open. And 2 years down the line, the MRI scan shows complete resolution. She has not recurred yet so far, she still comes once a year to see her as a patient. This is probably the biggest petrous apex cholesteatogranuloma we've ever seen. A young boy was involved in an accident. So you can see now, that's the petrous apex. You can see how the tumor is going all over the carotid artery. But what made it difficult was how close it is to the carotid artery and how it actually goes from the middle cranial fossa over the petrous apex here, goes into the posterior cranial fossa. So the question is, can we remove this tumor through the nose, curve a little bit, go into the middle cranial fossa, go to the small opening and go to the posterior cranial fossa? Preoperative view, I'll keep this in view of time. So what we're going to do now is we're going to use a debrider, remove the part of the septum, remove the posterior ethmoids until we actually enter into that's the superior turbinate. And now we are actually looking into the cholesteatoma sac itself. This is now in the sphenoid sinus on the right side. We are using a Carrison punch to remove the cholesteatoma sac. So with this now, you can see the cholesteatoma sac being exposed. Always make your enemies your friend. Who is your enemy in this case? ICA. Once we know where the ICA is, the rest of the surgery is easy. So what we're going to do now is we're going to open the capsule. We're going to dissect the cholesteatoma out of the capsule. At the same time, identify the ICA. Scissors, we use simple basic instruments, as you can see. This is just a normal turbinectomy scissors. So we are cutting the capsule out until we are able to find the ICA. And you can see the ICA coming into view. This is the ICA in the lower part. Next, we're going to, this is the ICA here. Can you see, guys? This one here, that's the ICA. Now we're going to remove the remaining of the cholesteatoma. As we remove the cholesteatoma posteriorly with a CSF leak. So we knew itself immediately post-op the patient's going to have a lot of meningitis and so on. So now you can see the ICA very clearly. Middle cranial fossa dura is pulsating, the vertical aspect of the carotid artery, the horizontal aspect of the carotid artery. This is very important because the junction between the middle cranial fossa and the posterior cranial fossa, the small window is here. So now you can see we have removed the lesion from the lateral aspect of the of the pituitary apex. This is the view of the ICA, the horizontal and the vertical aspect. That's the opening into the posterior cranial fossa itself. By using a 30-degree scope, we are now able to go from the nose, bypass the carotid artery in a horizontal and vertical carotid artery, enter the small opening that we have from the middle cranial fossa to the small opening to the posterior cranial fossa and identify where the leak is. That's the defect. So from the middle cranial fossa, we've gone to the small ledge to the posterior cranial fossa, and now we're going to use fat. And now, because the carotid artery has been decompressed, we can actually push the artery down to do the surgery. There's fat being plugged into the defect itself. Post-op MRI, he's been symptom-free until now. This is almost 2 years now. He's still symptom-free. Okay? Now, this case, when I saw the scans of this case, I told myself I should have just done dermatology. Life is much easier. This is adenocarcinoma. So low-grade adenocarcinoma. So the oncologist said, you have to remove this tumor as much as you can. So how do you remove this tumor? It's all the way from the parapharyngeal space, cavernous sinus, to the carotid artery, to the clivus. So you can actually see the carotid artery here. So what we did was, we did it in a stage approach. I'm going to skip this in view of time, and I'm going to go straight into the post-op view. We remove the tumor from the clivus. We remove the tumor from the Meckel's cave. That's tumor being dissected out of the Meckel's cave. Remove the bone around it, optical carotid recess, and the tumor that is being removed from the Meckel's cave. And that's the Meckel's cave after the tumor has been removed, as you can see. Final view of the surgery from as far as the nasal component is concerned. Clivus, no more tumor. Dura dehiscent. Optical carotid recess at the top here. And you can see the optical carotid recess. And this is the Meckel's cave. Carotid artery, the Meckel's cave completely clear. But that's not over. We've only removed the sphenoid part. How do we remove the parapharyngeal space? So what I did is, I also do head and neck, I also do otology. Yeah? So we identified the carotid artery, that's the hypoglossal nerve, clip the middle vein, mobilize the common carotid artery, identify and go into the parapharyngeal space itself. And you can see the tumor in the parapharyngeal space. This is taken from my iPhone. You can see the carotid artery, there's a tumor there, and we are going to remove the tumor. And once we remove the tumor, we have only removed the lower part of the parapharyngeal space. How do we remove the tumor in the upper part? So some people told me, let's do a maxillary swing. The older I get, the less morbidity I want for patients. I asked myself, if this was me, would I accept a maxillary swing, a mandibular swing? The answer is no. So what I did was, I used an endoscope. So I'm going to put an endoscope between the carotid artery and the hypoglossal nerve, and identify the tumor here. And then by using an endoscope, I dissected the tumor out. Just follow the tumor, dissect the tumor out until I'm able to see, this is the pterygoid muscles here. Go between the two heads of the pterygoid muscle, dissect the tumor until I'm able to see the dura of the V3. There, that's the dura of the V3. And you can see grossly we have removed all the tumor between the two heads of the lateral pterygoid muscle. This is what we did the surgery. The biopsy came back as a myoepithelial carcinoma. So not a single incision in the face, which staged the surgery within 6 weeks apart. This is for Nishi. 42-year-old male who had a foreign body that entered the orbit. He had blatant vision, he had a lot of infection. So we were told if we cannot take out the foreign body, they will remove the eye. He had light perception. So how do we remove a foreign body right in the center of the optic nerve? So what we did was we got our eye colleagues to tag the middle rectus muscle. Then we did an orbital decompression. And when we did the orbital decompression, we were able to identify the middle rectus muscle. And now, after that, we were dissecting the middle rectus muscle to go intraconal. And here you can see the middle rectus muscle that is being exposed. And now we are into the intraconal component. And as I showed you on a dissection yesterday, that's the oculomotor nerve. This is in real life. The oculomotor nerve looks identical as how I showed you before. Now the problem is we have opened the access. We have to go intraconal. What can we use? Some of my colleagues say use coablator. But coablator will get stuck, will get blocked all the time. We need something sharp and precise that will cut exactly what is required to go into intraconal. So I'm going to show you what I did. But please don't do this at home. Don't do this until you are very comfortable with this instrument. Yeah? So I'm going to use the debrider to remove the periorbital fat. So as you know, there's a hand that holds the instrument. They always blame the debrider for everything. But when you use the debrider, you use it like driving a car. You know when to go slow, when to go fast. Now I'm going to go inside intracornal. Middle rectus muscle, superior oblique. Now we are inside intracornal. And I'm going to use the debrider, and I just tells me exactly where I need to go. I'm going to use the debrider now to remove the orbital fat layer by layer in a precise manner. Don't go fast, go slow. So if you drive, the older one of us who grew up driving a manual car will know how to control our leg. The younger ones who grew up driving an automatic car, you will not know how to do this. Layer by layer by layer, you will have bleeding because it's infected. As you go deeper inside now, the superior oblique is here, middle rectus is here. I'm using a 30-degree scope. I'm using a curved one. Again, I'm removing the fat layer by layer by layer until I can see the optic nerve. So now we are going to identify the intracornal, the foreign body that is next to the optic nerve. There, can you see, guys? So we're now going to use an instrument that they call it the fish hook. We are just next to the optic nerve, and we are going to fish hook to remove the foreign body. Can you see how sharp it is? So if we did a blind dissection, we would have definitely caused, thank you, we would have definitely caused and cut the optic nerve completely. So this is you can see his pupil is dilated after surgery, and the next day, pre and post, he had light perception before surgery. The next day post-surgery had finger counting. But can you see his eyes is slightly squinted? That's because the middle rectus muscle has been stretched. But my eye colleagues told me, don't worry, it will readjust itself in 6 months. If it doesn't, a screen surgery is much easier. So we did save his eye and take away the foreign body. And we couldn't get it published in any ENT journal. Despite the fact that I sit in quite a few of the boards, they said this is too dangerous, it should never be published. So we finally published it in a computer-assisted medical technology journal. Nobody wanted to publish this. So again, please don't do this unless you're very, very comfortable with debrider, and the debrider becomes a part of your hands. So this is a patient who has got a meningioma of C1, C2. Can you see the brainstem? It's almost completely compressed. So the exposure, I'm going to cut the nasopharynx in the center. I'm going to dissect the clivus away. And after I dissect the clivus away, now I can see the clivus C1. Is that clear, guys, on the screen? The junction between clivus and C1. So once we have done that, I'm just going to drill, expose the clivus, C1, and now you can see the incision we do is vertical. Now we're looking at the ligaments in front of the upper cervical, upper vertebral spine, the cord itself. So now we are intradural. You can see the CSF leak. That's the dura of the upper cervical spine, and that's the tumor underneath the upper cervical spine. So now we're going to dissect the tumor away, use a CUSA, and remove the tumor totally from the upper cervical spine to the vertebral cranial junction of the basilar artery. And that's the tumor being dissected out, as you can see. The final view. So we're going to the hole in the septum, the straight incision that I made inside. And here you can see now the upper cervical spine, the vertebral artery. And this is the upper cervical spine, as you can see. That's the vertebral artery, and that's the blood supply to the vertebral artery, as you can see. How do you reconstruct this? Again, the same way as I always do. Vertebral artery, can you see, guys? And you can see these lovely small blood vessels that is supplying the upper cervical vertebra itself, the upper cervical spine itself. So I'm going to use fat. My patients are ever willing to donate their fat. Then I'm going to suture back the two flaps like this. And with this, we didn't put a rice tube. We just let the patient eat because the soft palate is able to protect the nasopharynx. And this is how it looks like 6 weeks down the line. So a transnasal upper cervical spine surgery. Yeah? So I was asked whether people are now in America, they're doing a lot of surgeries in a day surgery, a lot of FAS. So one of the things they asked me is, can you do a skull-based surgery in the clinic? In the clinic. I said, fine, I'll take it as a challenge. If anybody can do it, we Asians can do it. Don't tell them I told you all this. Huh? Okay. This is a tumor that we selected. Can you see this? There's a meningoencephalocele, but there's no communication. So I was quite happy because I thought, if there's no communication, we can do this. So in the US, they always do the maximum they do is inverted papilloma in the clinic. So when I was more or less challenged, I said, fine, I'll do it for you. The setup, the patient, the way I sit, patient awake, my colleagues were helping me, the IGS that was mandatory for us to use. So this is the surgery itself. Middle turbinate, inferior turbinate, and you can see the large meningoencephalocele that is going towards the foramen cecum. So what I did was, I used ribbon gauze to wrap around it to reduce the bleeding. Remember the patient we're doing in the clinic. So what we do is we pack the entire area with ribbon gauze like a roti, from the top, below, side, so that there is enough anesthesia around it. After that, I started cutting. Bipolar the top, bipolar the top, and cut. So at one part she said she was having pain. So that's when we used lignocaine from the urologist. Now I'm going to cauterize the upper part of the attachment, and this is where the upper part of the meningoencephalocele is. I'm going to use the scissors, and I'm going to cut it across. And with this now, the tumor is out. Oh, sorry, there you go. Tumor is out. You can see that she's wearing lipstick because we told her we're going to record. So she looked nice shirt, and she came with the lipstick. There you go. The tumor has completely been removed. That's the area that I had to put a bit of fat. So this is how the surgery was done. Looks like nothing was done after surgery. Because when they are awake, they are so scared, the adrenaline stops all bleeding. We gave her a cup of coffee and some buns, and she went back after 1.5 hours. So you can do skull-based surgery in the clinic, but please don't do unless you're comfortable. Please choose your cases carefully. Yeah? Head and neck. I go very, very quickly. So now we are doing our tumors, a huge parapharyngeal tumors now, transorally. We don't have robot. It's too expensive for us. And this patient was from Singapore. They wanted to do a maxillary swing. That's when mandibular swing. That's when he remembered his emulation and came back to us. So we did the entire surgery transorally. A Boyce David mouth gag. I got one of my colleagues to hold the endoscope for me. So this is, the uvula is somewhere here. The uvula has been pushed away from its normal position. I'm going to use a monopolar to open the plane. The concept of this is very simple. It's like removing a sari. It's layer by layer by layer by layer. You have to remove up to the last strand. The tumor must be completely with nothing on. There. Can you see this? These are layers and layers and layers of fibrous tissue that has formed over the years. You have to cut layer by layer by layer until the tumor is completely bare. Only then you can dissect. So there's still some fascias on top of it. So the last few, then the tumor is completely bare. So only when the tumor is completely bare can you start using. There. This is where the tumor is bare. Can you see this? Only when the tumor is completely bare, you are able to remove the tumor. If the tumor is not completely bare, you cannot dissect it. This is the bigger lobe that is going at the back, towards the end. And this is from the posterior aspect. And now I'm going to dissect the tumor from the posterior aspect. That's the bilobe appearance of the tumor, the lower part of the capsule of the fascia. And now we're going to use, and this is at the very edge. And you can see the dissection of the tumor from the lateral aspect of the tumor. And we are going to use a cautery and cauterize this. And that's the final part, and the tumor being moved out. And the surgery took us 20 minutes. Because with the endoscope, you have a beautiful view. And that's the post-op view. The uvula is back to where he belongs finally. He was completely obstructed before. And this is, you can now inspect into the cavity itself. And you can actually see, make sure there's no bleeding, cauterize all the bleeders, put Surgicel, suture the whole area. We didn't put any rice tube. We put him in front of the nurses. No rice tube. We allowed him orally the next day itself. Post-op, after a few months. We did the same for carcinoma. This was a respiratory surgeon, respiratory physiologist from Indonesia with CA tonsils. And this is so we did the same way with the endoscope assisted. So you can see the carotid artery. We removed the CA tonsils all the way lateral. There's a carotid artery here. Is it clear, guys? So use an endoscope. You may not need a robot. An endoscope will be able to give you beautiful views like this during surgery. This is a patient who was from Singapore, referred to us. She had 2 previous retrosigmoid surgery, and she has now come with tumor in the parapharyngeal space going into the foramen ovale extradural. So how do we do this surgery? She was offered a mandibular swing. So we told her, no, we will try to do the normal way we do. So I removed, as you know, I also do head and neck. So I removed the tumor from the neck. Then we use an endoscope to the neck, all the way to the top. That is the cavernous sinus, as you can see here. Can you see, guys? There's a tumor that is stuck at the capsule itself. And all the surgery, cavernous sinus that is blue, and the entire surgery was done through an endoscope to the neck. So now we are going to dissect the tumor, identify the dura. So that's the dura, the capsule of the dura, and we're going to remove the tumor from the capsule of the dura. So that's the capsule of the dura, and the tumor that's being removed from the capsule of the dura, as you can see. So now only the dura is completely dehiscent in a patient with trigeminal schwannoma. So this is the final view. From the neck, the 2 heads of the lateral pterygoids, maxillary artery, the lateral pterygoid itself. That's the cavernous sinus here. Lateral pterygoid, the cavernous sinus here. And here is the dura, the foramen ovale, where the dura has fallen down through the foramen ovale. There's no CSF leak, and we've managed to preserve the dura itself. Post-op scans. You can see how it has been removed all the way to the middle cranial fossa. I'll go to otology. Now, it's always been said that you cannot do a translap in someone who's got a total asclerotic mastoid. So we had a 15-year-old boy who came with a huge acoustic neuroma, and there was not a single air cell in the mastoid. So this is a totally acellular mastoid. I'll show you. Can you see? This is middle cranial fossa. Posterior cranial fossa, the ear canal that's been thinned out. This is sigmoid sinus. The junction between the sigmoid sinus and the ear canal is the size of a 4mm diamond. There's lateral semicircular canal here. That's not a single mastoid air cell at all. So now, what we're going to do now is we're going to do a translap in this patient, a 15-year-old boy, push the posterior cranial fossa backwards, and start drilling the ledge of bone that separates the middle cranial fossa and the posterior cranial fossa. And then we're going to start drilling the levantine. So this is the anatomy that you get. Ear canal, sigmoid sinus, not even 1 centimeter space in between. So you can see now the posterior cranial fossa, middle cranial fossa that is stuck together. This is the lateral semicircular canal, and we have drilled off the bone over the spinodural angle for transtentorial. That's the endolymphatic duct here, as you can see. And this is IAM being exposed. Now we're going to drill the IAM, and this is the final view in a translap. Middle cranial fossa, ear canal, middle cranial fossa, posterior cranial fossa with a sigmoid sinus. Look at the gap between the ear canal and the sigmoid sinus. It's extremely narrow. Both the middle cranial fossa and the posterior cranial fossa are hugging each other because there's no space whatsoever. Jugular bulb. And once we push this down, you can see a huge acoustic neuroma tumor here. A large tumor that now my neurosurgeons will come and remove. So can you do a translap in a totally acellular mastoid? The answer is yes. It took me around 2 hours to do the drilling. You just need to know where the anatomy is. So this is a patient who came with a 7th nerve palsy. This one here. That's a normal nerve, 7th nerve palsy. And when we did the scan, you can see a cyst around the CP angle. So we did the surgery now with a very small retrosigmoid. The opening is 2 centimeters. This is the opening. The size of a micropathy. A micropathy is 1 centimeter. So now we are going to put an endoscope through this. So we are going to use a free hand and push the cerebellum down. Now we are able to put an endoscope inside and open the cyst. And this is the final view of the surgery. There's the 5th nerve here. There's a 7th nerve, 5, 7th, choroid plexus. Can you see the lower cranial nerves, 9, 10, 11, how they are pushed against this, the petrous bone. So this entire surgery was done by a retrosigmoid approach with 2 centimeters. Same way we did this patient who had a brain stem cyst who came with imbalance. So we did a dual opening, again of 2 centimeters, open the dura. I'll go a bit quickly in view of time. We're going to retract the brain and until we're able to see the cyst. Now we're going to cut the cyst endoscopically from a retrosigmoid that is 2 centimeters until we are able to see. Can you see the lower part? That's the 5th nerve. 7 and 8 complex, but the cyst is being removed. ICA from the 5th nerve, 7 and 8 complex. And as you go lower down, you will be able to see the lower part of that's the 11th nerve, 12th nerve, and the vertebral artery, the basilar artery. So now the reconstruction. Can you see how small the opening is? So we are going to close the reconstruction by pate and simple closure. But not everything should be endoscopic. So this is a patient who had a recurrent fibrous dysplasia. So we had to do this surgery open. So we did this in an open manner. This is how it looks like 2 weeks down the line. Post-op scans. There was one case that made me change the way I look at things. It's a patient who had multiple surgeries and angiofibroma before. The carotid artery has been clipped. He's been embolized, 5 different surgeries before they sent to us. Can you even see a single space where there is any space inside? There's no space. I couldn't even put my scope inside. So this is how the patient came to us. And he was bleeding every week. So I pushed the tumor at the back, and I tried to access the maxilla. And after 20 minutes of trying, I told myself, what am I trying to achieve? I did a mid-facial degloving, put my finger inside, called Ganesha's name, and the tumor came out so easily. And this is the tumor, and this is how big the tumor is, and this is the view. After that, I put a surgery inside. So this is the pituitary gland. This is the sigmoid polar. This is what happens when you do otology and rhinology at the same time. This is the paraclival carotid, optic nerve, cavernous sinus, and all this we did with a simple mid-facial degloving. So it made me realize that surgery took me 20 minutes. I lost 200 ml of blood. It made me realize, are we overdoing endoscopic angiofibroma? Are we doing it only so that I can stand here and show a beautiful video? Will you do this if it was your son? This is how it looked like the next day after surgery, 2 weeks down the line. He's still well, no tumor recurrence whatsoever. He was getting married, so he came to invite me for the wedding. This was 8 years down the line, no tumor recurrence. So are we overdoing endoscopic angiofibroma? Will you do this if it was your son? So the way I look at it now, I'll only do an endoscopic approach if I can have a similar operating time and I can avoid a blood loss and a transfusion. So everything about skull base is teamwork. This is teamwork. How quickly is change? But sometimes teamwork can also be a bit difficult. 2 children going up on the same bed, they can't go up on their own. So both of them want to go up together. They end up pushing the other one up. But if this fellow is down there, he cannot go up. So sometimes teamwork can end up something like this. Life is already complicated. So let's keep surgery simple, because there is more to life than being here giving lectures. At the end of your career, on the day that you retire, all the people who are calling you Prof, Sir, will all go away. You will walk alone to your car, and the only person waiting for you in the car will be your spouse. So you better be good to her. Thank you very much for your kind attention. Thank you.
Wonderful presentation by Professor again. It's really, you should consider the life first and what way you can make the life easier. Easier for you and easier for the patient. It's not the questions of endoscopic or external one. Yes. So any questions from anybody?
So I would like to comment on that. You know, what we are seeing, it looks so easy that he has approached something and he thought of it, and by the end of the day, he is sleeping well, enjoying his meals.
It's very important for me, yes.
Yesterday also, yeah, that is important. Yeah. You know, whatever you do in the day at your workplace, it reflects on your face in the night. So when you get back to your home with something not done well, you don't feel good. And this is what I teach my residents. Something should be done in the way that you you really relish your food and you sleep well. So that is, I think, but looking at these videos, taking this message home that you can do everything which comes there at the skull base, I don't think so. The important thing, if you could see behind all these slides and cases, is dedication. Is dedication, is the knowledge, is the practice in the subject. He would have done hundreds and thousands of dissections, then he has attained this skill. You know, and the skills are not inherited. Skills are learned with practice, practice, and practice. So the thing is, he is following the radiology, he is following the pathology. What pathology do we have inside? You can't operate a craniopharyngioma just like you do a pituitary adenoma. They are different things. You can't remove the whole craniopharyngioma. Don't try to remove the whole craniopharyngioma in one go like you do in an adenoma. So I think read the radiology properly, know the pathology, and define your approach. If you are not well versed dealing with the carotid inside the sphenoid, please practice first, then embark on total endoscopic approach. So the last case is shown that beautiful, handsome guy he did with this sublabel approach, with maybe Lefau's type 2 fracture you did and all.
No,
Type 1 you did and...
Just sublabel approach. So I was in Brazil around 10 years ago.
Yeah.
So one of the surgeons was from Patagonia. And Patagonia apparently is endemic. Angiofibroma was endemic. So they presented 3,000 over cases of angiofibroma, all done by sublabel incision. Not endoscopic at all. So there are people who do thousands of angiofibroma. We just don't know. They don't publish. They do their work, have their coffee, go home and sleep. The Brazilian guys in Patagonia have done 3,000 over sublabel incision with very good results. And here we are showing cases again and again and again with bleeding. So maybe we should ask yourself, if this is my child, what will I do? That's what I do these days. My boys are big now. If this is my son, what will I do? So you don't have to do everything endoscopically. As long as the work is done, patient is well, there is no complication, open is fine. As much as possible, try not to have a scar. A midfacial degloving works very well. So you don't even need a Lefau's incision. Yeah. Do what works in your hand. Don't look at this and say, oh, he can do it, I can do it as well. It doesn't work that way.
Yeah, and we are not here to demean your morals. We are here to boost your morals rather, but do practice, acquire skill, read well, and then you can anytime just ask. If you are having any confusion, you are having any difficulty, please don't have an ego. Don't hesitate to ask others. Don't hesitate to call some mentor or call someone on the phone. That is, I think, the best practice.
And if you see, the surgeries we did just now, they were all done with basic instruments. We didn't have a coablator, just scissors.
I couldn't see a coablator there.
No, yeah. So we had only simple basic instruments.
No navigation you are using as well.
Sorry?
No navigation you are using as well.
So basically...
So he's following the anatomy, you know. This is what there. Anatomy is going around the tumor, seeing the anatomy.
Surgical anatomy.
And then all those.
Thank you, sir.
Madam is waiting.
Excellent tips, sir. I had one just small question. When you were doing the orbital and the base skull surgery, which suction were you use? Suction tip, because I could see it was a little angled suction tip with a blunt, and the suction holes were on the sides. So
yeah, I designed it myself. It'll be out soon. I've named it after my wife, so I'll tell you when it comes out. It's not under my name because I don't think it's right that it should be under my name. It's under my wife's name, Nita. It'll be coming out end of the year. It's used in such a way.
So which company is?
Pentax. Okay. So we don't have access to Indian companies. We only have access to the European companies. It's done in such a way that one part is slightly sharp. Yes. So it uses it to be able to elevate tumors and find the tumors. Yeah. It'll come out soon.
That is what I was just watching.
Thank you for noticing it. Thank you.
Thank you, sir.
Any other questions?
Hi, sir. That was superhuman, not human, your presentation. Thank you very much. Recently, me and my neurosurgeon, we did a case of quadriplegia. Patient was from Kenya. We did a transoral odontoidectomy for brainstem decompression. I have put sutures as you have shown in the nasopharynx. They have given away, and patient developed reflux. Whenever she's swallowing, she was regurgitating to the nose. Then we have put a Ryle's tube for a week, but that regurgitation was not coming down. So what would you suggest for?
So that's a very good question. So I've got videos of odontoid pack, but we do everything to the nose the same way that I did just now. So your incision should not come below the soft palate. So your passa muscle and soft palate must be able to close. Then you won't have a problem. So if you go transoral, your incision will definitely be below the passa muscles go up. So you will definitely have problems. You need a Rice tube. So if you do endoscopically on nasopharynx, because the C1, C2 is in the nasopharynx itself. So your odontoid pack is nasopharynx. So go to the nose, remove the posterior wall of the septum, cut the nasopharynx into half as how I showed you. When you suture and the patients the soft palate can close, you won't have a problem. Do it endoscopically next time. It'll be much better.
One more thing we did, like 2 or 3 cases we have done with the neurosurgeon. We raise an inferiorly based flap, a U flap. Put it down, do the job, put it back. Even if you can't suture that, it falls short, what you could do is put it there, take some glue, and pack the nasopharynx maybe 5-7 days with the Marocel. It works well.
So we did endoscopic only, sir. But the only thing is the approach was transoral.
Yeah, so your incision will be lower down.
Yes.
It must be above
from
the
nasopharynx lower down.
Yeah, so we don't use a U flap because I'm born lazy. I just like to find the easiest, simplest way to do things. So I go straight because the tumor was midline. If the tumor was lateral, I would have gone a bit more lateral. So it's all looking at the scan, sagittal, coronal, sagittal, and axial, and in your mind reconstruct and then come up with the simplest, safest approach. That usually works quite well. And say a prayer always works much better.
And I think that is a good point. If you go per oral, you might extend that incision below the passivus ridge. Then that would be a problem. So if you are going through the nose, you will limit yourself to the level of the soft palate. Thank you so much.
My pleasure. Thank you for having me.
I think he deserves a standing ovation. The work he is doing for the mankind.
Thank you. Thank you. Thank you.
I would request our chairperson, Dr. Somnath Shah, to please felicitate our keynote speaker, Dr. Prepagaran. I have an announcement. Are our delegates really very hungry? Can we wait? Can we delay our lunch for 20 minutes?
Ranbir?
Yes?
Ranbir?
So I take it yes. We'll take one talk from our faculty and then we'll break for lunch. Thank you.
Good afternoon. Good afternoon, everyone. On behalf of the organizing committee of the forthcoming South Zone Conference at Hyderabad, I think many of you are aware of it, but it's my duty to announce it again. We have a South Zone Conference coming up at Hyderabad, at Alankata Resorts, Hyderabad, for 5 states of southern states. And it's going to be a good show. I think those of you who are not registered so far, I welcome them to register. We have a huge, contingent of faculties, close to almost 60, including the local faculty, South Zone faculty, national faculty, and international faculty. Around about 60 faculties are there. We have a very jam-packed, huge scientific program spreading over 3 days at Alankruta Resorts, Hyderabad. So far we have a very good response, and we are expecting the delegate numbers close to 4-figure 1,000. So far our delegates have already crossed 500, and we want to make it a very big show. I think I invite all of them on behalf of the organizing committee of South Zone. Please register, come and enjoy the hospitality at Hyderabad, especially at the resort setting. It's the first time it is holding at the resort setting. So I invite all of you from the organizing committee. Thank you very much. Yeah. Nothing, brochures are available in the Sun Pharma. Thank you.
We are now getting on to our next session. Will be a potpourri, a session with diverse blend of various subjects. So I call upon our chairperson, Dr. S. Vijay Praveen. He is an HOD at ESIC Medical College, Hyderabad, and Managing Director of Meraki ENT International Hospital, Hyderabad. And I also call upon Dr. Sandeep Dachuri, Consultant ENT at Medicover Hospital, Hyderabad, to please chair the session.
Good afternoon, everyone. I'm Dr. Sandeep. I would like to invite Dr. Kalpana Nagpal onto the stage. Good afternoon, ma'am. She would be speaking about robotic surgery in sleep apnea and her technique.
Thank you. Before the slideshow begins, I just want to take a few seconds and just talk about WOI. WOI is Women Association of Otolaryngologists of India. I'm the founder president, and we have more than 1,900 members. And just to tell all the junior female colleagues here, if they could join this organization, as we, they'll benefit at large, because we're doing a lot of online courses and offline courses. Every month we have at least 2 online courses, and every other month we have at least 1 cadaveric workshop. And it's been only 1 year old, and we have already done more than 3 physical conferences. Thank you all. So today's topic is TORS in sleep apnea, that's transoral robotic surgery in sleep apnea, my technique. Now, you can see, now this particular surgery can happen only when there is a multidisciplinary setting. As you all know, OSA needs specialists from all different fields, and you need to have robotic skill acquisition, and if you had both of them, you still need the infrastructure. So unfortunately, not too many robotic surgeries are happening in India. Also, it's because of the lack of training centers in India. So I'm a senior consultant at Indraprastha Apollo Hospital. That's my alma mater. I've been there practicing for 20 years now. And the slide on the right-hand side says that I got trained from Yonsei University Severance Hospital for this robotic surgery program. I underwent basic and advanced course. But the good news now for you all is, in case you want to acquire robotic surgery, now we have this ARIS Foundation, Association of Robotic and Innovative Surgeons of India, under which we've started a fellowship very recently. So the fellowship can provide cadaveric dissection, and we request the companies. Now it's more than one company, it's not just Da Vinci. And so we can, train, we can give you the simulation course, and probably you can think of taking that. Before I continue, I must also say Dr. Narayanan's talk was mesmerizing. I'm awestruck, and I hope I don't have a mind block. And the surgical procedures in OSA, everybody is familiar with. There are so many surgical procedures that I mentioned. Many have been trying different things. And there are different centers, like I was working with Dr. Samuel Mickelson in Atlanta School of Medicine. They were doing a lot of oral procedures those days, but this was 15 years back. And there are other centers which are doing a lot of palatoplasties. But all this has been, old, like 15, 20 years, even coablation procedures, laser procedures, etc. But now, TORS, transoral robotic surgery, has taken over because the proven outcomes and adequate exposure of base of tongue, and base of tongue being actually the culprit in most cases of, when you do the dyes, and then you confirm, and also different literature. I mean, if you go across all the Western countries and the developed countries, because of their results and the outcomes as compared, what we do is we compare polysomnograph, from pre-op and post-op, improvement in the objective statistics as well as the subjective symptoms has now made TORS a proven procedure with great outcomes. So let's now... Technology has played a great role in medicine. Robotic technology has clearly given very good outcomes, and in select cases in each specialty it has given great benefits. And what are the benefits? You can see the parts of the robot. Now the robotic technology gives you a greater magnification and depth perception. Now these are the arms that you're seeing. These are the instrument arms. The center arm is the endoscopic arm. Now this is the surgeon console you're seeing. The surgeon gets a binocular vision, a 3D vision, and these are the finger manipulators, and these are the instrument arms, which are 5 mm instruments, and these are very fine instruments which are inside the body. And whether it is suturing or stapling or cutting, everything is done very neatly. There's so much neat dissection and precise dissection, and 10 times the magnification the surgeon gets. So you can see the major neurovascular structures, and therefore there is no damage. And then it has other benefits, like even in cancer surgeries, lesser morbidity. Before I proceed with TORS and sleep apnea, I must also tell you that our center has been doing a lot of robotic surgery procedures for both benign and malignant conditions. Of course, my benign series are more, because of the competition with the oncologists that we have. So the main cases of benign cases that we are doing currently is TORS and sleep apnea, and removal of parapharyngeal space tumors without any external incision or cuts, and also scarless thyroidectomies. So I'm doing both transaxillary thyroidectomies as well as retroauricular thyroidectomies, and also in cases of hemangiomas of the tongue, hemangiomas of the lower BOT, or even the oral tongue, and the lingual thyroid, and many others. There are few that have proven to be, very efficient, like in thyroidectomies, the outcomes are very good, and hardly any symptomatology post-op. And there are indications where, like Eagle syndrome, where I did it for the sake of doing, because it was mentioned in the case of indications, but there was no great benefit because haptic feedback is absent in robotic surgery cases. Now, these were just publications only pertaining to the OSA, which was published even in American Journal and ACTA Journal of Otolaryngology. And currently, we have the largest series of TORS and sleep apnea in the country. And these are some of the instruments that are required for performing TORS in OSA. The retractors that we commonly use is the Dingman and the Crow's retractor, Crow-Davis retractor. But FKW retractor is the ideal because it gives maximum exposure to both the lower base of tongue, the hypopharynx, the supraglottis, etc. FKW, whenever we did larynx cases, we borrowed from Olympus. but unfortunately the hospital hasn't bought because each retractor is so expensive. Even the self-retaining retractor, the chunks retractor that we use for the transaxillary thyroidectomy is more than 14.5 lakhs. So each time asking the management is not fruitful. So we have now started requesting somebody to make similar retractors for us. And the instruments that are used in robotic surgeries are very fine instruments, just 5 mm instruments, which I used to be using in the SI system, which was previously there. And now it is the XI system, which is more advanced, but unfortunately the instrument size is 8 mm. But, each institution can have only one type of robo, and so I had to, adapt myself to doing with 8 mm instruments. And so what is exactly that we do? As compared to other specialities, the advantage in our specialty is all the instruments and endoscopes are hanging in the air, in the sense I don't need to make ports outside to introduce the instruments. It's just a good mouth opening that is required. So obviously, you cannot do in cases of trismus, whether it is benign or malignant, mouth opening should be very adequate. And so the endoscopic arm is usually a 12 mm, endoscope with 30-degree up view for, when you're performing it on the base of tongue or the supraglottis. Otherwise, 30-degree down for some other procedures like palate, etc. And here we do a nasotracheal intubation because, you want adequate space for all the instrument arms so that there's no collision or crowding. And that's the master control, where I'm using only 2 fingers. I'm sitting and operating, so good ergonomics. I can adjust the height of my shoulder and arms, etc., so that, I do not have any muscle aches, and, one can perform even 5 or 6 robotic surgeries at a stretch without getting tired. So basic benefits of robotic surgery, most people I think by now know that it has no bleeding or, that's why it's very useful in hemangiomas. Because you have the cautery coagulation mode in all these instruments and you have the left-right arms. All the, buttons are near the feet, and with the touch of a button, you can keep adjusting. You can do the swapping of instruments also without asking the nurse or anybody to change. We can do it. The surgeon can do everything by himself or herself. So this is a small video. I made some animation videos and we have some real-time videos for you to understand. So there are 3 parts, basically the surgeon console, the patient console, patient cart and the vision cart. Now vision cart is a 2D dimensional view. Unlike the surgeon console, which has a 3-dimensional view, you get the 10 times magnification, and you can see all the neurovascular structures and the muscle planes, etc., very clearly. That's why in-depth, precise dissection is really cool in this. So in torsion OSA, as I told you, now this is the animation video where you can see the base of the tongue. Base of the tongue anatomy, everybody must be familiar with, but just briefly, let's revise. It's the anteriorly, it's limited by the circumvallate papillae, where in the center you have the foramen cecum, and that's dividing the oral tongue from the pharyngeal, that is the base of the tongue. Now, the difference, so the incision exactly begins at the circumvallate level. And the circumvallate papilla, you have to clearly see it under the 3D vision. And then the lateral limits are the glossopalatal sulci, and the posterior limit is the vallecula. Now, I don't need to go too laterally in transoral robotic surgery for sleep apnea. Those boundaries are required when you're doing a base of tongue cancer, where you don't need to do a mandibulotomy. Everything is transoral and transoropharyngeal, and the patient is very happy because the cosmosis is very good. So after you do the base of tongue resection, then you start seeing the petiole of the epiglottis, and that's where your end of dissection happens. And now this is the real-time video where you can... This surgery is being done for hemangioma base of tongue. Now this... Sorry, I think it's some other procedure. Okay, now if you see these pictures, the first picture shows a huge lingual tonsil hyperplasia. Now these are the kind of cases where the TORS benefits in sleep apnea. So your case selection is very important. Either your AHI, the cases should be mild, moderate, or early severe. Earlier I used to take up where apnea-hypopnea index used to be until 40, but now I've gone up to 60 because post-op polysomnograph, it shows that the AHI drops to 8 or 10, from 60 also. So why this has happened is it's all a learning curve. You know, once you start doing more and more cases, you're more confident about removing the volume of the base of tongue. Now, how is this different from coablation? In coablation, it is a surface reduction. In radiofrequency, it is surface reduction. Whereas in robotic, you're actually removing en-bloc tissue. So the volumetric reduction is much more, and that is why the results have been phenomenal. Now, what exactly you do? You do the lingual tonsillectomy, as well as you remove the central part of the base of tongue, I mean the muscle also. So now, these are some of the pictures under the console. The first one is the white color structure is the endotracheal tube. Initially, you're not seeing because of the reduced isthmus space. And then as you keep dissecting, then you see more and more of the tube. Now, the first picture is lingual thyroid. Now, this girl, 16-year-old, she also presented with OSA-like symptoms because it's causing choking spells. And we always measure the volume, and we always send it for histopathology also. In fact, the current indication of TORS in OSA is also for, unknown primary. So we do send every case for histopathology. And the volume, if it is less than 10 ml of volume, the patient is not going to get adequate results. Recently, I received 2 patients from UK where the resection was inadequate. Apparently, in UK, the robotic surgery program started later than us. And if you remove more than 30 ml, you can end up giving the patient aspiration issues. And the right-hand side picture I want to show you where in the outpatient, after 3 months, when you ask the patient to open the mouth completely, this is the kind of picture you see because you have reduced the thickness of the tongue on the backside, and that is why the epiglottis is clearly visible. So now this is another animation video showing basically the midline glossectomy and the partial epiglotectomy. Now, what do you do in epiglotectomy? Basically, it is the 1/3 removal of the epiglottis, and that to suprahyoid epiglottis, so you're not giving any aspiration issue. And if you go further lower down, below the pharyngoepiglottic folds, you can even cause bleeding because you're going to injure the superior laryngeal vessels. Now, remember one thing, in the anatomy of the base of tongue, if you go 1 centimeter laterally on either side of the midline, you're safe. But if you go beyond that, you're likely to injure the lingual arteries. Now, the techniques, everybody knows Davicini. I mean, he's basically based in Italy. Now, I had a chance to go to him also. He invited me during one of his workshops. And he adopts this inverted pyramid technique where, again, as you go lower down, meaning upper BOT to lower BOT, the length of the incision, meaning horizontally, keeps reducing because you're not going to injure the vessels or the nerves that way. Because as you go in depth, you might even injure the lingual nerve. And now I've adopted the stepladder pattern. Sorry, the other green picture, the rectangles that are seen, this is the technique adopted by Dr. Scott Magnuson in Florida. Now he does a trapezoid resection. The first segment that he removes from the base of the tongue is very thick, and the second one is smaller, and third one is even smaller. Now, stepladder technique, which I have adopted, is, instead of going directly in depth and going beyond 2 centimeters of the depth and causing a risk, you can keep removing little by little, after giving multiple stepladder incisions along with the cautery coagulation mode, and that way you're safe and you do not knock out anything, and your resection is complete. So now you can see the incision that is happening. The right arm, depending on if you're a right-hand surgeon, you would choose the right arm as the cautery arm. So this simple harmonic cautery spatula is used for cutting. And both the right leg and the left leg, you can use for pressing the buttons near your feet. If you want the coagulation mode, you can use the left-hand side. There's also attachment to bipolar cautery and unipolar cautery, so you can choose whatever. And you need an assistant to use the Yankur suctions so that there is no fumes in between, and the left-hand side is a Maryland retractor, where you tend to hold the tissue as well as grasp the tissue. So while you're dissecting, keep on dissecting and keep on grasping more and more, and that is how you will achieve the tunnel. So finally, your new breathing channel should be nice and patent, and that's how you'll get good results. And now, this video will show you the technique of the epiglottoplasty. Now, this is the picture of the epiglottis, which you've already seen. So you, drag the epiglottis, with same Maryland, and you can give an incision either right in the center, or you can give a horizontal incision right in the center. So if you're giving a vertical incision, then you remove the right part and the left part separately. Make sure you're not removing more than adequate, because you're going to cause aspiration. We're also doing epiglottis cancers for this, and it's a wonderful technique. Everything, as I said, is done in the 3D vision. Now this epiglottoplasty or partial epiglottomy is more useful in floppy epiglottis crossing the OSA. And all of my polysomnograms are usually performed 6 months after surgery. Now this FKW retractor or whatever retractor you use, adequate exposure of base of tongue is very, very important. And you might have to keep, readjusting the retractor as you go towards the hypopharynx or the supraglottis in order to achieve better resection and better dissection. So I think it's one of the last videos, but I still want to say the techniques, thank you, the two different techniques. One is to remove the right lingual tonsillectomy, right lingual tonsil separately from left lingual tonsil, but I do an en bloc resection of both. And thank you all for the patient listening. I'm sure everybody is hungry and waiting for it. Thank you. These are some of my mentors.
Thank you, madam. I have a question. Do you combine the nasal or palatal procedures when you are doing the tongue base? Do you do all of them together, or do you do them staged?
Yeah. Good question. If there is multi-level obstruction, all my cases are in one sitting. I never ask for a second sitting. First of all, it's a private hospital, and then the cost issues are there, and every time you don't want to give extra expenditure to the patient. The advantage of TORS in sleep apnea is we never had to do tracheostomy, no nasogastric tubes to put in, and the stay has been only for 1 day, and all our series, there's no extra admission required for a day also.
And if there is
so we're doing all procedures at the same sitting.
And if there is an injury to the lingual artery accidentally, how are you going to control it?
Yeah, good question again. Now, there are a lot of people, now this is one fear people have when they do robotic surgery. First of all, in my experience now, I've seen that all the dorsolingual branches are not, wide or the caliber I'm talking about. They can be easily controlled with the cautery itself. I didn't even require clips to, clip them. So most of them are controlled by cautery. And always remember 1 centimeter lateral from the midline to be safe. And don't go beyond 1 centimeter, on either side of the midline. But in case you have encountered, you can still control under the robot. So far, no case has been converted from robotic to open, but one must know how to, control lingual artery bleeding. In case it is torrential, then you need to expose the external carotid artery and ligate the lingual artery. But thankfully, thank God,
so you take a consent for
required.
that?
Yeah, we take a consent for that. And in all malignancy cases, we already expose.
Thank you.
Ma'am, one question. Yeah. Wonderful videos and beautifully edited, and the presentation is so crisp. Thank you for that.
I was just going fast, lunchtime.
But it is very nice. How do you measure the volume? You spoke about the volume once.
Yes. So we put it in a bottle of saline. We just use little saline, but we've borrowed it from neonatology, that weighing machine, it's all in ml. So it's easily happening.
So what, according to you, the ideal target of this much of volume should be removed?
So I've been removing 25 to 30 cc's of the tongue.
Sorry to interrupt. We can put in a syringe, actually. I've seen Professor Vicini in Italy. He puts it in a syringe, 20 cc syringe, whatever he has removed, and approximately he calculates.
I'm using it in a small measuring jar from neonatology. I got it.
He puts it in a syringe.
And a few words about the post-op protocol.
Yeah. First of all, pain relief and counseling for pain is very, very important before you take up a case for TORS. A lot of, and that too, in my series, I've seen that Indian patients complain more of pain as compared to Africans and Russians, etc. So what we do is we give pregabalin along with other pain medications, and pregabalin we even give it for 3 weeks. And gargles are very important, betadine and hydroxyl, and steroid, like oral steroids. Of course, intravenous steroids during the stay, that 24-hour stay, and post-operatively we give oral steroids for about 5 days. So post-op management, no ICU stay required, but in the wards also, we make sure that there's oxygen near the bed, and also we tell the sisters to keep checking oxygen sats every 4 hours. Now, this is very important. And we try to prevent edema. Prevention is more important. During your dissection, if the retractor is for too long, the tongue edema is going to be much more. So the learning curve has shown that, our dissection time has improved a lot, and we don't take more than 25 minutes. And that's how we're not having, significant edema.
So, while operating for TORS, madam, will there be any chance to release the retractor and then later on keep the pressure back so that the edema will go down?
So what I do is, after robotic resection of the base of the tongue, after the base of the tongue resection is complete, and the epiglotoplasty or epiglotectomy, because I've now combined, even if the epiglottis looks normal in dyes, I somehow have started, and I've believed in the literature which has happened, Western countries also, simultaneously do the partial epiglotoplasty. And then I release the tongue blade, because after that only I'll proceed for palatoplasty, because then the robotic arms are off. Because before that, if I do anything like that, then there could be, change in positioning of the arms. Then there can be injury. The arms can injure the lips and buccal mucosa, etc. So I do not want to release the tongue blade with the arms inside.
Yeah. So when compared to radiofrequency and coblation versus TORS, how about the pain score, madam? Is it significantly lower, or is it
the pain
comparable?
score, as I said, majority of Indians do have it. In my series, at least 75 to 80% series, we produced one article already, have significant pain lasting for maximum of 10 days.
Okay.
So the sprays help. Xylocaine, lollipops as well as sprays help.
Okay, wonderful talk, madam.
Thank you, madam. Thank you for the presentation. Now we will be breaking for lunch for 30 minutes. We'll be back at 2 o'clock. Please kindly enjoy the lunch.
Thank you so much, ma'am, for the wonderful insight session, talk about the session. Can I request our chairperson, Dr. S. Vijay Praveen, to please felicitate our speaker, Dr. Kalpana Nagpal. Thank you so much. We will now take a break. Thank you, sir. We'll resume the session after our lunch again. Right now, there is another short 5 minutes we need from our audience. The winners of our quiz. Are all the winners here? 3 winners?
No, I think they are not here now. So I just want to say that the session will continue after the lunch. I am requesting everybody to come back at 2:15 sharp. We have very interesting talks after this. Dr. Nishi Gupta's talk will be there, which is on transnasal endoscopic orbital procedures, followed by Dr. Chandra Jayasurya and Dr. Meghnad. So 2:15, I request all of you to come back to hall.
There's another announcement. Our international faculty, Dr. Chandra Jayasurya, she has made a nice educative video for all our delegates, which will be played now. And I request all our delegates to play it. It's visible. So please make a best use of the educative video, which our faculty has made for our delegates. Thank you so much.
Thank you for coming back. I would like to introduce the next speaker, Dr. Nishi Gupta. Ma'am, she is the Head and Director of Department of ENT at Dr. Sharaf Charity Eye Hospital, New Delhi. Her area of interest is endoscopic lacrimal and sinoorbital surgery. She has conducted multiple workshops on endoscopic lacrimal and sinus surgeries for the past 25 years, and she has multiple publications in this area. Welcome, ma'am.
मैम ऑडियो का वाला मेरे को वीडियो ऑडियो वाला नहीं है इसमें बस पीपीटी खोल लो मेरा Good afternoon. Some of you have already seen this presentation. I would like to thank Sampurna for inviting me for this. I'll be talking on transnasal endoscopic orbital procedures, and this is some of the literature that I've collected over the years during my work at an eye hospital. This is the latest one atlas of transnasal endoscopic orbital surgeries. The book has 50 chapters and 1,000 colored illustrations, and this is our 6th book. As we can see here, most of us venture into the orbit all the time while doing sinus surgeries. So some of the cases, interesting cases that we collected over a period of years, we published, and some of them I'll be presenting here. This is the whole plethora of procedures that we can do through transnasal endoscopic route. A small maxillary antrum that was seen at that time. So the sinus endoscopic surgery role is simple in this case. We need to clear the ethmoids and also drain the mucopurulent discharge from the maxillary antrum. This was combined with the lateral, the orbitotomy by giving an incision laterally with the oculoplasty team. The aim was to explore the floor of the orbit to see any possible combination of the outside fistula with the floor of the orbit. So this radio frequency was used to give incision over the periorbita. The floor was explored, as we can see here. And there was no communication seen, but the dead tissue was removed. And the outside fistula was palpated to remove the bone, which revealed osteomyelitis, and the organism was Staphylococcus, and the child recovered well with the antibiotics. This is the second case that we do often in our institute in refractory cases of thyroid orbitopathy. In a 33-year-old lady who presented with deterioration in her vision, the left eye, despite high dose of IV methylprednisolone. Her vision dropped to 1/60 with restricted eye mobility on the left, and she was taken off for surgery. MRI shows bulky muscles, extraocular muscles, as we can see here. We did only on the left side because there was severe visual acuity loss on the left side. We can see the medial rectus and the lateral rectus, both bulky. And the standard sphenoethmoidotomy with maxillary sinus ostium widening was performed. The main issue in these cases is of diplopia. And if we do only medial decompression, see this is the sphenoid sinus, that's the carotid bulge pulsation seen under the thin bone, this is optic nerve. And the lamina papyracea is removed and the fat is allowed to prolapse into the nasal cavity. The main issue is of diplopia in these cases, so the decompression should be done close to the skull base so that the anterior prolapse is prevented. And if we can, combine it with the, see this is the bone that needs to be drilled near the apex. And if we combine it with the lateral decompression, then the diplopia is minimized, or we can do an inferior, the orbital floor decompression also. So if there is an emergency and we need a fast debulking, then we do some amount of optic nerve decompression also. The patient's pre-op vision was 1/60, and within 5 days the vision came back to 6/6. So that way procedure is rewarding, provided the diplopia is taken care of. This is the third case of a 31-year-old male who had severe proptosis on the left, as we can see here, chemosis, lag of thalamus, and vision loss. Biopsy was done elsewhere and it was non-conclusive, was referred to us from ophthalmology. And on imaging, it was seen that 3/4 of the left orbit was occupied with a mass on MRI. We took up the patient and thought of debulking and removing the mass. It's a firm mass occupying the left nasal cavity. There's no cleavage between the lamina and the mass. The mass was firm. It was not hard, but it was solid enough to not to be debrided. We were not able to debride it, so we divided it into strips, and then debrided each strip and the bigger chunks. This is intraproptosis. Each chunk was then debrided and removed with the forceps. Frontal process of maxilla, as we saw in imaging, was eroded. This was further drilled to expose the medial part of the orbit and deliver this mass into the nose, which was again removed. As we can see here, the mass had to be removed in piecemeal because it was very firm and it was difficult to cut this mass. So it was divided into pieces and removed. Remnant of the lamina papyracea was also removed. A part of the nerve was also debulked since patient had severe loss of vision. So the bone over the optic canal was also removed. The tissue sent for histopathology surprisingly was invasive aspergillosis. Patient was put on voriconazole, and we were able to salvage the eye with complete recovery of vision from hand movement to 6/6 with complete recovery of the diplopia, of the proptosis. Then our role as ENT comes in diagnosis of such cases where this case like this, a 15-year-old girl presented with esotropia and fallen vision to 5/60 in her right eye. One biopsy taken by ophtho team through external route was inconclusive. CT shows a heterogeneous mass lesion in the retroorbital region with the widening of the orbital apex and extension of lesion into the sinus. So the transnasal endoscopic route, we are all familiar with the Denker's approach. So through that approach, this is the nasolacrimal duct, that's the maxillary antrum. This is the roof of the antrum or the floor of the orbit, and we can see such unhealthy look. The biopsy again revealed aspergillosis, and we were able to reach a diagnosis. Again, this case where invasive aspergillosis with the severe vision loss, we have realized that while debulking the lesion, we also do decompression of the optic nerve, like it is an indication in compressive cases. And then we put the patient on voriconazole, then the patient is much happier than just with the biopsy alone. So in this case, we saw this is the sphenoid sinus filled with unhealthy tissue. This evisceration scoop was used to remove all the tissue, and we could expose the optic nerve. Patient had vision improvement and is under regular follow-up. Then this is, of course, lacrimal, very close to my heart, a refractory epiphora with canalicular obstruction. 35-year-old lady presented with epiphora. We can see both eyes full. She had post-traumatic epiphora due to roof collapse on her head. She had undergone 7 surgeries before, but continued to have epiphora. Finally, she was advised to go lacrimal gland debulking surgery because this is latest what the ophthalmic team is doing now, so that they can decrease the tear production. So I thought of taking a chance. I said to myself that we are not losing anything. Patient had canalicular obstruction, upper at 7 millimeter and lower at 5 millimeter. So we took up the patient for endoscopic exploration. You can see a big septal perforation here. This is right nasal cavity, this is left nasal cavity. And we injected the lateral wall like in routine cases. We were not expecting any sac remnant after so many surgeries. So we did this decroendoscopy. This is the intraluminal view of the canalicular obstruction that we could see at 7 millimeters. So this is complete fibrotic obstruction of the canaliculi. So we used Sisler trephine to do trephination of this canaliculi, and both upper and lower canaliculi were trephination was done. This is the post-trephination decroendoscopic view of the canaliculus with a patent lumen. So when both canaliculus were trephined, we used a bicanalicular silicone stent, and the dynamic movement of this stent shows that this ostia is functioning. So this is called, when patient blinks eye, you can see the stent moving. At 6th week post-op, when we removed the stent, patient, the ostia was patent. So patient had almost 95% resolution of symptoms. And before I go to the next case, I would like to speak a little bit about the lacrimal procedures in children. We do quite often in our institute. This is the right nasal cavity, inferior meatus, and this is the distal NLD opening which is covered with a membrane. A condition called congenital nasolacrimal duct obstruction is seen in 6% of children, and in this we just have to pass a probe through the puncta and see the opening into the inferior meatus. So it has better outcome than the blind conventional probing done by many ophthalmologists. And then comes the dacroendoscopic assisted probing. Again, as you can see here, this is 0.8 millimeter dacroendoscope which is inserted through the upper punctum, and we can see the glow of light into the inferior meatus. This is supposed to be more precise way, not needed in every case, but we used a dual camera in this case, a 4 mm through the nose and 0.8 millimeter attached to the camera through the upper punctum with the dacroendoscope, and we can directly go into the membrane and perforate it. Then third one comes the balloon dacroplasty, where balloon dacroplasty, or I would say the lacrimal catheters, are very expensive. So we used the coronary angioplasty balloons. They are cost effective, and they are available in very wide range. So in this case, the only advantage in refractory cases is that it allows the radial dilatation of the opening that we have made, but it is not needed in all the cases. So the procedure is same as in any balloon sinuplasty or any other procedure. This balloon is inflated and is allowed to stay there for 90 seconds at 8 atmospheric pressure, and then it is deflated. Then the balloon is pulled out so that the tip remains in the nasal cavity. So it is approximately at the site of the proximal nasolacrimal duct. And after dilatation, we can see this free flow of dye. Am I running late? No? Okay. This is another case where we were able to salvage the lacrimal drainage system and avoid endoscopic DCR in a child that was referred to us after failed probing. If we can see the intraluminal view, there are multiple concretions into the lacrimal sac. And in this case, even if a probing is done, and the child will remain symptomatic because these concretions will stop the flow of tears into the nasolacrimal duct. So when we saw these tears, these concretions, we can see them dancing to and fro because the membrane is intact at the lower end of the nasolacrimal duct. So this explained why the first probing had failed. So when we examine inferior meatus, we can see this bulge here, and as the probe is passed, you would see that the probe can easily perforate the membrane. The child still had epiphora. So in these cases, we can incise this membrane. We give a wide incision and then push the dicryolates through the through the puncta, through the NLD and sac into the distal end. And these concretions were retrieved into the inferior meatus, followed by a successful syringing. So this child, we could avoid endoscopic DCR. So in such refractory cases, it is dacroendoscopy helps if it is available. So this was about lacrimal. Now we also get cases of optic nerve, post-traumatic optic nerve injury in our institute. Of course, it's a very big subject in itself. So this is about the technique here. This 32-year-old male presented with the history of road traffic accident. And the procedure is same as we do in thyroid disease, where we remove lamina, but here we only remove the canalicular portion of the bone covering the optic nerve. So in this case, post-operatively, vision improved from light perception to hand movement. It is a very, very big topic about the indications and outcome, but I can't cover everything here. That's the optic nerve, and this is the orbit. Coming to the last case, a 50-year-old lady presented with persistent lid cellulitis and discharge following left external DCR performed elsewhere a year ago. And CT scan showed mass in the medial compartment of the orbit. We can see here on MRI, the mass is well localized, and we thought it's a mass and we'll take a biopsy. So we took up the patient. That's the opening of the external DCR here. We can see the fluid flowing into, and there's a mound of tissue into the axilla. When we removed this tissue, we could see some fibers peeping from the undersurface of the opening that we had made. As we tried to pull it, we realized that it was some ribbon gauze that was placed. Probably there was heavy bleeding during previous surgery, and when the pack was pushed, it just took its path along the least resistance, that is through the lamina papyracea into the middle part of the orbit. So we kept removing the pieces, but because it was a long-standing pack, it got disintegrated, so we had to remove in piecemeal. So we opened the frontal sinus to reach the superior part of the orbit, and here we could see the granulations, all these granulomas with impacted gauze pieces. So we removed all this, and once we were sure that you can see the level and the separation of the complete fibers, and after that we published this as supraorbital gossipy bioma, mimicking an orbital mass, an unusual complication of external DCR. So this is pre-op and this is post-op. Thank you.
Thank you, ma'am. That was an excellent presentation.
Yeah.
We can take questions. Can somebody give a mic to Dr. Kiran?
Thank you, ma'am. Thank you very much. May I ask a question, please? We had a 12-year-old kid with craniotubal dysplasia, where all the cranial foramen were narrowed. The child has bilateral visual compromise. One side vision lost, the other side was getting compromised, and bilateral hearing loss, which is moderate to severe hearing loss. So with the opinion of ophthalmic surgeon and also the neurologist, we took up endoscopic optic nerve decompression with orbital decompression. Now my question is, in such a case, would the bone grow back, and what would be the fate of optic nerve decompression?
Can you explain the defect again, why optic nerve decompression was performed?
The optic canal was narrowed.
Okay.
So all the cranial foramina in this condition get narrowed. It's called as craniotubal dysplasia.
Okay.
Some neurosurgeons say that the bone growth will definitely come back, and some people say it would not. So we don't know whether we have done a proper surgery or for a proper indication or not. That's the
But
reason
what was the, of course it's a unique case, but what was the outcome in your case?
The vision where it was lost in one eye did not restore. The other side got stabilized.
Stabilized, meaning?
Yeah, it did not deteriorate. At the same time, it did not progress.
But it was progressing otherwise.
Yes, yes.
I have not done a follow-up of all post-traumatic optic nerve decompressions, but once a certain level of recovery reaches, it takes 3 months. Then
Okay.
it does not deteriorate.
Okay.
I have done around 20, 21 cases. So
Okay.
I have, and of course selection criteria is another point that but I have not seen them deteriorating in post-traumatic cases.
Right. Thank you, ma'am.
Ma'am, we saw a green colored dye you were using to wash while doing the DCR. What dye do you use?
That's fluorescein, which ophthalmologists use in my institute. I learned from them.
Okay.
That's very safe.
And how much does this endoscope cost, which goes through the lacrimal system?
That is around 5 lakhs because you can use the same.
For same silent.
That's the endoscope.
Okay.
That's same as the endoscope. So you use the same camera, screen, everything. Just the endoscope is different.
You use 0.8.
0.8. There are multiple sizes that come, but the smaller the diameter, the worst is the
Quality.
Quality is not that good. And plus, that much of advancement has not taken place in endoscopy, where you could, it's exactly like yellow endoscope, where you put small endoscope and through a side port you can do the procedure also. Because the puncta size is just one. I mean, you can't use that 1 centimeter yellow endoscope into. So it's more of diagnostic thing.
Okay.
So.
Thank you, ma'am.
Foriconazole because it was invasive aspergillosis. We gave oral dose similar in any antifungal like 300 BD, 400 stat, and then 200 BD. And we actually taper it based on the symptoms. We were trying to devise something where we could say that you are going to use it only till this period. Most of the cases we have to, once we stop, we have to start again. But in this case, we used almost for a month After complete recovery, there is no recurrence.
Okay, the minimum period should be given for 1 month.
Not in all the cases. I think we have Dr. Megnath here, who's done much more than me and has more experience. My experience with voriconazole is that I don't know whether I have not searched the literature enough, but there is no study that says that you give it only for this point of time to this particular patient. Because we have given for 1 month, like the lady I showed with optic nerve decompression, I think in last 5 years, 3 times we've put her again for one month. Okay. So I think Dr. Megnath, you can also add some. You can give this.
Yeah. Usually these invasive fungal disease patients, they require the antifungal depending on their immunity. Their immunity is the most important thing. It is a transient loss of immunity or hypoimmunity, then a short duration is enough. But if the patient had the disease without any known hypoimmunity issues, like somebody had an accident, was in ICU for 10 days, the immunity is suddenly dropped, and they develop a invasive disease, then you can give for 2 to 3 months and that's enough. But otherwise, what I follow is complete resolution by MRI and then continue for another 6 months. Okay. And here I prefer itraconazole because of the cost factor.
And hepatotoxicity.
Yeah, hepatotoxicity is also less in Indians compared to the voriconazole. Itraconazole is less in Indian population. Itraconazole hepatotoxicity is more in Western population, but fortunately it is very, very less in Indian population. I have been testing the liver function test. I have done in more than 4,000 patients. I have been checking. I have never seen deranged liver function in the last 4,000 patients.
With itraconazole. Yeah, with vori we have seen. So
vori is more hepatotoxic than itraconazole. Itraconazole less expensive. Only problem where I have shifted to itraconazole to voriconazole is when they develop rash, skin rash. Okay. Around 10% of the people develop skin rash. And in that scenario, I have shifted to voriconazole. But when it is prohibitively expensive for the patient's economic the pocket, then what I do is I continue the itraconazole. I give intermittently, means I give for 1 month, stop for 1 month, rash subsides. Again, you restart, the rash comes after 1 month, again, stop it for some time.
Desensitization kind of.
Yes. Gradually you can.
So there's not a single line answer for using antifungal. I think you have to tailor-made it for the
according to the patient's
according
need.
to the patient.
The most important thing here is the patient's immunity. As the innate immunity of the patient against the fungus is low, then probably they require for lifetime. But if the sudden drop of immunity is the cause for the invasive fungal disease, yes. Then, say for example, pregnancy. After the delivery, patient has developed the invasive fungus disease. Then you give for short duration. The pregnancy is the cause for the invasive fungus disease. In other way. Okay, thank you.
Thank you, ma'am. Thank you. Madam, do you have any experience with treating iatrogenic medial rectus trauma patients?
That's an interesting question. No, I don't have any experience, but I went for EndoKL 2 months ago, and there was a presentation by a European surgeon, and he said there are a lot of articles in the literature he showed saying that medial rectus injury is an irreversible injury and you cannot, and he was really making fun of those presentations. I don't remember his name. Very good presentation by that European surgeon. And what he did, he had showed 2 videos of medial rectus injury, and he said, if you have an external colleague, like we also tell our oculoplastic surgeons sometimes to just put a string to help us identify the muscles. Okay. So he said in those cases you tell your ophthalmic colleague to just dissect a little bit of medial rectus and give you that end into the nose. And you go down and resect the leftover portion which was damaged and suture the 2. And he had shown fantastic results. So I only know that much about. And he said, why everybody says irreversible damage? It is not irreversible. See, and he showed, I think, 2, 3 nice videos. So.
Wonderful, man. That was a wonderful presentation, madam. Thank you. We'll go to felicitation. Please stay on stage.
Thank you so much, ma'am, for the nice. Thank you, ma'am. Here, I would request Sandeep Dachuri and Dr. Vijay to felicitate our speaker. We'll carry on with the session.
Yeah. The speaker for the next session is Dr. Chandra Jayasurya. Madam is a senior consultant surgeon. She worked with National Hospital of Sri Lanka previously and experiences as the president of College of Oto-Rhinolaryngologists and Head and Neck Surgeons of India from 2004 February till date, and experiences as the secretary of Lanka National Laryngectomies Association for the whole country, and experience as member of Board of Study for Otolaryngology PGIM. I welcome Dr. Chandra Jayasurya. The topic is CPAP, patient's perspective.
Is it okay? No? Huh? Huh? Like this. Huh? Right? Can you turn it on? So I'm going to talk on CPAP perspective. Thank you very much, Dr. Sampurna and the team for inviting me. Every day you are proving me you are Sampurna. You stand for your name. I'm going to talk about my Sri Lankan experience. So it is actually underdiagnosed in our country. People were not aware. You can see how I'm trying to improve the awareness by making this public video also. And mass media, we did one day, the whole newspapers, all the radio channels, all the television channels, same time we advertised, same day. So that by that way we improve the awareness. Now people know a little bit about OSA, but unfortunately they don't all come to ENT surgeons. Mainly the chest physicians have taken over. I don't know how, because the obstruction is in our territory. I don't know how we have given up, and they are taking over the management. So I think my main aim is to invite the Indian surgeons to encourage the management of OSA should be by us, and then the secondary part by the chest physicians. Few centers available. We have only totally patient-funded CPAP. We don't have government-funded CPAP. We insist on CPAP trial. Initially, we were giving option whether patient can opt for surgery or CPAP. Now we never do surgery without a CPAP trial. Especially when they have excessive daytime sleepiness, when they are symptomatic, AHI is not the only guide to prescribe CPAP. So we have to be very grateful for this man, Dr. Colin Sullivan, who invented this. And our Sri Lankan supplier is with Mr. Dr. Sullivan recent photograph.
So now you can see the American College guidelines. All the strong guidelines and the conditional guidelines, we are nowhere. So if not even ENT examination is mandatory. So I hope the 9th guideline will be ENT examination is mandatory for OSA patients, because we know the CPAP failures also we can help. So this is our treatment protocol. We take detailed history and examination, and we do the awake examination in the clinic. We have both sleep study level 1 and level 3. Level 3 is more popular than level 1 because, you know, it can be done at home. And drug-induced sleep endoscopy in selected cases. We can't do every patient drug-induced sleep endoscopy, but I feel if before sleep app also, if we can do a drug-induced sleep endoscopy, we can exclude all the contraindication for CPAP. And in surgery, some patients, when they fail CPAP, we give surgery, and otherwise, unaffordability of the CPAP machine also one indication in my country, because it's so expensive. It's more than 400,000, the proper one, and the Chinese alternative with our economic crisis, very few people can afford CPAP. That's another issue. Maybe in India also the same. CPAP machines are expensive and patient funded only. Do a government give CPAP machines? No. So I make it a chance to promote my country also. This is 5,000 elevation hot and plains. I know we have many Indian visitors coming to Sri Lanka. You make sure you visit this heaven on earth. So you can see the obstructive sleep apnea, why we are not invited to manage this all over the world, because you can see the obstruction is mainly in our territory. So how it works, machine generates positive pharyngeal transmural pressure so that the intraluminal pressure exceeds the surrounding pressure. So as a result, respiratory events due to upper airway collapse are prevented. So air column acts as a stent here. So the impact of CPAP. Now we know we call diabetes is mother of all diseases. I think we can call CPAP also same. You can see it affects every system. So diabetes is the mother of all diseases, and it looks like the father of all diseases. Because all the systems are affected, cardiovascular, cerebrovascular, liver, diabetes, everywhere. You can get, so when we give CPAP, it's a gold standard. So it improves daytime somnolence and reduce choking, gasping, and improve the quality of life in bed partner where motor vehicle accidents are reduced. So though it's gold standard, we all know the adherence is poor, and it has helped to control the resistant hypertension patients also. So there are studies, randomized control trials with 24-hour blood pressure monitoring. The studies are conducted. So what are the CPAP adherent targets? Sleep. So though the 4 to 5 hours is the target hour, when we inquired from the patients who like CPAP, they wear it for 7-8 hours, because if they really like it, they don't remove after 4 hours until the time they go to bed, until they wake up, they wear the CPAP machine. So what are the factors affecting the adherence? It's severity of subjective sleep-related symptoms. If they are very sleepy, and if they know there's a machine and they have heard of the machine, they have the knowledge on CPAP effects, then they will start using it, and they will be very grateful for the machine also. And the narrow upper airway hinders CPAP use. We know when there is nasal obstruction, the upper airway resistance goes up. Then we have to increase the CPAP pressure. When the CPAP pressure increases, patient won't be able to use it. It sounds comfortable. So that's why it is very important to examine the nose and the throat to identify these conditions like septal deviation, and we can, you know, as ENT surgeons, we can manage these conditions very easily with the help of coblation, as Dr. Shakuntala already did a very nice presentation. So adenoids in, even we have seen a lot of patients having adenoids in adults, although it's called a childhood problem. Many adults have got large adenoids. So, and palatal collapse, we know collapse epiglottis, if it is real collapse epiglottis, they will never benefit from CPAP machine, because actually they will get worse with CPAP machine. So that's why I mentioned, before we prescribe CPAP machine, if we can do a drug-induced sleep endoscopy, it is more beneficial. And I heard that we can do CPAP titration also with drug-induced sleep endoscopy. I also got a lot of information from Dr. Srinivas Kishore's 3 lectures given in Sahasra ENT Foundation. I'm only given 15 minutes here to talk, but it's about 8 hours talk, 3 lectures, 2.5 hours each. So you all can listen to those 3 lectures. You can get a lot of knowledge about obstructive sleep apnea. And the CPAP use also, not only surgery, drug-induced sleep endoscopy. So if there are problems of CPAP, it hinders the use. So there's a very nice study conducted in Singapore. They have conducted a big study about 751 patients, and they were given 1 month CPAP trial. It was found that if someone is using CPAP for 1 month, it is likely that they will use it long term also. So they have selected few patients, about 44.9 patients were adhered to CPAP therapy during first month of trial, and even after 1 year, out of them, 78.5 patients was after 1 year also they are using the machine. So I think this CPAP trial was given free of charge. So trial was not charged, but they had, even in Singapore, it's patient funded, not government funded. But the trial in my country, the problem is the mask is 25,000 rupees. So although the machine is given free, the mask cannot be reused, so they have to buy the machine. So some people cannot afford to buy the mask. So, so that hinders the trial also sometimes. So these are the common problems of CPAP. Some people, even you are given the machine free of charge, they don't use it. I have an audio clip about a person they were given free of charge in the West, in the Switzerland. Can't use it because she's claustrophobic. And these are the things: aerophagia, nasal congestion, skin irritation. We can sometimes see ulcers on the nose, because when there's a nasal obstruction, we increase the pressure. So then again, they can get problems because there's nasal obstruction, but the other dispensers of CPAP, they increase the pressure without looking at the nose. And they have dry eyes, dry nose, bloating, skin irritation, all these problems. If they have these problems, I think we have to always educate them about these problems, and then we have to tell them that there are solutions for these problems. Some of these problems are already solved by giving, because now it's humidifier is incorporated in the machine. Earlier it was optional. So how to improve adherence? One of the ways is we have to ask the person to fix the mask and do some reading while awake. Do some work with, because everyone reject the mask. Mainly the main problem is mask and the tapes. So we can treat the nasal congestion by giving steroid drops, and proper fit prevents over tightening. Wear the mask and tube during daytime, and it's very important to motivate and help the patient to complete first month of CPAP use. So I think that way the supplier also will look at the SD card, and then they will check the HI also. So that way they can prove the patient by this trial your condition, and even the patient feels that they are better, and there is objective proof also to show that the first month trial will help. Objectively we can prove the patient. So sometimes we can give a desensitization period. If patient doesn't like it, we can stop for some time and restart the whole procedure again. And if we think DICE is indicated, if we can do DICE before CPAP, it's better, but otherwise we can at least do. The problem is the chest physicians don't get ENT surgeons advice even if the patient cannot use it. And I found their follow-up is very poor. I inquired from the chest physicians because they are dispensing more machines than us. So then I inquired, do you do follow-up? They said no, they don't. Only the supplier, CPAP machine supplier doing the follow-up. So patients, they don't know. The patients are just lost after supplying the CPAP machine. So these patients, about 24 patients have undergone surgery during their first year of CPAP, when the nasal surgery, palatal surgery, and combined surgery. All these after this surgery, their adherence improved. We can show these studies to the chest physicians. If we have a way to show them, I think we can improve the adherence. So early surgery for patient who fail CPAP, and it's both ways. Maybe we are doing corrective surgery for OSA, or to improve the CPAP use, surgery will help. So you can see the most beautiful sunrise in the world when you climb this mountain. What we found, so we also did an audit study on 93 patients who have used CPAP. 16 of them were females and 77 were males. Actually, I did in 2018, I think Sampurna can remember, I did a presentation, and we managed to follow them up after so many years. I called everyone, and actually still using, 72 out of 93 are still using CPAP. 17 out of them are unhappy about CPAP, and this manual CPAP use is not essential here. And 21 out of 93 abandoned CPAP due to various reasons. You can see actually weight loss played a major role because there's bariatric surgery, and some people underwent bariatric surgery, so financial difficulties also a cause. And then we did another audit about 93 patients during 1 year. They underwent sleep study, furthermore, we did another study, 180 patients who underwent sleep study, a single center, January 2023, 150. 30 patients referred by us, ENT, though the rest of the 120 patients said they were not referred to ENT surgeon. They were referred by physician and chest physician and the physician. And 28 of them improved due to weight loss because with the financial economic crisis, they could not buy CPAP. So they were very motivated to lose weight. So in a way, they have managed to get cured because they're young people. And then this is our success story because we are dedicated staff, only one supplier. It is monopoly, but in a way monopoly is also good because they have dedicated staff. And patients have self-funded machine. You know, when you give something free, they are reluctant to use it because they have to spend money, they will use it. So we have some drawbacks, the cost and anatomical physiological limitations. I have we have one success story to listen. Speaker.
I was diagnosed to have severe sleep apnea 15 years ago. And thereafter I started using a CPAP machine. Now the symptoms I had were, I had daytime sleepiness and my oxygen saturation dropped to about 70 during the apneic attacks. Now after using this, daytime sleepiness has disappeared, and also I use the pulse oximeter nowadays, which they are available cheaply from many places, to monitor the effectiveness of the treatment. So to find that now my blood oxygen saturation level never drops below 90 during sleep. So I'm quite happy about the treatment, and I think this will be valuable for those who suffer from apnea. Thank you.
There is one more unsuccessful story. We can listen to that also, and then my talk is over. No. To just play, but it is half played.
I am Sagari, staff nurse working in Switzerland. I was diagnosed with sleep apnea. My symptoms were daytime sleepiness and heavy snoring during sleep at night. When my sleep study was done by experts, I had a moderate degree of sleep apnea. Then I was given a CPAP machine from my medical insurance. Though it was given free, I couldn't use it because I had claustrophobia and I really hate that machine. I kept it for 2 days and I couldn't sleep at all with the machine. I didn't go for another checkup to see why I can't use it. I still have symptoms of sleep apnea because I can't use my machine.
Okay. Thank you very much. It's the end
Thank
of
you,
my
madam. Thank you
presentation.
for the presentation. I would like to invite the next speaker. I would like to invite the next speaker, Dr. K.R. Meghnad sir, who does not need any introduction. He is the Managing Director of Ma ENT Hospital, Hyderabad. His special interest is in laser-assisted surgeries in ENT, cochlear implant surgery, anterior skull-based surgeries, and he has pioneered a lot of concepts in coagulation, which are famous. And he has published around 14 papers in peer-reviewed journals. Welcome, sir.
Good afternoon. Yeah, we had a talk on sleep. I think we should wake up from the sleep. And thank you, Dr. Sampurna and her team for giving me this opportunity to be with this August gathering. So my interest is always, in ENT, we have a bad reputation that ENT surgeons, they do the surgery, but again, most of the time it fails. It is not most of the times, but there are good significant number of failures in our surgeries. Say it is a canal wall down mastectomy or say a sinus surgery for various reasons. Because one thing what we have not understood is, for example, sinusitis is essentially a medical disease and we try to control it or correct it with surgery. And similarly, in the ear also, there are a lot many healing factors which are having an effect on the ultimate outcome. So, one of the reasons for the failures in our tympanoplasty, let us study. So, actually, initially I was trained in underlay technique and I practiced for nearly 5 years. So, I had some problems. The one is the anterior residual perforation, mucosalization of the neotympanic membrane, and recurrent automycosis because of the weeping drum. I've seen good number of patients having mucosalization. What happens is, patient comes, sir, I'm having little wetness in the eye. I think operation is failed, sir. But you see, you do the sagalization, drum is intact, neotympanic is intact, but there is some mucoid discharge collected in the canal. And these patients have the high risk of developing recurrent automycosis, especially when they are coming from the coastal areas where high humidity is there. And so what is the answer, other answer? Can I do the onlay? When I looked at the literature, and fortunately I was exposed to the onlay tympanoplasty by one of my consultant in my student period. But I have seen few of cases getting into graft lateralization, poor hearing outcomes, and very rarely you will get an epithelial parallel because of the retained skin. So I understood. So interlay is probably the good answer, and I started doing interlay in almost around 2000. So here, we elevate the fibrous layer of the tympanic membrane all around 360 degrees. And anterior canal skin is also elevated. Many times you cannot see because of the anterior bony canal hump, then you do by feel. And most important thing is, while elevating the tympanometer flap, leave the mucosa of the middle ear in situ. Don't elevate along with the tympanometer flap. So the general practice, what we do in a stepidotomy, when we do the lateral tympanotomy, we elevate the annulus, then we enter the middle ear, and we puncture the mucosal layer as well. The mucosal layer of the, which is the medial wall of the tympanic membrane, is retained along with the tympanometer flap. Whereas when you are doing it for a tympanoplasty, we recommend to leave it. So the new graft will sit as a sandwich. I like sandwich. So if at all some mucosa could not be removed, left onto the TM flap, we excise that part of the TM flap. And now we keep the temporalis fascia graft onto the bony canal all round. So no edge of the graft is left into the middle ear, unlike underlay technique. So what is this content? Now this is the mastoid antrum which we have opened. So that is the canaloplasty which was already done, and we use cotton balls, and we are identifying the annulus. We are using that is the white annulus. Now watch this point very carefully. What we are doing, see, that is the mucosa. This is the mucosa. We are elevating the annulus and fibrous coat, leaving the mucosa. So I have been doing this surgery, but when I talk to my other peers, they hardly accept this. Is it possible to leave the mucosa and elevate the fibrous coat? Thanks to good quality microscopes and cameras, we are able to demonstrate today. So that's how we have elevated the, so same, once you got the right plane, you continue it all along. So usually what I do is, I elevate the TM flap in the posterior inferior quadrant, then I go to the superior area. So here, another important thing is where you can leave the mucosa is along the handle of malleus. So here, you have to denude the handle of malleus completely. And of course, that you can see the chorda here. That is the chorda, and we are elevating. So what happened? So elevating the skin or the epithelium of the tympanic membrane and mucosa together at the region of the handle of malleus, and finally you have to excise it. So then go anterior to the handle of malleus. You can see thick glue coming out. So you can see the annulus. Again, here you can see that is the mucosa. This is the mucosa, which we have not elevated. We left it there. So the next step is to elevate the anterior canal skin. So we are elevating with it is semi-blind procedure by feel using the circular knife. And how much you have to elevate? You have to elevate till you can fold the anterior canal skin. So that is the end point of elevation. And check you can see here, little mucosa is, which came along with the TM flap from the pars flaccida. All that mucosa is to be excised. If you can't excise the mucosa alone, don't mind excise along with the fibrous coat and remaining skin. No worry whether you have a small perforation or a large perforation. It heals very nicely. And another important thing, what I feel in our to have a good outcome, what is the cause for this perforation to remain? Many perforations do heal. Majority of the acute suppurative otitis media perforations do heal. Why some turn into chronic suppurative otitis media? The reason is the mucosal folds. That is, I believe. So if you keep exploring and look for the mucosal folds, in all CSOM cases, you will see a reason. And one of the reasons is persistence of the mucosal folds which block the ventilation and drainage of the mastoid antrum. In fact, mastoid cellular system acts as a cushion to tackle the shock of eustachian tube block. And when this is not functioning or blocked, you will have the problem. So always you do the transantral atticotomy and expose the entire attic and clear the mucosal fold. In this case, I will show this part again. So this is transantral atticotomy. I have not shown completely in this case because this presentation is on the interlated pornography. But I thought this is an important point. Sorry. See, that is the medial inguinal fold. You look for it, I promise you, you will get some or other reason for the CSOM. Some anatomical factor. Now we have to design the temporalis fascia here. So this fold, that part of the graft will go anterior to the handle of malleus, and also that fold will go on to the bony canal. So we give a cut for the handle of malleus. So it all depends on the dimensions of the middle ear. So that this part will go on to the bony canal. This part will be anterior to the handle of malleus, and this is posterior to the handle of malleus. And next thing is, why do we fail? If you use only temporalis fascia graft, we have seen successful tympanoplasty for a decade, and then you will see the failure. Why? Why this happens is, if you look into the types of collagen, the temporalis fascia has something between type 1 and type 2 collagen. And type 2 collagen life is around, half-life is around 5 years. So after 5 years, if you look at the tympanic membrane thickness, it will be only 50% of the original thickness. So after 10 years, it becomes 25%. Then it is likely to perforate. So how to avoid this? So you look for a collagen which has a more half-life. So type 6 collagen or type 5 will have a half-life of 60 years. So what is this? Where do you get this type 6 collagen? You can see in the periosteum, perichondrium, and tunica adventitia. So what is the best material to graft is tunica adventitia. The second best is the perichondrium. Tunica adventitia is a wonderful thing because it is very vibrant like the original tympanic membrane. But getting a large vein is difficult. So if the patient is having varicose veins, then you can take a small bit and it's a wonderful thing to use. So otherwise, we will use the perichondrium. Sorry, some of the field is not visible here. So now we have to place the graft. So once again, ensure that we have elevated the anterior canal skin. Now what I do is, I do keep temporalis fascia. And below the temporalis fascia, I'll be using the perichondrium. So many times people ask me, why not only perichondrium? Why temporalis fascia and perichondrium? The reason is, initially I tried with the perichondrium. The growth of squamous epithelium over the perichondrium is somehow very slow. I don't know the reasons. So what happens? It takes long time to heal. When it takes long time, there is a risk of granulation tissue formation. So this is the reason I started using temporalis fascia as well as the perichondrium. I know the temporalis fascia is going to disappear after a decade, and what is going to remain is perichondrium for the patient's lifetime. So here, once it is successful, this kind of surgery is successful for the lifetime of the patient. Even if the patient develops some automycosis, some infection, even if it perforates also, this will heal again because the collagen is there. And I think that's enough. I think, so we have kept the temporalis fascia there. So next we will keep the perichondrium. I have done 4,400 surgeries in 22 years, and these include 1/4 cholesteatoma cases also, and our mucosal incidence cases are nil. The residual perforation are in 2 cases, which is less than 0.5%. This is my honest result. Thank you very much.
Thank you, sir. That was a wonderful presentation. We'll take questions.
Yes, please. Good afternoon, sir.
This interlay tympanoplasty, at once it was started with Dr. ABR Desai, the concept came far back. Then Ashim and Dr. Satish Jain, they started doing this interlay. Theoretically, I do interlay, sir, since my residency. I was doing it during my residency, 2nd, 3rd year by default. I didn't see anyone doing interlay. I was doing it by default. I was elevating the annulus and the rest of the things are lying there. When I saw Satish Bose there in 2005 in one of the conferences, oh, I do it. So then I came to know this is something like interlay. But if you go by the theory, the tympanic membrane is 130 micron. 100 micron is your epithelium, 29 is your fibrous, and 1 micron is your mucosal layer, that is lamina propria. It is humanly impossible to dissect 1 micron of 129 micron. So what happens there, basically, your fibrous part of the residual TM, which remains there with the mucosal, and the annulus is a condensation of the fibrous layer which comes with your epithelium. This happens in the interlay. So I've been doing that in thousands of cases. Since 2004, I started doing. But over the years, I have observed, maybe this is an absurd idea, and this has been an absurd idea to many of the people. Still 50, 60 people in India are doing this job. What we started doing, Dr. Suri Prabhu at first came with the idea because he saw these mucosalization of his own cases and other cases. So he came up with an idea of total annulus excision. Because whenever you are elevating, you are leaving some mucosal glands there. And we have histologically proven that with the biopsy specimen of the residual TM. Even Arshad Hussain at Bangalore he has done, me and Dr. Amit Rana at Bareilly we have done so far histological studies. So some mucosal glands are entrapped there in the within your graft and the epithelium layer, which keeps on giving you this mucosalization and weeping tympanic membrane. So the neotympanum, and the second thing, whenever you put in a graft, you are having that epithelium, then the graft, then fibrous layer, then the epithelial layer, the mucosal layer. And when you are putting it from posteriorly and you don't tuck it, or you don't do a circumferential, posteriorly is thick until it is thin. Your tympanic membrane is not uniformly thick. It is not a trimeric membrane. But if you do a total annulus excision with the residual tympanic membrane, what do you have? You have a cut edge of the epithelial layer with the shooting blood vessels. Then you do have a lamina propria inside. And your graft stays there, sir, if you do have this architecture there. So what will form? We elevate posteriorly, we cut the posterior flap till the annulus, we make circumferential cuts along lateral to the annulus, remove the whole tympanic membrane, and then we put in the graft, elevate, just like you did in the anterior part, anterior mucosal elevation, so that your 360-degree elevation should not be there. We leave that vascular strip as you left there. And believe me, I have done a randomized study. It is published in JLO. None of the cases had any residual perforation till date, 5 years follow-up now, no mucosal. And by doing this, you are a bit lateralizing the tympanic membrane, giving an air bubble in the middle ear. So a middle ear space elevated, a good trimeric physiological tympanic membrane forms uniformly thick. You can try that, sir.
Sir. Yeah, I do.
So
TAE.
that is something
this is
I
total
want to put
TAE,
in. Thank you, sir.
That is TAE, total annular excision. I do in some cases, but that is not required in every case. Okay, when I do that, when I do interlayer, I would like to explain here. The most important thing here is what he said is absolutely true about the normal anatomy and dimensions in a normal tympanic membrane. But in a case of CSOM, chronic suppurative otitis media, the mucosa is also 100 microns. Sir, please check, measure the things in a case of chronic suppurative otitis media. So if you go back to the elevation, how we did here, you can see the mucosa very clearly. So,
sir, we are not able to see.
Okay, doesn't matter. So here, what you see here, this is the mucosa there. So are we seeing the 1 micron mucosa? No. This is nearly 100 microns. I have done the measurement. This is 100 micron size. So why it is 100 micron? Because of the chronic suppurative otitis media, inflammation, and thickening of the mucosa. So in a chronic suppurative otitis media, it is possible. But can you do for example, if you are doing a autosclerosis, lateral tympanotomy, you cannot separate the mucosa from the fibrous coat. It is difficult. Thank you very much.
Thank you, sir. Pawan Singhal, sir, we request you, if you have any videos of this total annular excision, if you can edit into a small video and post it in the group, we'll come. Okay.
Congress of Surgeons, ACS Congress. Out of 550 papers, it was the best paper I got in the US at San Francisco. So it was an innovative paper. If you read that paper in JLO, total annulus excision, you would certainly, you don't have to do it in all cases, but you can get an idea what we want to deliver.
Sir, kindly share it.
I'll share on the group.
Certainly. Sir, one question. Dr. Meghnad, one question. Yeah. Yep. Sir, about the hearing outcome, did you find any difference doing this?
Yeah, hearing outcomes in the first year, there will be 3 to 5 decibels less than the only temporalis fascia graft. This pericondium may not vibrate that nicely like a normal tympanic membrane. Maybe 3 to 5 decibels less than the only temporalis fascia. But after a period of 1 to 2 years, the hearing will improve. And these patients' hearing will keep on improving the next 3 to 4 years.
Yeah, thank you, sir.
I think we have to fill state. Sir, please stay on stage, sir. I would like to invite Dr. Jayasurya ma'am.
May I request Dr. Vijay Praveen, our chairperson, to please felicitate Dr. Chandra Jayasurya ma'am. May I request Dr. Sandeep Dachuri to present a memento to Dr. Meghnadhan. Now, may I request Dr. Meghnadhan to present a memento to our chairperson, Dr. Vijay Praveen. Our next session is otology panel discussion. So before we start arranging for our panel discussion, we would like to have a short, sweet quiz. Are you all ready? Yes. Yeah. Hello. As the questions are here. So I request Dr. Venkatram Reddy to please conduct the quiz for us.
I had been given the privilege of conducting quizzes over nearly 2 decades. Well, this is question number 1. Whoever answers this can raise the hand. Is it open to all? Yes? Which is the right answer? Yes, sir. Dr. Vinod. Vinod, I think there are some prizes for that? There are some prizes for that? D is the right answer. Huh? Your answer. But I have not seen your hand. Yes, yes. You may distribute.
We have chocolates,
you have plenty of
brochures,
plenty of prizes.
and BP apparatus, Omron BP apparatus, sponsored by Acme Medical Solutions Private Limited.
May I call the winner of this question? Huh? Yes. Dr. Satyakiran, please come. I need to give this one folder on this. Okay. We'll move on to next question. Yes. Raise. First hand. Yes. Doctor. No. Sripati Naidu, come.
think this is the last question. Next. Don't raise now. I'm just looking at who is the first hand. First hand, first serve. Right answer, please. Right
Please
answer.
raise your hand, please.
Right answer. No.
Backbenchers.
Right answer. No. Right answer. Yes. First no. Remaining. Who said 4? Who first said 4? Please tell honestly. He's the one. Yes, please come, sir.
Number 3.
Please come. He said 4. I think that's all. One more question is there? Only that's it, I think. I was told only 3 questions, right? Yeah? Formulation in what? Anything. Anything open. Okay. I think very difficult to remember anything. Okay. In South Zone Conference, we have 2 prizes. One is South Zone quiz, other is the Telangana quiz. Yeah. I think Sampurna, you can come and tell some question, because you are the conducting this. Please come. Just extempo ask one question and give a spontaneous answer. I'll be watching the hand.
Okay, I want to ask that what is the AHI level in pediatric sleep study when you tell a child has OSA? I will give the options. Madam, she raised hand first. You mean 0 up to 0 is normal. So if it is 1, will you say the child has OSA or not? Yes, so she gets it. So, ma'am, you get a BP machine, free BP machine measuring, put it in your OPD. Yeah, please. Oh, this is what you say. I don't know. You say that, what is that? Sorry.
It's a BMI machine from Omron, body composition monitor.
Thank you very much. I think there is one chocolate left here. This is for the quiz master, I think.
For our panel discussion, may I invite Dr. Ranbir Singh, President AOI Hyderabad and Senior Consultant SMS ENT Hospital and Care Hospital Hyderabad, and Dr. Piyush Sarkar, HOD of ENT Department, Central Hospital, Guwahati, Assam, to chair the session. panels will be there. Yeah, I think that should be there. Sir. And I would request our panel moderator, Dr. Pawan Singhal.
इसका चालू है? Yeah, sure. Meanwhile, I'll arrange the things.
Should I do it? Pawan Singhal.
Yeah.
It's great pleasure actually introducing Pawan Singhal, sir. I'm one of his fans. So he's senior professor and unit head at SMS Medical College, Jaipur, and is president of NES and Medical College Teachers Association of Rajasthan, past secretary of NES, executive member of AIO, FHNO, and All India Rhinology Society. Sir, which society is left, you have to tell me. He has been instrumental in many achievements and activities of AIO for last 3 years.
I'm not there with sleep apnea. Buddha is going to make me a
as governing body member.
Yeah.
He has been instrumental in many achievements and activities of AIO for last 3 years as a governing body member. Pawan Singhal is a gold medalist in MS and is an international fellow. He has more than 50 articles in international and national journals and has innumerable awards and accolades to his credit. He has many awards for his, and including the most reputed state award for His Highness the Governor of Rajasthan. So, welcome, sir, to Hyderabad. We are really indebted to you because you have come all along to share your knowledge from Rajasthan to Hyderabad.
Thank you so much, sir, for kind words. So, with the panel, I would like to invite our panelists there, Dr. Anand Acharya. So, Dr. Anand is the superintendent of government ENT hospital at Koti, Hyderabad. There are only 2 separate government ENT hospitals there in India. Is one in Hyderabad and one in Mumbai. That's what I think. Please have a seat, sir. Thank you. He has got a special interest there in rhinology, otology and all. Second, we do have the stalwart, Dr. N. Venkatram Reddy, sir. We have learned a lot since my residency. I'm seeing him. He is professor in Bhaskar Medical College with senior consultant in my ENT. A practicing ENT surgeon for past 29 years, has got an experience of teaching people for more than 20 years at Osmania and presented more than 35 scientific papers. Now this 35 must be going more than 100. This is an old figure, I know. He has published many publications, editorial secretary there in IJOHNS from 2005 to 2012. You know, that was the golden era of IJOHNS when Dr. Venkat was there, Dr. Dwarkanath Reddy was there, and Dr. PSN Murthy was there. All these 3 people, they are credited to give impact factor to IJLO. So this was a golden era for IJLO. To start with an impact factor, I still remember that because I was a budding resident, a young consultant. I was always thinking of publishing my things there in the IJL. It was a big thing to get a publication there. So he delivered many guest orations. Now he's organizing secretary. He was organizing secretary of the Asia Oceania. And now he is going to hold one of its kind South Zone conference, which has got more than 800 registrations till now. And the figure will cross 100 for such a conference. It is going to be a remarkable one. Next in the panel, we do have Dr. Ashok Moganti. He's a consultant ENT at Medicover Hospital. Dr. Ashok has got more than 14 years of experience working with reputed hospitals like Dr. Rao's ENT and KIMS. And he possesses clinical skills including microscopic, endoscopic, and microlaryngeal surgeries. You are most welcome to the panel, dear. Next we do have is my friend Dr. Shripati, more of a Jaipurite rather than being a Hyderabadi nowadays. You would have seen more of his this persona there in Jaipur with Satish Bose. So he is an associate professor with Pratima Institute, and extensively trained in anti-electrical skill base. I used to, even 10 years back, we used to discuss about the skill-based approaches, and used to find like we can have some new approach which could be easier one to. So he was like, he got this phenomenal thinking that in skull base I used to see. And with Satish Bose, who is sort of, he sleeps by standing, and he used to be by his side. So it is his association with Satish Bose, and I think all these academic achievements he has got is negligible in front of his knowledge about the subject and the workshops he had attended, and now he is training people in the workshops. The next on the row, we do have Satya Karan, who was the first one to get award from this quiz. So most knowledgeable. He has been working on his toes since yesterday. We have been seeing that. He was managing each and every academic activity. Dr. Satya is assistant professor at Uthmania Medical College, senior ENT consultant, cochlear implant surgeon with Rainbow. And he has got advanced implant training from Institute of Cochlear Implant at LA in US, clinical observership at Department of Neurology at Johns Hopkins. And now he has been on the World Skull-Weight Foundation with Dr. Sampath. Together we have shared the workshops. And I also have got a connection with Johns Hopkins. Recently they have made me a mentor to their tobacco control program. That is a fellowship course there. So 2 fellows would be coming to my place from US for tobacco control. So to start with, the agenda is to just give a brief overview of tympanomastoid surgery, indications, surgical techniques, more about complications and patient outcomes. The history, it started somewhere in ancient times. People used to have a chisel and hammer to open the skull bone, and then used to drain the mastoid abscesses and other things. Then came an era of barber surgeons. Barbers used to be called to drain the abscess from the back of the ear or maybe in the cheek and something like that. Then came an era of budding otologists, innovative surgeons who thought of techniques like Schwartz technique by Schwartz, Toynbee and all those people. Then came an era of William House, if you talk about any head neck area, William House has done something there. So this was the most innovative era in mankind about head neck and otology. And then in the modern era, we are going through microscopes are coming up neck to neck with endoscopic techniques. Then you have got navigations, you have got many other modalities coming up to ease our life operating, to reduce the complications, improving results. So, chronic otitis media, chronic suppurative otitis media, the term has been obsolete now. We used to divide them in tubotympanic or safe or unsafe. More of it is a mucosal disease, which could be an active mucosal or an inactive mucosal, then active squamous, which is basically a cholesteatoma, frank cholesteatoma to inactive squamous, that is a retraction pocket to the heel tympanic membrane, which might have some tympanosclerotic plaque thereon. An overview of mastoid surgery is always a puzzling thing. We used to call etechotomy, scototomy, etechotomy, editotomy, editomastoidotomy, something like that, going inside out, going outside in, intact canal, combined approach tympanoplasties. So many names have been given to mastoid surgeries, and always puzzling for the residents to what should be done, what should not be done. Then comes a more logical thing, is like if you are keeping an intact canal or you are doing the canal down. So it's an intact canal or canal down technique. In intact canal, you can go and drill the epitympanum and reconstruct that back, and you can do a cortical mastoidectomy altogether. In intact canal, also you can go till the antrum, and in canal down, you do a canal down with or without grafting or osteoplasty and all those things. Indications, all these surgeries, primary disease or tympanomastoid surgery, or maybe an approach to the other things like maybe the glomus, which is a misnomer, paragangliomas, middle fossa approaches, or going through the tumors in the petrous apex, or going more medially for CP angle and all those things. What you do is, basically, you do an hearing assessment, you do an examination under microscope, which I have shifted to autoendoscopy prior to surgery. In spite of doing an EUM, now I'm doing an autoendoscopy, and I get more and more, what do you call that? More information as compared to microscope. But one thing is lacking, that is suction. So now I'm also developing the technique of suctioning in my OPD itself, and I do an autoendoscopy while suctioning those things. So, and imaging, you know, there have been a lot of papers about HRCT and CBCT and MMR. CBCT slowly is creeping in among the temporal bone pathologies because lesser of radiation, more condensed and more focused radiology you get with CBCT. And now I'll ask panelists, any of the panelists, do you ever do a vestibulometry in all these routine cases of tympanoplasties and mastoids?
Clinically, if you do the fistula sign, if it is negative,
yeah,
I don't think you have to proceed to vestibulometry. And if Romberg sign and neurological everything is normal, there is no need for a gamut of vestibulometry tests.
Any other?
In chronic otitis media, who is planned for tympanoplasty or mastoid surgery, no vestibulometry is required.
No.
In my practice.
Okay. Same thing. So I've planned the panel like this. I've kept a case. I'm showing the surgery I've done, and we'll just discuss the relevant clinical practices. I'm not there to talk about evidences there. I don't want to quote any paper there, because we always don't go by the papers. These are experienced surgeons sitting there. We can use their experience, how do they do the things, and what results they are getting, and how to modify the things. That's why I kept the heading consensus over controversies. So there would be a lot of controversies created by the panelists, by me. I'm the most controversial fellow you have been seeing since last 2 days. So we have to reach to some consensus over these controversies. So this was a 30 years male, right ear discharging for 2 years, decreased hearing. You can see the audiogram. And then it was having, according to the nomenclature for the residents to report it during the examination, it's right chronic otitis media with inactive squamous disease. To see this, can you see any cholesteatoma there? So it is not seen. You can see some mucosal disease there in the retracted part. So inactive squamous disease with moderate conductive hearing loss without any complications. Am I right with the diagnosis? Yeah. Even with the retraction pocket, you do have some history of discharge sometimes. Because chronic otitis media, at first, if you see it started with, it might be, have been an acute episode which would have given some discharge, and then it healed, and then the retraction pathology going on, and granulation, but there is a perforation there. So if this perforation tells you there would have been, maybe it is a copious one, which happens there in the squamous disease, maybe a copious one, with some odor, those PG questions, you know. Then, so I planned right tympanomastoid surgery. Anything else you want to put in? Any lacking of information there? With investigations, else of investigation will come. Yeah.
Usually this sort of perforation occurs in the retraction pocket with granulations under the ossicular chain.
Yes, sir.
So maybe it has become better, but you need to explore the ossicular chain to recover his hearing.
Yes, sir. Venkat, sir. We'll discuss about that. Right now, I was just asking about the findings. Did I make the right diagnosis in this case?
Findings are absolutely right, sir. Your audiogram is in support of it. You said moderate conductive hearing loss without any complications. I would expect here the ossicular chain to be intact here. Why? Because at 2000 Hertz, AB gap is quite normal.
But if you take an average, it is more than 45 decibel.
It's better as compared to the other parts.
Okay.
Like low frequencies and high frequencies.
Anyone else differ from his, like?
Plan is right canal wall up mastoidectomy with canaloplasty and cartilage reinforcement tympanoplasty. My
Canal
plan
wall
is that.
up or down?
Sorry?
Canal
Up,
wall
up,
up.
up,
You
up.
are thinking of?
Up.
For
Intake
plan-
canal. Okay.
Su-
Anyone from the audience? It's
Yeah.
an open forum.
No, such cases I prefer to do endoscopic approach because inactive disease and there is a perforation which is central, there is a cholesteatoma flakes may be there, it may be have a limited disease, it's not progressing. So depending upon
I would
the
decide
imaging,
after opening the mastoid. sir.
imaging.
So Venkat
after,
sir,
after
Venkat,
imaging.
you are a proponent of the endoscopic approach.
Yes,
in
yes,
this case,
yes, yes.
I've seen your videos, sir, and
Yes.
we were there together in China also.
Yes, yes, yes.
Yeah. So we were on a mission in China for 10 days. Friends of China Society, me and Venkat sir, in 2017 or 18 somewhere, 16. For 10 days. So he showed wonderful things there in one of the Chinese hospital and
No, you're mistaken. I think Dr. Mohan Reddy was there.
Dr. Mohan
I was
Reddy was
not
there?
there. I was not
Okay.
there.
So,
but
sir is-
I do.
sir is
I
in
do lot of
favor of-
endoscopic ear surgeries.
Okay.
Lot of endoscopic
So
ear
sir
surgeries.
is in favor of endoscopic approach for this patient and
And without
three
mastectomy, sir?
three young people.
Without mastectomy?
No,
You are saying
I
intact-
go for
intact.
imaging. The imaging shows there's nothing much, showing. Then
Yeah, even with the endoscope, you can do inside out a bit
you can
and
do.
see the
You
disease
can
and
do limited articotomy, still you
reconstruct the
can do
defect.
it.
Done.
So his point is very well valid. Looking at this picture. So now we move on. Imaging. Which imaging you order? Anyone here who orders X-ray?
No, sir.
No, not really. But
Oh,
yeah.
you guys in private? Anyone?
Correct.
HRCT, sir.
Okay, we still send it for X-ray also because we are working in a government hospital.
Yeah,
We still,
X-ray still has in
value.
my practice. Suppose a man comes with a central perforation, 70 plus, a poor guy. So just grafting a tympanic membrane and give it a hearing aid for that age. Why go for a HRCT? Do endoscopic tympanoplasty, give a grafting, successful grafting, and put a hearing aid for him.
Yeah.
So why doing HRCT for a poor man with a comes with a 70 plus?
Sir,
So there is still has some role. It is not completely ruled out. And as a basic investigation, we teach X-ray mastoids, although we insist on CT, temple bones HRCT.
I beg your pardon. I don't agree with sir, but I respect him a lot, definitely. See, X-rays in modern otology is obsolete.
Yes.
Okay. So it doesn't give any information about your editor's patency. It doesn't give any information about the so-called key areas. It doesn't give any information about the ossicular chain. It doesn't give any information about your possible or predictable complications because of the anatomical variations. So
I think, yes, sir.
But the patient did not have any symptoms. I don't know, I have to still open the case and, just operate the case. But the CT reported a superior semicircular canal dehiscence and CT also reported a tegment dehiscence because those things you can't see with the X-ray.
So
because if you planned
you
a
would have got a
CT,
partial view for that.
yeah,
Partial
but
view.
if you do a CT, at least you have planned before the surgery. I will probably expect
the
something.
CT is required only when you open the mastoid. In cases
Yes.
where the opening of the mastoid is not necessary, put a good graft and send him for a hearing aid, then it is not necessary.
Sure, but So I
you,
think-
you
but in
cannot
the-
tax the patient for a CT. So these are very, very, very limited cases, what I'm talking
I
about.
think to cut short the discussion, any other proponent of X-ray? Yes. So the thing is, we were talking about evidence. We have generated evidence over here itself. Only two people who go with this X-ray, he and me, because my limited thing. But in these cases,
This happens only less than 1% of cases, what I'm
Yeah,
telling.
yeah.
It's not,
So-
don't generalize it.
So
It's
the
1 or 2%
consensus-
of cases.
Sir, so the consensus we have reached is CT is a must in all chronic
Yes, sir.
otitis media cases. Got it? So this is a consensus over this controversy between me and all those things. But do you ever advise MR? In which cases you advise MR?
recurrent and complicated of intracranial complication of COM,
Yes.
I would
so
like to
impending
advise MRI.
intracranial or
That's it.
an open or an obvious intracranial.
Correct.
Impending or obvious intracranial.
Correct.
You get both the things done.
Yes.
Anyone who differs to this thing, this is statement? Yes. So you see some mass down there. You expect any other pathology?
Here
there?
we are talking about only chronic
Yeah,
otitis.
chronic otitis media viewers. You suspect, if you suspect, if you see the polyp there and you
there is
feel like
in
it
an
is,
ASOM, if you get any intracranial complication, otogenic
Yeah.
abscess, then we would write.
Yeah.
Depending on symptoms of the patient.
Facial palsy.
and what do you advise to your radiology? You want to get a film or a CD?
CD.
A CD these days?
CD.
Who is not comfortable with the CD?
I usually get films. In case if detail is required, we go to the system. That is something called as a PAC system, available with the radiologist. You make friendship with the radiology team. Go sit there with your radiologist and screen through all the films.
My professor in first year told me this. If you can, please try to marry a radiologist. And I did.
Any second chance, sir?
And you know, this has helped me a lot. And all my controversial cases I discussed with her.
Is that the consensus of this?
The radiologists, nowadays the radiologists are very expensive.
Yeah.
It is high rated.
You have a second chance always.
So we are very clear. We should get a CD there so that on Osirix or DICOM you can see the images progressing. You know, when you see different films, you can't make a linear progression of any pathology. If you want to follow a structure or a disease, if you got this CD, you can follow that slowly moving the cursor ahead. You can make out where this disease is going, what is the relation. So I think it's a consensus these days to get a CD for viewing in the maybe Osirix. How's at the end? Yeah. Yeah. That's what we are getting. You know, at SMS now we have outsourced the imaging. So they are giving me my patients. They are giving me a WhatsApp with the link to that. This is something being done there, and that saves those expensive films of no use. They are carrying it in kilos with them, the patients, no use. They can just have this online or on that. They can, even the patient can send you and you can open it and see the things. So I think it is done. A lot of people.
Can we go back?
Yeah.
Also mentioned about the navigation, backslide.
Yeah, navigation.
So
till date, we don't have a proper
autologic
navigation there in
system, we
lateral
don't
skull
have it. Why?
base.
Because these fiducial markers will come in your way.
Yeah.
It's very difficult. But yeah, maybe in future we might get this.
That's
navigation.
why I put in
Yeah.
there, just to safeguard all the. So navigation, it is future, I'm telling you. Just like in 2004, Indian Radiology Association had their annual conference in Hyderabad itself, Shilparam. I came with my wife, of course. So they had something known as a dextroscope those days. A dextroscope. That was a machine which has got a slot there. You insert your fingers, just like a robotic consoling you do now. There was a tumor there, and you try to remove that tumor, avoiding the vital structures. So this is how the development is going. In 2004, they thought of it, and that came in form of navigation, and now it will be coming for the lateral skull base as well. So imaging can diffusion-weighted imaging replace CT in daily practice?
Only in cases where you suspect squamous type of disease in cholesteatoma, it may. Why? Because in pediatric practice, we are more concerned about the radiation caused by the CT. It may replace CT in future.
Anyone else? If you compare it with CT scan, with cochlear implant planning, do you really want to advise CT and MR in cochlear implant planning?
See, at present we are doing dual imaging, but maybe in future we'll go only with MRI.
Only with MRI. Because, yes. You will see that black line, sir. With high resolution MRs in the coming era, I'm telling you, you won't require a CT for lateral skull base. And that's what many cochlear implant surgeons have stopped advising HRCT. Because on MR, you can very well see all the cochlear ducts and anomalies and all the nerves and their relations there. So there have been indexes, Mary index. If someone uses that middle ear risk index, you use, sir?
I gave it as a thesis to one of our postgraduates.
Sir.
In that, the last smoker one is the one which is forgotten. In cases of failures, smoker is the cause of failure of a tympanoplasty.
It is very true.
That is what I wanted to emphasize also. The rest of all, everybody is talking about it.
And this should be a part of history. Whether he smokes or not. Because smoking does a lot of things, is the cause of a lot of failures in ENT. Whether you operate nose or ear, or maybe the throat itself. Smoking causes a lot of changes your results in benign tumors of larynx as well as the malignant tumors. And head neck also, sir. Oh, obviously, sir. So I left it. So now, you all were in favor to do an intact canal or endoscopic in this case. See to this radiology. Same patient. Now one by one. What will you do now?
See, what I see is only a soft tissue attenuation in the middle ear and the mastoid, which is also eroding the posterior cranial fossa dura. Okay, so not the dura, posterior cranial fossa plate. So I still go with canal wall of mastoidectomy with the tympanoplasty.
See, I would open up the mastoid, explore it, see, clear it, and decide.
Sir, about you?
Tympanic membrane looks intact.
Tympanic membrane was intact.
It was intact, yes.
I'm talking about this CT.
There is attic defect, sir.
You have seen this CT, sir?
Yes, I have seen the CT. What exactly you want to know? The procedure?
No, I just want to know the procedure. We were all in favor of an intact canal. Now, if you see this,
looks like a straightforward intact canal.
Venkat, sir? Same. Anyone else on the ground, on the floor? Intact canal. Okay. So this disease which is approaching the posterior fossa, you could see a lot of things there in the mastoid. Okay, we move ahead. So the approach, which approach you guys take?
I prefer a post-auricular, retroauricular incision approach.
Okay.
Post-auricular approach, sir.
Post-auricular with the flap elevated from the canal.
Sir, endoscopic approach? Transcanal?
Yeah, it depends on the findings actually. I may go endoscopic as well as post-oral also.
In this particular case,
I will do both.
In this particular case?
In this particular case, post-oral is better.
Post-oral is recommended. Okay. Anyone differ? Would like to go for endoscopic approach in this case?
One correction, sir, if you permit me. There's something called is not post-auricular approach, endoral approach. Permeatal is an incision, not an approach.
Yes,
actually.
it is not an
endomeatal approach.
Endomeatal approach, that's, yeah. So we do have all these approaches, a lot of literature there. So we'll come to that approach later on. Graft materials, we have discussed a lot, I think, cartilage and fascia. What is your choice of graft material?
Temporalis fascia graft and conchal cartilage with perichondria, reinforcement.
Both the things you use?
Yes.
In the same patient?
Yes.
Okay.
Sir, I would use temporalis fascia graft, and I would use for the artic, put a cartilage for the artic defect there. Tracheal cartilage. I use tracheal cartilage.
Tracheal cartilage. Sir, your
I prefer conchal
choice?
Temporalis fascia to start with, and then if you need a cartilage, either from the tragus or from the conchal cartilage, whenever there is an attic reconstruction to be done.
Temporalis fascia and conchal cartilage.
Okay. Anyone else? Yeah. So island, you want to make an island of cartilage with extra perichondrium around. That is, so we have done a thesis there with island cartilage. Anyone else? Yeah, you were saying something?
The same set, like temporalis fascia graft along with the conchal cartilage.
Yeah, he told
the same.
Yeah.
We can get the more perichondrium also. With the
if you would have listened to Dr. Meghnath, he was using both the things. Then he said, with the perichondrium, the healing is delayed. and the granulations are there. He told this out of his experience of last 22 years. He told us. So there are opinions that do differ. Anyone? So if residents or a junior consultant can say, why temporalis fascia? Available there, ample amount. In revisions you can use it. What else? BMR is too low. It doesn't get lost within 48 or 72 hours. Even in my TA philosophy, it stays there at the middle layer forever. Yeah. So, graft material, everyone agrees that you can either use a temporal fascia or an island sort of graft, or both the things. People use both the things together. Surgical technique, we have listened to Dr. Meghnath, underlay, overlay, your technique. We have talked about TAE also, a big subject. There have been comparisons. So how I followed your orders. I started with the post-oral. Okay, I have already exposed the external acoustic canal. I am elevating the posterior flap. Please correct me anywhere if I am wrong. My instruments are going wrong or anything which you find there. So could you see that retraction pocket there? So I'm drilling a bit of the medial part of the posterior canals so that inside out I can make out and I can reach to the fundus of this retraction pocket and try to do that. Is it okay the way I'm drilling? Yeah, I'm
You are a left-handed surgeon, I guess.
Yeah. Oh, good observation. So I'm a left-hander, but I can use scissors by both hands.
At one point of time, actually, your diamond drill actually dipped into the...
Yes. This is what, look, I'll hold it there. Oh, why it is going back?
And number one, you...
Yeah.
Sir,
These things I wanted to...
Yeah.
So I would elevate the flap.
So one important point to learn. My diamond drill, it dipped inside at one place. This should not be done. Your direction should be from inside out like this. Your drill should not be drilling on a point for more than 2 or 3 seconds. It should always be moving a bit so that you don't insert it or make a hole there. And it should be like upside down or downside up or maybe inside out like this. Okay.
And number 2, you haven't given any lateral circumferential incision. Number 3 is like, I don't see a proper 360-degree anterior view, and the anterior canal wall is actually
It was intact. If you remember that picture, it was intact. Yeah. That's why I kept it anteriorly. I saved it.
And this, the mastoid detector, the plexus mastoid detector, what you have used, should be only in the cartilaginous portion and not into the bone. It's slightly going on to the bone. Over here.
Okay. Just to retract it efficiently. So what I'm using it, you know, what thing I'm using there?
The carrier sheet here.
Yes. So it's a sutures upper covering, that covering which comes. I always do this. So to protect my flap from my drill. This is what I do always. Okay. Any other observation?
So I would elevate the flap more superiorly and place it more anteriorly.
Yeah.
So I get good view of the head of the malleus.
Anterior also.
Yes,
Okay.
yes. So I can know the artic defect there.
Sir.
What I conventionally do is I give an incision outside at the 12 o'clock, make an incision 3 or 5 millimeters lateral to the annulus, elevate a flap. That flap will come onto that when you retract. Then you will have a 360-degree view of the tympanic membrane.
In that case, sir, my philosophy is I want to keep the flap intact so that the vascularity keeps intact. So I don't give a radial incision ever in these mastoid cases.
What I observe is the students will have a difficulty in keeping the graft when the skin is there attached to the posterior.
That is the later thing. I'll show you later. But initially, I just elevate the whole thing. I don't make a radial incision anywhere. So that I can use this skin to drape the cavity for epitheliation. So I have to save each and every bit of this external acoustic canal skin so that it will be covering most of my mastoid cavity so that rapid epitheliation would be there. This is my philosophy. That's why I don't make a cut there. Later on I'll make it, you will see that.
This is like Yugo fish versus non-Yugo fish technique.
Versus non-Yugo, yes.
Sometimes the skin may get involved in the drill and get torn also.
Yeah, that's
So
why
then you'll have a granulation in the
yeah.
post-operative period.
I think fast we can. So now, after drilling this area, you can see something there. Still, you will be like, now I was a bit skeptical. Should I proceed further with this inside out? So I put in my drill on one side, use the ball probe. That is a safer instrument to use. Once I was using that pick, that should not be done. I was making a cross with it. Look, I'm using this pick there to elevate the things. I've drilled till if you can make out, it is almost segment has come there.
No, facial now.
Yeah, that is the facial now. Yes. Who said that? Oh, you can make out. Look. It's decent. Only a small plate of bone is there on the facial. So this. I should not have used this pick. You use this ball probe to remove the pathology from there. But still, is it a good technique to insert your probe and then do a blind thing? Not done. So deliberately I was doing to show this. And this is how we make mistakes. And we insert it. Sometimes your dura is very low. You can poke it in dura. And if you see now, looks like there is no disease. But if you move the patient further back, you will see something there. So I had to drill it again. I was not fully confident I have removed the disease or not. Once you drill, now you see something there. Can you see that white flake coming? So I would have made a mistake. Yes, that's why, ma'am, I asked all of them
why were you
after
poking
CT.
and drilling in that narrow space? Because already the CT scan was showing the pathology in the adductor sacrum and
Sir was doing it for the
Ma'am,
panel, ma'am.
the mistake all my panelists made, I did.
No, because if
I didn't read the CT well.
If we didn't have the CT scan, then I can
The CT
understand
was
that
showing
you-
extensive disease, which
that's
is
what.
eroding the pre-sinus plate.
Yes, sir. So then why were you trying to do that in the narrow places? What I didn't understand.
Because I made a mistake like them.
Because after the CT scan.
Yes, after the CT scan, they made a mistake like me.
See, one
we
thing.
were talking about post-auricular intact canal wall, okay? We would have gone through the McEwen's triangle.
I'll show you that.
Doing an inside-out technique.
Sir, I'm a proponent of inside out. Why? Because I just want to follow the disease, take out the disease, reconstruct the defect, and my job is done. Because there is another ventilation system which is working there in the mastoid, the mucosal ventilation system. These pathologies, retraction and cholecystium happens because your stricken tube is at fault. Whatever I do in mastoid, your stricken tube pathology remains there. So I would always try to preserve the mucosa in the mastoid ventilation system. That's why I don't drill from outside in, because while drilling, you also drill the medial wall somehow and remove that mucosa. And that ventilating mucosa is gone. So the philosophy is going inside out a bit, follow the disease, don't rupture the sac, and then take out the sac and your mucosa is intact there.
So it is all right to, in my opinion, it's all right to do inside out because it depends on what we are comfortable with. But what I felt in the technique which you were showing is that you have to drill the scutum and expose the fundus of the disease before you try poking and trying to take out
Yes,
pathology.
exactly. So that's why I have kept this video there.
See.
I have kept this particular video there and I deliberately did this so that they can point out and we can discuss and reach to a consensus. So the consensus is, she has pointed out, don't poke in any instrument blindly. You should, first thing, any instrument you use, you should be seeing the tip of your instrument.
Can I add one thing, sir?
Yeah.
See here, what I usually do is first elevate the tympanic metaflap, inspect the middle ear, keep some decongesting agent there, then come back and do your mastoidectomy, then go back into the middle ear. By the time you do your mastoidectomy, your middle ear will be decongested, number one.
Yeah. So very, very good take-home message. You can decongest. But I usually don't use any this thing, a cotton ball. I prefer to use the gel foam piece there. I've used in I use in a few cases. Otherwise, I don't use that because some fibers are left.
Is this one of your earlier videos when you were young?
No, sir.
Because actually when you are doing inside out, we tend to go behind, see the dome, and then come to the lateral part of the
But I did
pocket
only a
and then
small
come
job there.
anteriorly.
Yes, till attic. Sir, it was looking like a limited disease to me. My impression was a limited disease. With something preoccupied mind, you go and you do whatever your mind has thought of. So this is what I wanted to deliver there. Please read your radiology well. Think of the case, think of the approaches, and then. So, sorry. I think we go there. So I started doing enterostomy, cortical mastectomy there. So I'm showing it fast. And to my surprise, it was full of disease.
Same
inside.
case, same patient, huh?
Yeah. Same patient, sir. It is the same patient going on till last. You can see the disease everywhere. Yeah. Look, it's going in the dura was exposed. You will see that. One important point when you do an intact canal technique, thin the posterior canal wall to the most. It helps in two ways. You see the things inside very well, remove the disease, and the important thing is, even if recidivism is there, any residual or recurrent cholesteatoma there, this cholesteatoma is gonna break this thinned out wall. It wouldn't go here and there, like intracranially or on the sinus. It would come out in the canal. So that is one escape mechanism you have provided for any chances of recidivism there. So, and there have been a good paper by Thomas. He has reviewed his 604 cases about his inside-out technique, and if you read it, has got a good points there. And when you compare the endoscopic and microscopic sizes, a good paper has come from Lee. The recurrence risk was lesser than the microscopic approach in the endoscopic approach. Might be because you can see the nooks and corners with endoscope. So I think we can develop a practice after drilling in the intact canal. You can use the endoscope to see those corners. I think this is what, sir, you follow. Yeah, it was. But I'm talking about using an endoscope. So ultimately in this case, I could not clear the disease with the intact canal. I did a canal down. I started doing a canal down. The panel, what are your limits in canal down?
In my situation, in my practice, the only indication of canal wall down mastectomy is CA medulla. Most of the times, 99.99% of the time, what work you can do by canal wall down can be done by canal wall up also.
Okay.
Sir, in this case, I would remove the ridge and again do a soft wall reconstruction. In this case.
In this case.
Because it's a limited cholesteatoma.
It's not a limited.
I mean, we can reconstruct the wall. I don't think we require canal wall down in this.
Can you see only the labyrinthine block is intact, otherwise rest of the cells?
Yes, sir. I would remove the ridge, but I would do a soft wall reconstruction like Suri Prabhu sir does.
Venkat sir, your indications and limits of this canal down mastoid.
Canal wall down mastoid only in cases where there is extensive cholesteatoma involving the tip of mastoid.
Because they are having residual hearing is good, so I would not do a canal wall down.
So, do you think you can't restore hearing in canal down?
You can obviously do it.
We can.
It was around 45 decibel AB gap there.
But we would like to give a good ventilated ear if you have an intact canal wall.
There was a concept of difference in hearing gains in intact canal and canal down to a tune of maybe 15 decibel, if I'm not wrong.
Yes.
Does this concept stay back there in present era?
I would not say, sir, but I would like to give a ventilating ear. That is my...
You would like to give a
ventilated ear, because I believe in interiorization and exteriorization. If you are do a full job and remove everything, or do a soft wall reconstruction, and give a ventilated ear.
Sir, your?
When we operate, we want to see that the patient does not come back for a re-exploration.
Yes.
So our concept is a canal wall down, explore the tip, go down to the facial nerve as much as possible, explore the middle ear, anterior buttress, posterior buttress, till you see that the external aortic canal floor and the cavity floor are equal. Yeah. Because we operate in a public area, health area, where we don't have the time for the patient to come back also. Okay. So our concept is a canal wall down most of the time, because even now the literature says the intact canal wall still has a recurrence compared to a canal wall down.
Yes, it is there. It is there.
Sorry, I don't agree on that.
Reviews are there.
I really don't agree on that. See, if you do a proper canal wall up mastoidectomy, your results are the best. Yeah, it can be done by canal wall down also. It depends upon the surgeon and the situation given. But canal wall up also gives you the best of the best results.
I would love to see a publication from you. A
Sir,
large
there are-
sample size
There
publication.
are diseases where you see more granulation and where you suspect it can be tuberculosis.
Sampurna, I'll just
Yeah.
stop you there.
Yeah.
Can you see this thing?
You're going perpendicular to the facial.
Yeah.
Yeah.
Sir, this case, did you do only to show the what should not be done?
looks like
I think,
so wanted.
I'll tell you the reasons. Yes, tell me.
Okay, I wanted to comment on that.
Yeah. Yes.
For the panel, to moderate a panel and ask what is the defect, what is the defect. Yeah.
That's why I kept this case so that point out the mistakes and deliver a
Prepare
good
presentation.
message
Sir, prepared
to
video.
investors. Yeah.
That's why I wanted to interrupt you, sir, and just tell that what is it I'm seeing that this is the first
Yes.
time that
Tell
you're
me,
just
tell
drilling
me.
across the facial.
Tell me, man. So that's why I just wanted to deliver concepts to younger population there, younger ENT surgeons. If I would have kept an ideal case, I don't want to see that ideal case. I wanted because
Actually, I was having a sort of sympathy with you, thinking that maybe because left-handed, so you didn't have an option. So all these things were going on in my mind, that why is he doing this kind of a drilling? And
See, initially I pointed out whether it's the video when you're learning, not that point you missed, all of you. Is it one of your earlier
Sir,
videos when you're learning?
so Sampurna wanted to make a comment.
That's why I gave the lateral skull base talk on day 1 so that people don't suspect you.
Okay. Anyone else would like to?
Sir, I wanted to.
What
before
is your
drilling-
inferior limit in drilling? I wanted to have information about limits.
So floor of the external artery canal would be the limit.
One, yes. What else? Anything?
Inferior limit.
So he has pointed out the floor of the external acoustic canal should be flush with the floor of the mastoid cavity.
Yes.
As Dr. Morwani, you would have listened to his concepts. If your floor of mastoid is going far below
Obliterate.
your canal, obliterate it with bone dust or something like that, so that it becomes a draining mastoid cavity in the floor. Okay.
That is one. Number 2 is the dome of the semicircular canal, the facial ridge should be totally in line.
Okay.
That is one.
Now, in this scenario, you would have seen that facial is dehiscent in the horizontal part, and there is a bone chip which is lying on it. So it is covered with that. Incus is absent, stapes suprastructure is not there. What type of osteocloplasty you will do in this case?
TORP.
TORP?
TORP with
Which material?
Teflon.
Teflon.
I would do a cartilage, tracheal cartilage.
Tracheal cartilage?
L-shaped cartilage.
L-shaped cartilage.
Like meningostreptopexy.
Which shape?
Shape. L shape only, sir.
L shape.
Yes.
So one torp Teflon, two L-shaped cartilage.
I would make a small opener.
Boomerang.
Boomerang.
So he comes with boomerang technique of Dr. Satish Jain and Teflon.
Depending upon availability, if Teflon is not available, then boomerang L-shape.
In more than 500 cases of my series of osteoplasty with using torp made of Teflon, at least 15% I have seen extrusions.
With cartilage?
With the Teflon.
With the cartilage
With the
placement
Teflon,
over it?
15%. Teflon, with Teflon.
Did you keep cartilage over the prosthesis?
Oh, that is
Yes?
a must. That
Yes.
is a must to keep a cartilage over the.
Okay.
But if you compare it with titanium,
Yes.
the extrusion rates falls to 0.5%.
Correct.
So Teflon is not my choice. Titanium you can use. Any other method of reconstruction?
Yeah, one method.
Okay. But why to make an incision there in the septum, ma'am? You do have ample of cartilage there.
Homocartilage.
Okay, homographs. Okay. Yeah, Vijendra's.
We can use even a grommet.
You can use grommet.
Do you take consent of the patient that you are keeping somebody else's cartilage?
No.
The prion disease, have you ever heard of prion diseases?
What will you do if he refuses?
They will sue in the court. Out of 1,000 if one happens. So that is, and I, okay. Any other material? So I just wanted to make out, like Teflon, we have discussed.
Septal cartilage.
From the floor of the external acoustic canal cartilage, that is a thicker one. That's what I'm using there. Yeah, that's what I'm using there.
Yeah.
So L cartilage, they are saying with the concept of L1, the vertical strut, and then it is making a surface so that an aerial ratio can be matched. You are matching aerial ratio with this horizontal part of the L, and the vertical is going on the foot plate.
Yes, sir.
And boomerang, you are taking a big one, boomerang. But the problem with boomerang, sir, the contact angle with the foot plate.
Yes, sir.
Even if your boomerang is coming like this, you have made a partial cut, it somehow falls like round one.
Okay.
So the
hearing results.
The way out is take a long strip of cartilage from the eustachian tube to the attic, and then put another piece of cartilage on the
that can be done.
foot plate or the suprastructure.
Okay.
Can I add something?
Yeah.
When you think about ossicular reconstruction, there are three things which are to be kept in mind. Number one is mass effect. Number two is angulation. Number three is center of gravity. These three may not be achieved if you don't carve the boomerang-shaped cartilage or so. But this torp will give you actually the exact center of gravity, provided you support inferiorly by a little bit of a gel foam which gets fibrous at a later date.
So it was 50 microgram weight limit. It
Correct.
should not be on the foot plate. You can't put a weight more than 50 microgram.
Correct.
First thing is that. Second important thing is to give an space, middle ear space. Third is giving an aerial ratio. Your tympanic membrane being in a 90 mm to 3.2 mm of the foot plate, the aerial ratio comes to be 20 to 1 somewhere. If you would have read of that. 2/3 is like vibratory. So it turns out to be effective aerial ratio 14:1. So the thing is, you should have something like a larger one surface area laterally and the smaller surface area medially. So what I do, and I've published it in IGLO, we use a vertical strut. I make a wedge out of the cartilage, which has got a larger surface area laterally and a pointing area on the foot plate. And this is what I keep, and I put gel foams all around, and it should overshoot the annulus area so that it gives a good middle space. And I've published, you can see that on IGLO, vertical strut IGLO. At the floor of the external acoustic canal cartilage. So I'm making yeah.
I have one question for you in the end.
Sir. No, please, come on.
No, we have not come to the end.
Oh, okay. And the end, sir. You can use that, ma'am. You can use that. But how many of you do not do any ossicular reconstruction with the facial dehiscence? Facial dehiscence.
Even if there is facial dehiscence, you can still go with ossicular reconstruction. Nothing would happen.
Yes. So don't get afraid of doing a ossicular.
No, I recently burnt my hand. I thought I have placed it very nicely, the cartilage. There was a dehiscence in the horizontal part, and day one palsy happened, so again I had to take it out. And when I was very confident, and I asked my juniors, we placed it nicely, how can it, it is not the reason, is there some other reason? But after the opening, I saw somehow it got exactly stuck
That
there.
I'll tell you why. If you, after reposing the tympanometer flap, if you keep the gel foam too much and press the graft medially, that might have caused
It will
pressure.
cause at that moment.
Maybe I didn't think I did anything such pushing normal how I did, but it can happen. Even with best person, very confident, still it can happen. I'm not saying don't do, but if you see that this kind of case, any policy happened, immediately open and remove the cartilage and it improved.
Yeah, Vinod sir.
Because I had this case, like when I started my post-PG period, similar experience, cartilage fell on the facial nerve, but I didn't do anything. I just waited, steroids, it resolved. So I don't. So.
Sir, were you working in
Sir, you
corporate
make
or
hole in IC and say small bleeding. You can do that. For us, special policy on next day means our palpitation will come. So I had to open and see. And I actually saw it was pushing there because there was a nerve.
But the facial sheet is so tense. I'm telling you, it doesn't give way with the cartilage.
See, when you have a facial dehiscence, it's better to keep gel foam soaked in dexamethasone in the middle ear. That's the best way.
So this is how the vertical stud we put in there. We're using the gel foams inside. I've made it fast, twice or 4 times. It's going fast. This video has been going fast. It is not a normal speed. It has been going fast to make it, to cut short the time. So this is the vertical strut we use. And the curve should be like on the facial like this. It should be a bit of concavity towards facial so that it doesn't hit that. I'm moving that concavity towards facial there. And yeah. So it is it's obviously like columella, the single ossicle there in birds.
Long columella.
So we are on the concept of type 3.
Because it fits very well into the foot plate. That is the advantage of the long columella.
And the larger surface over that remains in touch with the timbering membrane and then it gives up. So this is how we do. So there have been a lot of papers about myotoplasty techniques. Now comes with the myotoplasty. Any particular take-home message someone would like to?
Yeah. For this case, I would like to do a canal wall up anyway.
Okay.
If at all I had to do a canal wall down, as Sripati said, I would like to immediately obliterate the cavity or reconstruct the posterior canal wall, soft tissue reconstruction. Now, when you obliterate the cavity, the requirement of the myotoplasty would be less. Okay. So exteriorization should be easy. So we don't do any wide myotoplasty or a narrow myotoplasty. There is something called as an adequate myotoplasty. So you
what
should
is
be
an adequate myotoplasty for you?
That's what I'm saying. So whenever you line the mastoid cavity, is lined in such a way that you don't see any bone around. All the soft tissues has to be covered by a facial layer. So the posterior superior extent of the facial graft or the tensor fascia lata or the temporalis fascia, you have to see the posterior superior limit like your synodural angle level. That would be the adequate myotoplasty.
I think that is a very good point. Don't go by the old victim, your little finger. Sampurna's finger does not match the finger of Sandeep. Got it? So you can't go by your little finger technique, what people used to do, like it should be adequate enough. Any other technique?
As large as possible, we
as
keep
large as possible.
No, keep excising until you reach the cartilage. Try remove some block of cartilage superiorly and suture the ends.
Because a patient do not want a disfiguring.
No, it won't disfigure, sir. Not you can remove the until you can go to the Simba conch at least.
Okay. You make some flaps out of epithelium, out of this skin.
So adequate enough not to miss any hidden areas or something.
Sir, your
so that
pearls of wisdom about myotoplasties?
Yeah.
Some cartilage.
So there are lot many types of myotoplasty. What we do is Siebenmann's myotoplasty, and we can suture the upper and lower flaps to the soft tissues so that again it doesn't get restenosed.
It is not working? Battery is over? Working now, yeah.
I think the concept of myotoplasty was earlier they wanted an open cavity for the elimination of the disease. So at that time, the concept probably was to have as wide a cavity as metoplasty so that they could inspect the cavity, because if there is a recurrence, they could visually see. Now with the advent of MRI, DWT technique, the real necessity of metoplasty, I don't know. And now that you are obliterating the cavity, and if you have done it perfectly well, then probably the metoplasty slowly should be going out of vogue. That's my impression. So what you have done is cutting the posterior auricular conchal cartilage, inverting it on both the sides.
It depends on what Dr. Anand said. I agree partially, but wherever it is required, especially in doing canal wall down, I think some amount of cartilage may be excised to have an adequate metoplasty for visualization through external aortic canal.
Actually, what I do is I make 5 flaps out of it. These are 2 flaps of your residual external acoustic canal skin. And when you elevate up there, you take a semilunar piece of the cartilage. I'll be taking like this. It would be shown. And then I make 2 cuts there in this medial edge of the remaining skin. And yeah.
This is
yes.
classical
So
Madhavya.
they are basically 5. Yeah. So there are 5 flaps created out of the skin. Yeah. And they are sutured and becomes a round metoplasty. So
And
this is what we have been following, just to show the juniors.
The concept is to epithelialize the cavity.
Yeah. So I go inside like this. I go with a knife, make a plane between the skin and the cartilage, and then excise the cartilage so that I'm left with this skin there, extra skin. Then I'll make 2 vertical cuts, and it becomes 3 flaps. Some more cartilage, yes, and even a bit of cartilage exposed can give you granulations. So it should be well covered.
What is the role of metoplasty?
These 2 cuts I make.
What is the role of metoplasty when you are obliterating the cavity?
Role of metoplasty, sir?
When you are obliterating
I don't obliterate, sir. In these cases where posterior fossa was open,
when you are not obliterating the cavity, then your metoplasty will become essential.
Yes.
Right?
So after suturing these, if you... Yeah, please. This is what I've done. I kept it last. The video has been cut 9 pieces. So I kept it last. So just to show the last step there to discuss in the last. So if you do this, you will see the resultant. Not always necessary. Dr. Morwani is against removal of any cartilage. I've heard him. You can elevate the skin and can take it round, but sometimes it falls short. We have seen that. But you know that appears a hump there when you see straight in the sitting position. It appears as a hump on the floor. Yeah, custom made. But taking out a sliver of cartilage won't make it's not harmful. Look at this, the round, these 5 flaps, they give you this round metoplasty. And it looks good, it's not bigger. So it wouldn't be disfiguring to the patient. Obliteration, I think we are left, 2 times we have got a bell ring. Thank you so much for, so sometimes, you know, what, I'll come to you, sir. We have been discussing about evidences, but there's ample of evidences there on the literature. You can't follow always a new study or the old studies. Go with your own wisdom. See your seniors, how they are working. Absorb something. If you want if you get a new idea, you can follow that. If you are getting good results, I think that is something. The motivation, sometimes it's you, sometimes it's someone else who will motivate you. Sir.
The title given was controversies and all. Suppose you have a patient who has got bilateral dry central perforations. Will you advise bilateral tympanoplasty at the same time?
I don't ever do that, sir.
And if not, why?
I do.
I do.
Sometimes I do.
Earlier it was told that it should not be done.
It's wrong.
Why? No. Earlier what you are told that if you do an exploratory tympanotomy also, there is a chance of sensorineural hearing loss.
Yes. Nothing like that.
So if you do a bilateral tympanoplasty, there is a technical possibility of patient losing hearing. Yeah, does an ophthalmologist do a cataract on both the sides at the same time? He won't. Why? Then in that case, why should we do a tympanoplasty on both the
I
sides?
do bilateral in cases of army unfit patients for tympanosclerotic plaques because
Yes.
that is a non-infective pathology.
And those who come from abroad, I did once a bilateral tympanoplasty in one sitting because he has no time, he has to go back.
Yeah.
So
to save the time,
I have done one
Army,
side
army,
post-oral
certain-
and one
see,
side
certain issue.
endoscopy.
Otherwise, if the patient is residing here, I never ever encourage bilateral tympanoplasty in one sitting
Yes.
because there is the remotest chance. Not only that, so see, doing any surgery in the body, the patient, will have a gap.
Yeah.
Multiple surgeries, multiple sites, anywhere.
They have-
A essential theoretical gap should be given at least 6 weeks' time. So that is a general principle, general surgical principle. You want to avoid that principle? Yes,
Sir,
you
very
can.
similarly, one
but
person going
provided
abroad.
you are
Surgical
highly
principle
confident,
is
you
that.
can go ahead. Suppose,
Any other point anyone wants to raise?
suppose in 1 year,
Okay.
I did
Jasuria ma'am.
once. Patient told
Okay. Thank you so much, the learned panelists. They have made it interesting. Thank you so much. I think, yeah, ma'am. It has always been controversial, ma'am. A few surgeons would say, hardly matters. Yes, Dr. Ramandeep, even with a steppies, he says that. My patient can fly. He says that. He says
see,
that.
for tympanoplasty, for
And what about the duration, sir? Any consensus over duration? 15 days, 4 weeks, 6 weeks, 12 weeks, 6 months? What is?
yes, generally more than 3 weeks' time they should give for a tympanoplasty, and definitely not for stapes. Stapes he has to be there for at least 6 weeks.
6
weeks.
months.
No, 6 months. 6 weeks minimum. 6 weeks
weeks.
minimum. Because any eustachian tubal block, sudden block can actually change the position of the piston, and also retraction.
Yes. And he will be coming for follow-ups again and again. Thank you so much. 1 week.
Too many wires. It was a beautiful interactive session. We thoroughly enjoyed listening to it. We'll start with the felicitation. May I request our moderator, Dr. Pavan Singhal, to felicitate our panelist, Dr. Anand Acharya. May I request our chairperson, Dr. Ranbir Singh, to felicitate Dr. Shripati Naidu. Chairperson. Ranbir Singh. Thank you, sir. May I request our chairperson of this session, Dr. Piyush Sarkar, to felicitate Dr. Satya Kiran. Thank you. May I request Dr. Anand Acharya to felicitate our chairperson, Dr. Ranbir Singh. And may I request Dr. Ashok Prithviraj to felicitate our chairperson, Mr. Piyush Sarkar. I extend my gratitude to all our chairpersons, moderator and panelists for the invaluable insight into the otology panel discussions. Delegates, here we come to an end to our 2 days Elevate ENT Summit 2024. And now I have an announcement to make. There are 120 certificates still remaining at our registration counter. Please collect it from our volunteers. We appreciate the invaluable insight from our speakers, the participants, and our guests, and the engagement of our audience. Your presence and contribution have made this event a success. As it's rightly said, success is a reflection of the collective spirit and effort of the team. May I request, thank you, sir. May I request our organizing team chairperson, Dr. Sampurna Ghosh, to please come on to the dais to felicitate the vibrant organizing team. May I call upon Dr. Neha Padia to please come on to the stage for the felicitation for the wonderful work you have done all through for this summit.
Is this mic on? Yeah. Neha, I'm really proud of Neha. She is my first fellow. She is expecting and she completely did the hard work like anybody else and my pillar since last 2-3 years. Thank you, Neha.
Next, Dr. Elena Khan. Please, round of applause to this team.
Work. Everybody asked me, how did you organize so well? These 3 girls, the girl power is the reason to organize so well. Relentless work they have done, sincerity to the maximum extent, and I love you all.
Next, I would like to call upon Dr. Aishwarya Mathur.
Aishwarya can't really describe how much you helped all of us. All the sleepless nights, they were more tense than me. How things will go. Big applause for Aishwarya. Oh, okay.
Now I request our chairperson to give a vote of thanks to our delegates.
This was really an overwhelming experience for me. I didn't imagine that this will come really so beautiful because of all of your blessings. All the faculties who came from different parts of India, Jaisurya ma'am, your blessings was there. You came from Colombo, Prepa sir, and Monica ma'am. All the national faculties gave such wonderful talk. We rarely see that audience is glued to chair in this way. Many big conferences we see that speakers are there and audience have only 10, 20 people are listening. But this is a conference, everyone was listening. Even outside when they have been eating, they have utilized the screen and listened to every lecture with equal importance. Neha, Aishwarya, Alina, wonderful work. I want to thank my secretary Farooq, who has also tackled everything very well. Dr. Ritika, Dr. Amulya, Manasa to volunteer in the hall and in the registration desk. Aishwarya Varma from Medicover marketing and branding team, Bhamsi for designing these beautiful gates and all the backdrops. I really want to thank the audiovisual team. You are the hero. Actually, you are the hero. The team from Manikanta, Dinesh, and Fayaz. How beautifully uninterrupted the show went, and without any lag, without any interruption. It will be impossible if there was any glitch here. I want to thank Satish sir, our group medical director, who helped me in this huge money transaction and taking into the logistic part, which I am a big zero, so I didn't have to take pressure on that part. Mr. Upendra Panda, who took out the stress from me to receive my foreign delegates from airport to bringing to hotel and everything. And I can't see Fayaz if you are here. Sir? In my car? 1 minute, sir. Okay. Fayaz, are you here? Anybody from T-Hub team, Fayaz, Vinay, for this beautiful venue and making it the way I dreamed of, how it should look out, that is because of them. The T-Hub staff and the brew and blends catering staff, if the food is not good, nobody will be happy. I guess the food was wonderful, everybody told me that. And now coming to the main supporting system, those are my sponsors. I'm telling you, everybody came forward without even asking that how much delegates will come, what we have to give. They just came because they love me. They said, you are doing something, we are with you. One by one, I want to thank all of them, starting from Bonds. Where is the Bonds team? Starting from Bonds, MI, everybody please raise your hand. Yeah. Where is Mr. Kiran from Solaris Division, Sun Pharma? Okay, you're there. Yeah, so they have been the biggest support. The Sun Pharma, other divisions, Cipla, they also helped tremendously, not only to get delegates, but in many other ways. I used to take their advice also. Tell me how to do this. I'm doing this for first time. So I used to show all my vulnerabilities in front of them. Still, they didn't lose trust on me. Where is Rakesh from Resmed? Ashok Das? My MC, Miss Jyoti? Yeah, thank you so much. You did wonderful job. Mr. Rajiv Duggal from Opto, who came from Rajasthan and personally was in the stall like a guardian for me. And Santosh Surgical, Jitendra, are you there? Santosh Surgical team outside. Okay, they are still busy in the business. I think they made the maximum business out of this. Teja from Tevas, whom I know because of other contact from Cochlea, but now he has moved, but he's a friend of mine and supported in a wonderful way. Suman from CuroCare, are you here? CuroCare team, yeah. And Jayabardhan from JICE. JICE normally don't put stalls in such conference, but again, because of my friendship, CuroCare has supported us and put a stall here. Last but not the least, to mention the Storage, Rakesh and Naveen from Medtronics, to give me the support for cadaver dissection. All instruments and beautiful camera was provided by them. Medtronics gave their IPC, skull base bars, whatever I asked for. And of course, during my surgery also, whatever I needed, all these instrument people, they gave me full support. So without you, this conference wouldn't have been possible at all. Once again, thank you all. And with this, we end the conference, which will be a memorable event for all of us. Thank you all.
Hip hip. Hip hip.